Let us invite our first speaker for the session, Professor Oladapo Ashiru from Nigeria.
I will talk about the environmental toxins in Nigeria, which is the same everywhere. I will talk about what we refer to as endocrine disrupting chemicals and their effects on reproductive health. And then how we've been able to minimize the effect of these endocrine disrupting chemicals with modern male type of medicine. And then I will conclude. Environmental toxins exist everywhere globally. And as I said, United Nations, FIGO, IFSS, all the fertility organizations have now become aware of the fact that these toxins are critical for the health hazard of the population. What are the environmental toxins? Environmental toxins are chemicals or compounds or elements that exist in the air, in water, in food, the soil, dust, or other environmental media, such as consumer products. In fact, that is the more frightening thing. The plastic containers we use to drink water, some of them, the food containers, the canned food, a lot of them, and I will show you some of them. And also in human samples, such as urine, blood, serum, breast milk, and meconium. They contain more than 300 environmental chemicals. This was reported in 2021 by the U.S. Center for Disease Control. There has been a lot of reports on this. The Integrated Medicine and Clinicians Journal reported on the effect of environmental toxins on infertility and showed that the effect occurs in both male and female. In females with unexplained infertility, and in male have been shown to be linked to sperm abnormality. Also, the Journals of Agriculture and Environmental Medicine talked about the impact of heavy metals on female reproductive system. These heavy metals include mercury, lead, arsenic, antimony, and so on and so forth. And lastly, we also know now that there is toxic cyanobacteria in water and in the air. So we are endangered species by what we drink, what we put in our mouth, what we breathe, and what we even put on our body as cosmetics. The factors responsible for reproductive health issues, aging, and disease. Let me highlight them. Fish, large fish, you think you like them, but the American Society for Reproductive Medicine and FIGO, they issued a committee opinion that if you want to have a baby, you have to stay away from large fish, stockfish, because they contain mercury and lead. And these have been found to be toxic to the reproductive system and can affect the baby. It can prevent implantation. Well, I talk about what we call pastries, wheat, and gluten. Unfortunately, 90% of Africans are lactose intolerant. We cannot take lactose, but because it's important to us, we take it. Whereas in Africa, we have milk that are homegrown, like tiger nut milk, palm kernel milk, coconut milk, which we could be taking. But we insist in importing this other meat from the Western world. Unfortunately, only 5% of the Western world are lactose intolerant. So when we take these pastries, they affect us because polycystic, they impair all our various systems. Then let me quickly run to arsenic in rice, fruits. Sometimes they contain a lot of pathogens, especially if we don't clean them properly. And when you drive, you're supposed to wear a protective shoe because those lining of the car, as I alluded to yesterday, they contain antimony, and it's been shown to cause implantation failure. I had a typical example of a doctor who worked in my clinic. Did IVF, produced several embryos. We had about 14 embryos from her. We transferred 2 at a time, and she was always miscarrying. She would lose the pregnancy at about 7 weeks. The longest was about 8 weeks. And then I sent her to a detox center and finally found out that she needs to detoxify. We did the test, we found antimony in her. She said, well, she don't have, where did she get it? I asked her, how do you drive your car? She said she removes her shoes to drive. And I said, that is where you got the antimony from. We detox her, we remove the antimony by chelation, and she got pregnant easily. So there's a lot of this pollution in the air. And these are the various routes of exposure to environmental toxins. It's a lot of cross-border through trade, food, wind, water, and there are iniquities and injustice in how toxic chemicals move about in the world. Pesticides, they go from generation to generation. It will affect the mother, it will affect the baby, the pregnancy, and it will affect the fetus of that baby that will be born. So it goes through 3 generations. And I've listed here a couple of all the various exposures. Bisphenol, all the cosmetics we put in our body, they contain phthalates. Lipstick, a woman is supposed to use about 1 ton of lipstick in a year. So you should be careful what you put on you. You always look at the label of what you put on your body, cosmetics, because the manufacturers don't care what they are pushing out. So you look at it, make sure that it doesn't contain some of those things. Also phthalates, battery, like the cell phone has cobalt. And this cobalt, if you use the cell phone and you don't use the protective leather coverage, you'll be absorbing this cadmium and cobalt, and they are dangerous. So there's a lot in this system. In Nigeria and many of the oil-producing areas, we produce oil, and that affects a lot of our people. We have 2.5 million barrels per day, and it produces in the Niger Delta area, in this area shown in yellow. And I found out that my patients who came from this area, and this was my exposure to modern medicine, they produce eggs, and we make embryos, and we transfer them, and they don't get pregnant. And then we said, okay, maybe it's abnormality. We do PGT for them. We transfer euploid embryos, they don't get pregnant. And then we finally discovered that we can test their body system for toxins. And we found oil fossils and petrochemicals. We detox it from them, they get pregnant. So it is now being recommended by FIGO that preconception cleansing is an important factor. So you need to clean yourself if you want to get pregnant. You can see here, these are the various oil companies that produce in Nigeria. They expose the environment and they don't tell anybody. In Russia, in America, people who work in the oil producing industries, they go annually for detoxification to clean their body. But we don't do this in Africa. You can see the oil spillage that can occur. So it affects this. And these endocrine disruptor chemicals, they affect reproduction, and the mechanisms and the epigenetics is as shown. It goes from, as I said, the brain, the hypothalamus, the pineal gland, down to the thyroid gland, the adrenals, all the systems of the body are affected, including the ovary and the testes. Endocrine disrupting chemicals has the implication for human health, and this has been produced by Lancet, and it shows that these polybromide flame retardants, they have effect on various areas of the body, and it gives support for evidence for urgent attention to reduce the exposure to these chemicals. The effects range from physical to chemical and even biological forms, and many of these toxins are not at the level they are toxic enough to raise an acute presentation in the body. So, in fact, some of these toxins, like bisphenol, they can stay, and like things you use retardants in the car, in the upholstery, they can stay in the body for years, but they don't get eliminated. So it's accumulated before they now, after a long time, they unleash their danger to the people. So these are some of the problems, difficulties in conception, miscarriage, abnormalities in the babies. And as I said, persistence can go through generations. So various heavy metals are harmful chemicals, act as endocrine disrupting chemicals. They cause infertility in both sexes, and they cause a reduction in work output. Naturally occurring radioactive materials like radium encountered during oil exploration may also cause bone and other kinds of cancer. And this shows you the various exposures, the oral inhalation, interaction. At the end of the day, they can alter the hormone receptors, alter hormone synthesis, altered hormone action, alter signal transduction, and then destruction of molecular pathways and dysfunctional reproductive cells, leading to reproductive impairment. Those are the pathways. This was reported by Fisher in 2013. Fisher did his PhD with my supervision and published the effect of crude oil and showed that this crude oil in experimental animal has serious effects on testicular morphology and sperm motility, and also overall effect on the male fertility has been recognized. And these are the various mechanisms. For the sake of time, I will just show you that at the end of the day, this has been studied, and they bind to either the what we call the direct response element, the digoxin, or they go to the aerial pathways, and these are the various pathways in which they can have their effect. This was published in 2014 by research team. At the end of the day, the genetic environment and the epigenetics shows that environmental exposures can cause genetic and epigenetic pathways. There are 4 pathways recognized. The genetic pathways are path A and B, which end up with high or low susceptibility and high persistence. And then the epigenetics also have the epigenetic makeup and epigenetic changes. Overall effect affect the health of the population. Having realized this and having come across this, the next objective is how do I minimize this in business? And I'll use the last few minutes to talk about this.
Last 5 minutes, sir.
Yes. Media therapy helps to do this, and it helps to This was done by Franz Xaver Meyer. This guy was born in Austria in 1875, but he was a medical doctor, finished with honors, and it shows that Meyer detoxification refers to the different processes by which toxic substances are eliminated from the body, and thorough intestinal cleansing is achieved for a healthy digestive system. And we know that there's an emerging role for the gut in immunity, the immunity of the system. And also, we know that once you clean the body, this is the pathway which has been recognized for this emerging role of the gut as the immune system. This was published in Fertility and Sterility by some people working in China. And the major detoxification therapy would be relatively new approach to preventive medicine, has gained widespread acceptance in Europe among workers in high-risk industries. And Meyer therapy effectiveness is in driving costs of health services because it's more of preventive medicine. This was published how we manage environmental exposures by clinical exposure in Meyer therapy in global reproductive health, where we showed that that you can remove these metals by chelation, and we measured this process that we use in the urine of the 24-hour urine of the patient. We measured heavy metals in them at the Genova Toxicology Center in the United States and compared it. And we showed that the results show that our procedure is able to chelate metals. And as I've said, we did get positive results from the patient. So at MathLife, we do this bioenergetic testing to measure the product. And then we also are able to apply these following common therapies: aposicator saline oxygenation. Chelating components include electrolysis, body detox, chlorella, selenium, cilantro, calcium bentonite, and lymphatic drainage. And these are some of the tools, equipment that I use to do this type of therapy. And this infrared tapping, hydrotherapy. And we now know that there is possible role for Meyer therapy for removal of nutritional toxins, removal of heavy metals, improvement of mitochondrial quality, and total body detoxification, antioxidant therapy, automolecular supplementation. So we now believe that it is a complete work of a team, health professional researchers, government agencies for implementation of industrial regulation so that they don't pollute the air, and advocacy groups to sensitize people to these environmental toxins so that they can be aware of it. I've sensitized this group today to some of these toxins and read about the level of whatever you want to put on your body, or you want to drink, or you want to eat. Even the drugs. Today, last week, we just found out that some prenatal vitamins have a lot of heavy metals in them, toxins in them. These are the centers that do this, and these are my presentations. We do this because in the words of Reproductive, I recognize no superiority in mankind other than goodness. I think I've spent 19 minutes. I don't know what time he has got, but I have spent 19 minutes according to my own time here. So thank you for listening to me. And there's a solution to everything. Enjoy your day. And if you need my contact, that's my number, but there's 234 behind it, before it. And this is our website, medicalcenter.com.
Very good morning to you all. At the outset, I would like to thank Merck Foundation, especially Dr. Rashad College, for the invitation. I am indeed honored to be in this meeting. This is the title of today's presentation. I've been asked to talk on this topic, the failed fertilization NART, the causes and prevention. This is my disclosure. I have no conflict of interest related to this topic. This is outline of my presentation. The next 20 minutes, 25 minutes, I'll take you through the causes of fertilization failure, then about physiology of oocyte activation, then how to diagnose fertilization failure in gametes, and then the mitigating approaches, how can we prevent, and some clinical evidences. The biggest disappointment early in the morning in IVF lab is when the fertilization rate is not as expected. And it is frustrating when there is total fertilization failure. It is frustrating not only for the team, not only for the embryologist or clinicians, it is frustrating also for the patients. It is well known that the fertilization failure is normally attributed to either sperm, oocyte, or embryos. But it's a challenging task for us to troubleshoot where exactly it went wrong when everything was fine previous day. The situation, insemination is done, the conventional insemination or IVF or ICSI, when everything was fine, optimum, above the level, but fertilization failure or total fertilization failure. That means you cannot predict fertilization failure even everything was fine. Yes, to some extent, you can predict fertilization failure in reality. For example, the situation, the quality of the gametes are not so good, the motility is not good, or oocytes are not, you think they are not mature enough, or done conventional IVF, or in ICSI, use non-motile sperm. Not sure about its viability. Our oocytes have several morphological abnormalities, or the skill of the embryologist is not validated. In this situation, you can expect kind of low fertilization. I'm sorry. So these are the terminologies. Low fertilization rate, that means when there is less than 1/3 of the oocytes are fertilized either by IVF or ICSI is called as low fertilization failure. The total fertilization failure, as the name suggests, there is absolutely no fertilization. So how common is the fertilization failure? The data, this is data from Dennis Sucker from Boston IVF, which shows that about 3 to 4% of the patients you experience total fertilization. If you look at the fertilization failure in IVF, it's about 4%, 4.3%, whereas in ICSI it is slightly lower, it's about 3.4%. So what is important is this fertilization failure is related to the number of oocytes you inject. For example, if you inject only one oocyte, one metaphase to oocyte, then the risk of experiencing fertilization failure is more than 37%. If you inject 2 oocytes, it is reduced to 11%. It is just a number. And if you inject more than 5 mature oocytes, then it is less than 1%. So you have more mature oocytes to inject, the risk is reduced substantially. So now let's look at what are the causes of fertilization failure in conventional IVF. I restrict myself only to the biological causes of fertilization failure. I don't talk about the lab because that itself is a separate topic. If you look at the causes of the fertilization failure post-conventional IVF, the studies have shown that about more than 50% of the oocytes attempted by or failed to show fertilization post-IVF did not have sperm inside the oocyte. No sperm head was seen in the ooplasm. That means it is related to the sperm-zona interface. The sperm, there's a defective binding, the defective penetration, or it could be due to sperm ejection. On the other hand, In case of ICSI, the fertilization failure is primarily attributed to the defective activation. In about 70% of the cases, the fertilization failure post-ICSI is due to the defective activation. Apart from that, there are several other causes like the defective sperm head decondensation, because sperm has to undergo decondensation once it enters the oocyte. The defective decondensation can also compromise the process of fertilization, and there are many other causes. Since the oocyte activation is an important cause, the failed oocyte activation is an important cause for the failed fertilization, I'll quickly take you through what actually happens during fertilization. It's a bit a complex picture, but what I want to tell you here is that the sperm, once it binds to the oocyte, once it penetrates the oolemma, the sperm has got a protein known as PLC zeta. The PLC zeta is an important protein, and what it does, once it gets inside the oocyte, it acts on the PIP2 and then divides the hydrolysis into DAG and inositol 3-phosphate or IP3. This inositol 3-phosphate goes and binds to the receptors of the endoplasmic reticulum. The endoplasmic reticulum is rich in calcium. So once it binds, this inositol 3-phosphate helps the endoplasmic reticulum to release the calcium to the ooplasm. So this calcium is a key molecule in fertilization. As you see here, the calcium is responsible for the release of the cortical reaction. It's also responsible for the resumption of the meiosis. Finally, you see extrusion of the second polar body. It's also responsible for the pronuclear formation. What I mean to say is that the calcium is a key molecule in fertilization process, and it happens within 10 to 30 minutes after sperm penetration to the oocyte. You will see a kind of calcium spikes known as oscillants start seeing in the ooplasm. And as you see here, this is measured in terms of amplitude, the amplitude and the frequency. The amplitude is about 2.25 micrometer, and the frequency starts appearing in about 10 to 30 minutes. It will go on for about 4 to 5 hours. So this pattern, the oscillation, is very important for normal fertilization. If you look at the literature, here I have two sets of data. These are the oocytes show normal fertilization. You can see a very nice pattern of the oscillation. Whereas in the other group, there is a low fertilization. This is completely distorted. You don't see any spikes. You don't see any oscillations. So that means it plays a key role. These days, IVF centers commonly use cryopreservation of the oocyte. We use in vitro maturation in certain clinical conditions. And it has been shown that these interventions in the lab can also influence this calcium oscillation pattern. As you see here, these are the oocytes. These are the in vivo mature, they are ovulated oocyte, a very nice pattern of calcium oscillation. Whereas these are the oocytes in vitro matured, GB oocyte, matured in vitro for about 24 hours. You can see that they have stretched for a long time. You don't see a very nice cluster like this. It is stretched over for a long time, and that can impair fertilization. And here another example is the vitrification. These are the mature oocyte, the frozen thawed. You can see again there is a difference in the pattern of calcium oscillation. And these are the in vitro matured oocyte, subsequently frozen thawed. Again, there is a distortion. It's extended for a long time. So what I mean to say is that this calcium oscillation plays a key role in fertilization process, and which is upregulated, controlled by the PLC zeta. So the question is that since we know that PLC zeta is an important molecule, can we use this PLC zeta as a diagnostic tool to test the fertilization failure? Yes, it can be done. It can be done by a simple immunofluorescence. You can do immunostaining with the PLC zeta antibody and see how many the spermatozoa are bound to PLC zeta. If there are less than 30% of the sperm shown positivity, that means the fertilization failure is attributed to the sperm factor. So there are other diagnostic tools such as MOAT, the mouse oocyte activation test, where you can inject the human sperm into a mouse oocyte and then look at the activation potential. If you see activation, more than 85% activation, that means it is not related to sperm. If you see only less than 20% of the activation, then that means the sperm it failed to induce activation in the oocytes. Similarly, there are other tests such as the calcium analysis. As I told you earlier, the calcium analysis is also an important diagnostic tool. You can do calcium analysis by injecting human sperm into the mouse oocyte, and then with a special microscopy, you can assess the calcium oscillation spike. And this is usually referred as the amplitude versus frequency. If it is less than 10, then it is sperm related. And if it is more than 10, it is related to the oocyte. So apart from PLC zeta, there are some other genes are also responsible for fertilization failure, such as, for example, specifically, if you see here, apart from PLC zeta, we have ACTL9, ACTL7A, SPATA16, DPY19L2. They are responsible for either phenotype changes in the sperm and eventually can affect the fertilization. We can't blame only sperm, even the oocytes, the genes which are the oocytes like V2, PATL2, TBB8, CDC20, these are also responsible for oocyte activation and eventually compromise the fertilization. So the question is from the clinical embryology perspective, how do we manage if you know that, okay, there is a problem? So how do we diagnose? This is algorithm a little bit complicated, but I'll try to make it simple. For example, if you see there's a PLC zeta mutation in spermatozoa, then you can consider ICSI followed by assisted oocyte activation. All right. So if you do mouse oocyte activation test, again, if you think that the sperm factor, yes, you can go with assisted oocyte activation. And if you still see fertilization failure after assisted oocyte activation, then it could be the combined factor. It could be due to sperm as well as oocyte factor. Then you have the option of going for donor oocyte, cell sperm, or donor sperm, and then use calcium ionophore activation. So these are the interventions used for fertilization failure. Assisted oocyte activation, as I stated earlier, it can be done either by mechanically, it can be done by electrically or chemically. But remember, all three methods are non-physiological, and the most preferred method for activation is chemical activation, where we use calcium ionophore post-insemination, post-ICSI. We expose oocytes to calcium ionophore for 10 to 15 minutes, thereby it can trigger the process of fertilization. And studies have shown that the calcium ionophore activation is quite useful. If you look at this, the meta-analysis, which has shown that they did it in about 9 studies, and they found that ICSI with assisted oocyte activation is associated with an increase in fertilization rate. But we should always remember that when we expose oocytes during assisted oocyte activation, we are exposing them to supra-physiological level of calcium, very high level of calcium. So always there's a concern about the safety of this on the oocytes and the progeny. And here they have shown that the study which looked at diploidy status of the embryo, which are derived from oocyte activation, they found that no significant impact on the birth weight and no significant changes in diploidy status of the blastocysts, which are exposed to calcium, ionophore during activation. Here is the blastocyst. These are the blastocysts, again, derived from assisted oocyte activation, and they're all euploid. So, but this alone is not sufficient. It's also important to look at the impact on the offspring. Studies, again, this is a systematic review and meta-analysis, which has shown that, if you look at about 22 studies, we show that the calcium ionophore did not increase the miscarriage rate, the congenital birth defects, and neonatal sex ratio in children. That means this is reassuring that this calcium ionophore activation is safe to use in clinical practice when there is a risk of fertilization failure. Is another study which looked at the birth defects in children who are produced by the embryos are derived from calcium ionophore activation. The study did not show any increase in the birth defect when the calcium ionophore activation was applied. So apart from this, what are the other interventions which can be used for fertilization failure? there is something known as early rescue ICSI. That means you do conventional IVF and look for the extrusion of the second polar body within 4 to 5 hours. And if you don't see extrusion of the polar body, then you can do ICSI. This is known as early rescue ICSI. But by doing that, there is always a risk of polyspermic fertilization. Sometimes there could be delay in the extrusion of the second polar body. So that means you are injecting another sperm, which can eventually lead to polyploid embryo. This can be, you can overcome with this problem with the late rescue ICSI. That means next day, you do PN, the fertilization check, and you don't see any fertilization post IVF, you can go with a rescue ICSI. You can do one more injection and see whether you can get embryo. The results are, there are conflicting results with this, but this can be done. But the only issue here is that the synchrony between the endometrium and the embryo is lost. You cannot transfer the embryo derived by late rescue ICSI to the embryo because there is a delay of 24 hours. There's an aging of the oocyte and the aging of the embryo. This you can overcome by freezing the embryo and try in a subsequent embryo transfer cycle. So the other intervention like the recombinant PLC, because we know that the PLC zeta is a key molecule, whether we can directly inject PLC zeta into the oocyte, yes, but so far people are not able to synthesize the PLC zeta molecule. And there is also a concern about the potential toxicity or the embryonic development. So far, we are not ready for this intervention. The other approach is using the piezo ICSI. The piezo ICSI is slightly different from conventional ICSI, where you see a pulse. We use the piezo pulse with this kind of needles. So the advantage with the piezo ICSI is that you don't really aspirate ooplasm. That means you are not disturbing the ooplasm. You are not aspirating. Otherwise, what happens in conventional ICSI, we aspirate about too much of ooplasm, which is not done usually in case of piezo ICSI. We deposit sperm in the ooplasm so that we can increase the fertilization rate. Studies have shown that this can increase the fertilization rate. This can reduce the degeneration rate, and this can also reduce the abnormal fertilization rate. So piezo ICSI is beneficial for patients who are about 38 years and have fragile oolema and has a higher risk of oocyte degeneration. So apart from this, what are the other possibilities where we can increase fertilization rate? We talk about the ejaculatory abstinence. The sperm has to stay in epididymis for a while. Although it can acquire fertilizing ability only if it stays in the epididymis for a few days. And it's also known that the prolonged abstinence is not good for spermatozoa. So now people are reconsidering the short ejaculatory abstinence. With the abstinence of 2 days, you can get about 85% of fertilization rate. And the more than 4 days of ejaculatory abstinence, it is significantly reduced. So if everything is fine, give a short ejaculatory abstinence so you can extract competent sperm, which can also increase fertilization and can give good quality embryo. This is our own study. We looked at the impact of ejaculatory abstinence and versus the quality of the sperm, and we found that there is no point in asking for the long ejaculatory abstinence. It can only increase the sperm number. It's also shown that the quality of the sperm, its functionality gets compromised with the prolonged ejaculatory abstinence. So if everything is fine, you can go with the short ejaculatory abstinence so that you can have better outcome. And these days, we are all fascinated with the ICSI, and the number of ICSI cycles have gone up significantly. And one of the non-medical reasons by the embryologist for doing ICSI is the fear of fertilization failure, because we are sure that we can attain fertilization by ICSI. That's why ICSI has become very popular. But studies have shown that the ICSI is not useful. It doesn't increase the cumulative birth rate in non-male factor infertility patient. When everything is fine, so give the option of conventional fertilization or conventional IVF so that you can have better quality embryo, since there is no difference in the pregnancy outcome between IVF and ICSI in non-male factor infertility patient. And this is our own data where we use the sibling oocytes. We divided them to 2 groups, and one group was fertilized by IVF, the other group was fertilized by ICSI. We looked at the fertilization rate. Yes, ICSI has increased the fertilization rate. And if you look at the top quality embryos on day 3, and day 5, they are comparable. So ICSI can only increase the fertilization rate, but if you look at the outcome, the embryo quality, they are comparable. That means if everything is fine, you can still go ahead with IVF. So to summarize my presentation, I would like to state that the fertilization failure by conventional IVF is primarily due to the sperm zona binding or penetration, where in case of ICSI, it is due to the oocyte activation deficiency. And we all understood that the calcium oscillation pattern play a key role. There should be the specific pattern of calcium oscillation should happen for better fertilization. There are diagnostic tools which can be applied to understand the reason cause behind the fertilization failure, but they are not easy. They're a bit complicated. You need to have the facility. But we know that the assisted oocyte activation by calcium ionophore can be safely applied if you have this kind of situation. But what is important is that though I have not touched the laboratory part, the lab factor plays a key role in fertilization and fertilization failure. So we have the gamete specific, the sperm specific or oocyte specific protocol in the lab. We should not follow very generic protocol. So it should be depending upon the quality of the sperm, quality of the oocyte. Accordingly, you can optimize your laboratory protocol so that you can overcome fertilization failure in the lab. So some of the data which I have shown have come from my PhD students, and I'm thankful to my colleagues who have contributed to this study. And thank you very much for your attention.
But an equally important factor would be the quality of the sperm that you inject. So if you have a good-looking sperm, but you're unable to determine the DNA content or the intactness of the DNA of that sperm, even if you inject it in a good oocyte, even if you activate it, it's not going to fertilize. So what is your view on testing for sperm DNA fragmentation in cases wherein previously they had problems with birth?
Yeah, thank you. It's a very good question. The first part of your question, which you asked me whether there are any impact of fertilization, right? Whether the sperm with the DNA damage can fertilize the oocyte. Yes, it can still fertilize the oocyte. It can still fertilize the oocyte. We can still get the embryo. And normally what happens during the pre-implantation development, the damage to some extent can be repaired by the oocyte. Oocyte has a fantastic repair system. But if the repair is not completed, then eventually it may compromise the implantation, or there will be implantation. If the damage still persists, that can lead to early miscarriage. But this is a rare possibility. And of course, understanding the DNA fragmentation in sperm is a very controversial topic. And so far, only the clinical evidence is that the high DNA fragmentation is associated with the increased risk of miscarriage in the partner. That's the only clinical evidence so far. But and many times the techniques are very conflicting. The complexity of the technique, sometimes the preparation of sperm to understand the DNA fragmentation, the technique itself can induce DNA fragmentation. So you don't know whether it has come from the sperm or the iatrogenic. It has happened during your preparation. Thank you very much.
Namaste and very warm welcome to my national and international friends and delegates. So today's my topic is declining ovarian reserve in a women with advancing age and measures for improving the fertility among them. So in next 30 minutes, I'm going to cover these top points. So ovarian age mapping, ovarian reserve, what, why, whom, and when to be tested for ovarian reserve. What is ORT, that is ovarian reserve test, and treatment of a low ovarian reserve. So by Richard Anderson, this I have taken from the history documents. So he has nicely shown in this graph diagram what will be the difference between the human oocyte availability in the difference between the animals and humans. So we can see the amount of follicles available in the reproductive period are very much less compared to the others. So considering the primary follicles available, so at intrauterine life, we are having 7 into 10 raised to 6 follicles. At birth, it will decline to 1 into 10 raised to 6. At the puberty, it is almost 3 lakhs. At premenopause, it is less than 1,000. And at menopause, nearly 0. So we can see here that there is a continuous follicular atresia going on throughout the life, from starting from the intrauterine life till the menopause. So the available number of follicles that are going to ovulate are only 300 to 400. So this might be the available follicles for the fertility career of a woman. So now you must have understood why there is an importance of detecting the low ovarian reserve, because if we have available of this much in a generalized population, if the women is having a low ovarian reserve, the quantity will be still less. So what is a ovarian reserve? So ovarian reserve is the number of oocytes within the ovaries which are going to form into the Graafian follicles, or the small antral follicles, or the follicles that are stimulated by FSH, or that can be rescued by FSH. So what we are trying to predict here are the natural fertility present for that age, then IVF outcome, and duration of fertility or age of menopause by predicting the ovarian reservation test. So why we should go for this ovarian reserve test? So age-related fertility potential in women decreases as age increases. It's already scientifically proven. But it starts around 30 years. It declines by 37 years and significantly more by 43 years. So practically speaking, the highest reproductive potential is available around 20 to 30 years. But is it declared that is it totally age dependent? No. In a newer obstetrics, we are finding more and more of a low ovarian reserve patients even in the younger age groups. So in whom we should do these tests? So starting point in decline in the ovarian reserve is totally unpredictable. So women with a very short cycles, women with the cycles ranging between 21 to 25 days and even below 21 days with a normal or scanty flow, women with the irregular cycles, especially in the women with the careeristic girls and women of new era who want to take the chance of highest fertility in their optimal zone. Women with a high risk poor ovarian reserve will have the option of fertility conservation if diagnosed early in a young age, and this can be vice versa. So can we predict poor ovarian reserve clinically? Yes, we can predict. Advanced age, as it is already scientifically proven that as age increases, the ovarian reserve is going to decrease. But the women with a short cycle length, irregular cycles, more cancelled cycles, or poor response on the ovarian induction or stimulation, and by doing the ORT test. So the key or pivotal star tests are the serum AMH and antral follicle count test. This I have quoted by Bologna criteria, and this has been already scientifically proven. So when we should test for ovarian reserve? Majority decline with age. Non-age related conditions are faster follicular atresia in a normal pool of follicles. Normal rate of atresia in abnormally small follicles. In such conditions, we should go for testing the ovarian reserve. So the high risk populations are the strong family history with a history of early menopause, age more than 35, previous ovarian surgeries, history of endometrioma, tuberculosis of pelvic inflammatory disease, genetic cause like 46X mosaicism, fragile X premature carriers, unilateral oophorectomy, chronic smokers, and history of chemoradiation cytotoxic drug use in a chronic conditions. In such conditions, we should go and provokingly do this ovarian reserve test. Need of ovarian reserve test, identify the high risk population, better IVF outcome, for the fertility conservation option in a young woman, especially in this careeristic era. Plan the pregnancy in an optimum zone. So predictive test based on the basic biology, that is age. Age is a surrogate, but it includes the quality. And FSH it is a indirect and it reflects feedback. Especially FSH, it is a cycle dependent test. So I will not very much recommend the test, but instead of that, AFC and AMH are independent of cycles, so they are the pivotal study test. Does ORT change ORN reserve test change approach to infertility treatment and conception? Yes, definitely. Because AMH is cycle independent, AFC is also cycle independent, and the higher live birth rates and are predictable with high AMH, but conversely, low live birth rates are associated with the higher FSH. So assessing oocyte quality, quantity, the correct dose and agent in the ovarian stimulation, and it helps the patient to make the appropriate informed choice. Now, second test is the AFC. AFC is antral follicle count. As you see in this image, this is the day 2 or day 2 to 3 antral follicle count. You can see the approximately 2 to 10 follicles. So more than 2 follicles are recruitable as they are sensitive to FSH. So we are practically seeing how many follicles we are having, out of which we can generate a mature follicles probably in this cycle. So automated 3D measurement of AFC software are also available to rule out the observer bias. Practical recommendation is it should be done on day 2nd to 4th of the cycle, and the TVS probe should be used 7 millihertz. Then AMH. So it is a glycoprotein produced by the granulosa cells of the pre-antral and small antral follicles. It's not cycle dependent. Normal levels varies from 2 to 6.8 nanogram per ml. Less than 1.8 and more than 4.8 should affect the live birth rate. Decline as age increases, less cycle to cycle variation, and live birth prediction is high with a normal AMH. Not affected by GnRH, and the cost in the Indian currency, it cost around 1,000 Indian rupees. So it's not that much costly here also. FSH, secreted by anterior pituitary, it increases the recruitment of the follicles and it causes the development of the follicles. Serum level measured should be measured on day 2 or day 3 of the cycle. Normal range is 1 to 9 international unit per liter. Cannot predict the hyperstimulation and requires estradiol measurement for better predictability. Intercycle variability is present, so it decreases the predictability of live births. Genetic markers are also available. Single nucleotide polymorphism for FSH, LH, estradiol, and AMH receptor genes, but it is expensive. So now we are practically speaking dependent on antral follicle count and AMH, and it will quite resolve the matter. So I'm just going to introduce you with the Bologna criteria. In the definition of poor ovarian reserve by Bologna criteria, at least 2 of the features should be present. Advanced maternal age, previous poor ovarian response with less than 3 oocyte retrieved after conventional stimulation and or abnormal stimulation, result. Ovarian reserve test, that is antral follicle count less than 7 or anti-Mullerian hormone on the lower side less than 1.1 nanogram per ml. In the absence of advanced maternal age or abnormal ORT, a patient can be defined as a poor ovarian reserve after 2 episodes of poor ovarian response following maximal stimulation. So I have just quoted the studies from where I have taken these references. One more criteria is there, that is a Poseidon criteria, which will rectify all the fallacies of Bologna criteria. So Poseidon group is patient-oriented strategy encompassing individualized oocyte number. So this is a new classification, introduces the better stratification of low prognostic patient and suggests 4 subgroup based on quantitative and qualitative parameters such as age, expected aneuploidy rate, ovarian reserve biomarkers like AFC and AMH, and ovarian response provided previous stimulation cycle has better performed. In addition, the Poseidon criteria also has introduced a few markers for measuring the success of ART. Number of oocyte needed for a specific patient to obtain at least a single euploid embryo for a transfer. Recently, there have been introduction of the online calculator to develop validated based on the predictive modeling using this criteria. So, for the Poseidon criteria, there are some strengths, weaknesses, opportunities, and threats. That is what for this Poseidon criteria. So, strength of this Poseidon criteria is inclusion of both quantitative and qualitative parameters as they have considered age as well as the ORT test in the selection criteria. Better stratification of the low prognostic patients, more homogeneous of the low prognostic women. Weaknesses are the lack of clinical validation, inter-operator variability. We can rectify this by using the computer-operated AFC counts. Variability in the AMH levels by using manual assays. So opportunities are the conduction of the studies and evaluation of the treatment modalities in the different groups. Recommendation the management according to the clinical prognosis, and ART calculator predicting the minimum number of oocyte to obtain at least one euploid blastocyst. Threats for the results by using this criteria: risk of reluctantness to use by clinicians as it is a new thing, poor recruitment of the patient due to the stricter criteria, and its cost effectiveness. So treatment protocol, this is a generalized protocol, but I am not very keen on using the higher doses. It is good for the IVF cycles, but even though the low AMH, that doesn't mean we should use always a higher doses. Even in the simpler cycles, even with a low doses of HMG also, we can retrieve 1 or 2 fruitful follicles. So the adjuvant treatment, just I want to discuss here. In adjuvant treatment, we can use growth hormone, which regulates the effect of FSH on granulosa cell through increasing the insulin-like growth factor 1. It regulates the follicular development, estrogen synthesis, and oocyte maturation. Light study also shown a good result with the poor responders. Meta-analysis showed growth hormone use improvises the live birth rate, but it will not improve the multiple oocyte retrieval. So the dose used here is the 4 international units subcutaneously from day 21, along with GnRH antagonist till HCG trigger. The dose can range from 4 to 12 international units subcutaneously. Second adjuvant is the LH. As we all know, the 2-cell theory, LH provides granulosa cell androgen precursor for estradiol production by FSH, resumption of meiosis and progesterone production. It showed a good result in a poor responders. Sorry. The role of androgen, this one more adjuvant, and nowadays it is some of boom with this androgen, role of androgen, acts on the metabolic precursor for the steroid production, helps as a ligand for androgen receptors, enhances the follicular recruitment, it increases insulin-like growth factor, eventually it increases the number of recruited follicles, estradiol levels, and it promotes DNA repair in the oocyte. Suppresses apoptosis, improved oocyte quality and better embryo cohort. Improves the mitochondrial function in the follicular cell and oocyte. So how this androgen is act? Dihydroepiandrosterone is essential substrate for the steroidogenesis. In the abnormal low DHEA, what happens is there is a lack of substrate for androstenedione production, testosterone, and estradiol. Eventually, there is a low recruitment of androstenedione and testosterone and estradiol. There is eventually a low recruitment of the follicles. That means your androgen follicle count will be eventually less if there is a lesser DHEA. So practically speaking, if we add DHEA in a low ovarian reserve, we might activate this flowchart in a reverse range and will get a more recruitment of the follicles. So as per Glacier et al., daily DHEA 25 milligram thrice a day or 75 milligram once a day for 30 to 120 days in 120 women showed with a low AMH have shown significant improvement in AMH levels. It improves the fertility rate, especially in the age lesser than 38. 23.6% pregnancy rate in IVF cycles. Improves the miscarriage rate. So DHA eventually improves the egg embryo quality and quantity both. Spontaneous pregnancy rate is high with DHA use. Pregnancy rate in IVF cycles is also improved. Culminative pregnancy rates are high if we use DHA as an adjunct along with the other treatment. Live birth rate is high, especially in the IVF cycles. So dose is 75 to 100 milligram per day, minimum for 30 to 120 days. Side effects are very minimal, just like acne, facial hair growth, and deepening of the voice. So take home message I want to give up after this 20-minute session. Treatment should not be denied on the basis of ovarian reserve test result, assuming that the advanced ovarian age of the women. AMH and AFC alone or combined are the better predictor of ovarian reserve. Good predictor of response to ovulation induction, poor or excess. Better opportunity in unexplained infertility for intensive treatment. So identification, detection of a high-risk population of a low ovarian reserve changes the approach to the treatment. Adjunct therapy, especially in IVF cycles, improve the pregnancy rate. The adjunct treatment available is transdermal testosterone, DHEA, LH addition, and growth hormone. Donor egg should be always kept as a last resort. Thank you very much.
Thank you, doctor, for a good presentation.
Thank you.
My question is, you highlighted the role of DHEA in improving ovarian reserve. The first question is that, is there a role to do testing after you highlighted that up to 120 days of treatment? And then the follow-up to that is this a transient or how much time do you have? Because you find patients that are young and you waking them up and you find that they have how can you counsel these patients to say, do you have this much time or what does it mean? Is it a transient reaction to the treatment? And if it's a transient reaction, then how do you counsel these patients? Are these patients that you counsel for cryopreservation based on if there is some significant response? Thank you.
Nice question. Thank you. I've told there the dose should be 75 to 100 milligram per day, and the minimum time should be 30 days to 120 days. And obviously, this is my personal experience. Whenever there is a low ovarian reserve, we just should not stick to the laboratory amount of AMH. Simultaneously, we have to see LH and FSH also. If those are not in the normal range, definitely these women are going to respond well with the DHEA. This is my personal experience. And the oocyte retrieval will be good compared to the non-users. And We should not use for just to prescribe the DHA for 1 month or 3 months and then try for a ovulation induction. It should go on simultaneously because they will correct all the I have shown in the flow chart. They will correct in the reverse way. So the oocyte retrieval will be comparatively good when you start DHA and simultaneously start the ovulation induction also. And yes, cryopreservation is the option, especially in the young girls who are not planning the pregnancy presently because of their career or their other priorities. It's the option available, though I say that in the cryopreservation option also, we should give DHA to get more and more follicles for retrieval. Thank you.
So thank you very much, organizers. And indeed, it's a pleasure and privilege to share this stage with all of you. So this is this institution where we are standing, and I am working here very passionately. So a little bit about the epidemiology of the disease in endometrial cancer. So it is a highly prevalent cancer, and we are seeing that the incidence has been increasing, and it is a significant problem globally as well as in India. Then this cartoon is showing the incidence and mortality rates, and we are seeing that it's the 15th most common cancer, and it is responsible for 1% of the cancer-related deaths globally. So again, a very, very, very important, cancer. There is rise in endometrial cancer mortality rates due to several reasons. It is beyond the scope of today's talk, so I will not go into the details here. And then I'll discuss certain biomarkers like microsatellite instability and mismatch repair deficiency, because in these situations, immunotherapeutic drugs works better in these cancers. So what are the DNA repair mechanisms? We know that the DNA damage can occur from several sources, and these defects may serve as a therapeutic targets in some of the cancers. So this slide is showing the DNA damaging agents and how the DNA damage occurs. There are several mechanisms, and what are the DNA repair mechanisms, and when they are defective, what happens? And in these situations, the defective DNA damage repair is a characteristic of certain cancers, which allows tumor cells to proliferate and acquire mutations. So these defects can be targeted as a therapeutic target in some of the cancers like endometrial. Then microsatellite instability and mismatch repair deficiency are the measures for the same biological phenomena, that is hypermutability. And DNA polymerase attempts to correct through proofreading, but some errors escape and they are corrected through the MMR systems. So there are certain mismatch repair proteins, and loss of function of these proteins leads to an unstable and or deficient phenotype and a hallmark of MSI. This loss of function can be somatic or germline, that is as seen in Lynch syndrome, and tumors showing the presence of MSI are classified as MSI high, depending on the extent of instability in the markers tested, whereas tumors without the characteristics are classified as MSI stable. So this is one of the very important marker, and it is found in several tumors across, and in these kind of tumors, immunotherapeutics works better. So this is the MSI high or DMR occurs in many cancer types with varying frequency, and we can see in this slide that endometrial cancer is one of the tumor wherein there is a very high incidence of MSI high or DMR. So this is the MSI high or DMR frequency in endometrial cancers, and endometrial cancers can be classified by TCGA database-based genomic profiling into 4 subtypes. That's a pole hypermutated, MSI hypermutated, copy number low, and copy number high. That is Cirrus-like. And these are having a prognostic correlation. So these are very, very important. And we can see here in this slide that pole ultramutated tumors are having high mutation burden, 232 mutation per megabase. So they are the target for immunotherapeutics. So this subclassification of endometrial cancer is extremely important in today's era, wherein the immunotherapeutics are having their role to play. So what is the rationale for immunotherapy in MSI high cancers? So the rationale for targeting MSI high tumors with immunotherapy lies with neoantigens and no mutational load. So MSI high or DMMR cancers are predicted to have very large number of mutation associated new antigens that may be recognized by the immune system, and increased prevalence of tumor infiltrating lymphocytes in MSI high or DMMR tumors suggests an ongoing anti-tumor immune response. Rationale for targeting MSI high tumors with immunotherapy is in inflammation and the tumor microenvironment also. And MSI high tumors can have upregulated immunologic checkpoint molecules like PD-1, PD-L1, and tumors and infiltrating immune cells. So the scientific rationale for immune checkpoint blockade and MSI high or DMMR tumors is that MSI high tumors are characterized by 10 to 50 times more tumor-specific neoantigens than the stable tumors. There is high level of TILs and an active Th1 CTR environment and high expression of checkpoint molecules. So the tumor mutational burden and the rationale for immunotherapy in TMB high cancers. So mutagenesis produces novel peptides for neoantigen presentation, and mutations or viral infection can lead to neoantigen presentation that activate the host immune response. There are varied TMB definitions, the tumor mutational burden, but essentially it is a marker of how many new antigens are there, and generally wherein the tumor mutational burden is high, the tumor is considered as immune hot and the immunotherapy works better. TMB is correlated with the neoantigen load of a given tumor. That is the most simplistic way we can define. And immune checkpoint inhibitors that target PD-1, PD-L1, and CTLA-4 reactivate anti-tumor cytotoxic activity of T cells. So immune checkpoint inhibitors essentially target these checkpoints like PD-1, PD-L1, or CTLA-4, which are kind of break to immune system. So in normal condition, these breaks are on. So there is negative regulatory signals which suppress T cell activity. And when we give immune checkpoint inhibitors, these checkpoints get inhibited. So this negative regulation stops. It's kind of releasing the brake in a car, if I take that analogy. So while the brake is released and accelerator is on, the immune system can provoke and take over and can eradicate the tumor cell. That is the essential mechanism of these immune checkpoint inhibitors. So tumors with high mutational burden may be more responsive to immune checkpoint inhibitors, and tumor cells with high TMB may have high neoantigen load, which stimulate immune surveillance, that is increased T cell reactivity. And I see and immune checkpoint inhibitors can also help reactivate local immune suppression. In a retrospective analysis, it was found that TMB predicted response to anti-PD-L1 therapy, and there is a distinguishing between the responders and non-responders to anti-PD-L1 therapy. The TMB has shown a direct correlation. This cartoon was showing the TMB distribution and various across tumor spectrum. So we can see that endometrial cancers lie somewhere in between. So they are having a high tumor mutational burden. That's why there is a hypothesis, and there is a proven hypothesis that these tumors are more responsive to immunotherapy. So TMB is not in isolation, and there is a significant overlap of TMB with other biomarkers like MSI and PGL1. So we can see that that high tumor mutational burden captures most patients who are MSI high, and an expanded pool of patients who may benefit from immune checkpoint inhibitor therapy. So essentially, this TMB and MSI high are the most important biomarkers for predict responsiveness to immunotherapy. This is again showing to overlap of TMB with PD-L1 and MSI high, depends on the tumor type. And one of the studies shown that higher percentage of MSI high tumors were in endometrial cancers, around 17%, followed by gastric adenocarcinoma. And endometrial cancers are also among tumors with highest proportion of TMB high tumors, around 12.5%, behind melanoma and bladder cancer. So that's why, again, it becomes a very important target for immunotherapy. The MSI and TMB are highly correlated in endometrial carcinoma type 1 tumors, which is the predominant type. 80 to 85% of the time endometrial cancers of this type. And we can see here that MSI and TMB correlation in this table is shown very significant, while the PD-L1 correlation is not that strong. What is the mechanism? What is the basic mechanism of anti-PD-1 therapy, which are the immune checkpoint inhibitors? So PD-1 immune checkpoint is essentially a receptor, and with PD-1 binds to its ligand and prevent. Sorry, excuse me. So when we use immune checkpoint inhibitors against this PD-1, preventing PD-1 from binding its ligand relieves the inhibition of the immune system and restores T-cell anti-tumor immune activity, including T-cell proliferation and cytokine secretion, resulting in tumor cell lysis. So that is the basic mechanism. And PD-1 blocking monoclonal antibody, here it is shown that it is a potent and highly selective humanized monoclonal antibody that binds to PD-1 receptors. And I will again not go into the very detailed mechanism, but it releases the kind of negative immune regulation, and so that body's immunity can take over to target tumor cells. Targeting the immunosuppressive tumor microenvironment may improve efficacy of immune checkpoint inhibitors. So some patients with cancer do not respond to treatment with immune checkpoint inhibitors, while some are quite responsive. So here the tumor microenvironment functions, and we can, by various mechanisms, we can, kind of modulate this tumor microenvironment in the favor that tumor, again become more immunoresponsive. One of those mechanisms is normalization of the tumor vasculature, what we call as angiogenesis, and which improve immunotherapy efficacy and improve patient outcomes. So there is the basis for combining immunotherapeutics with tyrosine kinase inhibitors, which are essentially anti-angiogenic drugs like lenvatinib. So this drug is coming very important way for combination therapy. So I'm just giving a brief description. So this is the VEGF signaling effects on tumor vasculature and tumor microenvironment. It is a very, very important signaling pathway which leads to immunosuppressive state in tumor microenvironment. So targeting it is a very important rationale. And dalbetinib essential mechanism of action is inhibition of VEGFR, fibroblast growth factor receptor, and other other RTKs as well. So it's a pan-TKI inhibitor, pan-tyrosine kinase inhibitor. So it can normalize vasculature and block both VEGF and FGF and other tyrosine kinase pathways, and increase effectiveness of anti-angiogenic therapy, decrease drug resistance. That is the basic mechanism. So the anti-tumor effects of lenvatinib is to normalize the vasculature, shifts the tumor microenvironment from an immunosuppressive state to immune stimulatory state, and promotes differentiation and function of immune cells. Tumor, again, they are tumor cells are very smart cells, and they can adapt and escape from angiogenesis inhibition also. So there are multiple angiogenic pathways, and we need to understand those. And we also need to understand that, how angiogenesis inhibitors create a transient window of vessel normalization in which O2 delivery is improved, and high dose and long-term angiogenesis therapy increases immunosuppression owing to increased hypoxia from vessel pruning. And closure of this normalization window is indicated by immunosuppression in the tumor microenvironment and adaptive tumor resistance, which needs to be targeted. So the rationale for combination of anti-PD-1 therapy, that is immune checkpoint inhibitor, and lenvatinib, is essentially that VEGF signaling blockade by lenvatinib helps shift the tumor microenvironment from an immune suppressive to immune stimulatory state, which can complement the anti-tumor effect of anti-PD-1 therapy. And that's why there is a role of combination therapies in endometrial cancer. So this is the very mechanism in a cartoon. This cartoon is depicting the same immunosuppressive microenvironment. And when we are giving the combination, it is releasing that immunosuppressive environment and promoting immunoactive environment. So lenvatinib inhibits angiogenesis by the VEGF and other TK pathways, and anti-tumor activity is improved by combining therapies which are having complementary mechanism of actions like tyrosine kinase inhibitor and immune checkpoint inhibitors. So actually, these slides I am not. I have kind of they are not relevant. So actually, I hide those slides, but they are still showing because of this technical difficulties. I will just move in the interest of time and core topic. So we will move on to this slide. So rationale of combining anti-PD-1 with chemotherapy, that is also very important rationale. And combinatorial cancer immunotherapy strategies may be employed to maximize the success of immunotherapy in certain ways, like it stimulates immune responses directly, targeting immune effector cells, and indirectly by targeting immune suppressive cells. It also enhances the immunogenicity of the tumor by increasing its antigenicity and induce immunogenic cell death. Dying tumor cells emit a panel of damage-associated molecular patterns, which can activate innate and adaptive immune responses both. So now about the clinical practice guidelines about the endometrial cancer treatment. This was the rationale, the biological mechanisms, why combination, why monotherapy, etc. We all understood that. Now we'll move on to the what is this in the international guidelines. So this is the Society of Immunotherapy of Cancer, the SITC clinical practice guidelines on immunotherapy for the treatment of gynecological cancers, and the white panel from the world experts. And I was privileged to represent this institution as well as the country in these guidelines. And the expert panel recommendations suggest that for all patients with rare gynecological malignancies, clinical trial enrollment should be offered as feasible. And this is the most recent guideline of SITC in this kind of tumor. So again, the diagnostic workup essentially suggests that previously patients who are treated with endometrial cancer are in either pre-treated or in advanced stage, their MMR status should be tested. And depending upon whether they are DMMR, that is defective mismatch repair, or MSI high versus where they are MSI stable, there are different therapeutics like in PMMR, or that is proficient MMR, or MSI stable, pembrolizumab plus lenvatinib is indicated. In defective mismatch repair or MSI high, pembrolizumab monotherapy or dostarlimab monotherapy. These are the highlights from the NCCN clinical practice guidelines on oncology for endometrial cancer. And essentially, there are regimens in early stages and metastatic stages. I will only concentrate on immunotherapeutics where there is a role. So here there's a biomarker-directed systemic therapy for second-line treatment. So preferred regimen here in various guidelines is lenvatinib along with pembrolizumab. I have shown you the rationale to combine lenvatinib along with pembrolizumab for non-MSI high, non-MMR tumors, and or pembrolizumab for TMB high and MSI high tumors. And other recommended regimens are nivolumab, which is again a similar class of drugs, and dostarlimab for DMMR MSI high tumor. And then if there are NTRKG infusion, etc., then there are larotrectinib drugs, etc. also work. Avelumab for DMMR MSI tumor, which is another immunotherapy. So these are the level of or categories of evidence and consensus for NCCN guidelines. We are well aware about that, which is being used. And the SGO treatment guidelines for advanced or recurrent endometrial cancers, they suggest that the use of chemotherapy in treatment of advanced endometrial cancer improves patient outcomes, and chemo and radiation can be used, which is superior in comparison to single modality. And in women with gross residual disease, chemotherapy with taxane platinum can be used. And in advanced recurrent endometrial cancer, the ESGO-ASTRO guidelines suggest, the standard of care therapies. Again, this is not the interest of today's talk. So we will just move from here and we will go to advanced cancer, advanced recurrent endometrial cancer. Immune checkpoint inhibitors are recommended in the form of anti-PD-1 based immune therapy with pembrolizumab, which is considered in the second-line therapy of MSI or MMRD carcinomas, and the combination of pembro and the multi-tyrosine kinase inhibitor like lenvatinib is recommended. Clinical trial participants should be offered to all patients. So largely all world over guidelines, they essentially similar. I wanted to emphasize that whether it is NCCN or ASGO or SGO or SIDSI, they all suggest these kind of immunotherapeutics are having a role in second-line treatment. And this is the level of evidence, whereas and the rates of recommendation, which is practiced in these international guidelines. This is the JSGO guidelines. And again, nothing which is new. It is similar. And what is the clinical practice guidelines for MSI-MMR testing? So in uterine neoplasm, which is the interest of the topic today, the universal testing of endometrial carcinoma for MMR protein is recommended. And then based on this, the preferred regimen, as we see, is pembrolizumab. This is the ASMO guidelines. Again, in endometrial cancer, MSI testing is recommended for all sorts of cancers in endometrium. The same is in JSMO guidelines, which suggest that dMMR testing is recommended to screen for Lynch syndrome. Now, a very important word of caution, because we hear it is Africa or Asia. There are a lot of time there are challenges to access of these kind of therapies, and which is true for large part of the world, especially in the low middle income countries. So I would give an example of advanced melanoma. I begin my talk with that this is one of the poster child where an immunotherapeutics has shown a remarkable success and actually changed the epidemiology of the disease. So essentially, in advanced melanoma, either immunotherapy or targeted therapy, if it is a BRAF mutated, that is the standard of care therapy. But what happens in the real world? This is our own data from Tata Memorial Hospital, and this is largest in this part of the world because melanoma is considered rare in this part. So this is around 659 patients data, and it suggests real world scenario that only 10% of the eligible population could actually afford immunotherapy. Only 10%. When there are a handful of drugs which actually work in melanoma. If we are not able to give the standard of care, there are very less options which are available. This is an alarming situation. I want to give emphasis. These are the guidelines which I suggested, what are the mechanisms, why we should use, and there is good data to support that these drugs are really working. But this is the current scenario, and this is the real world scenario I would like to discuss. And this is another paper from our group, and it is essentially the Oncology Society of India, which I pioneered along with an interest group in the country, and all academic centers from the India, they are having a participation in this Immuno-Oncology Society. We are also part of World Immuno Council, and we have initiated a large study and more than 1,000 patients from India with wide oncologic indications. We have seen that there's limitation. The standard of care for immunotherapy in advanced cancer generally, long course, around 2 years, and enough, flat dose, so there's a high dose. But majority of our patients are not able to afford, but it's somewhere around 2 crores of Indian rupees for complete therapy. So majority of the patients, they receive a short abbreviated course, for example, 6 cycles, 8 cycles, etc. And with the caveat of being partly retrospective and partly prospective, this data, which is more than 1,000 patients, suggests that data is kind of comparable to the published data on standard of ICI therapy, which is like 2 years plus, of immunotherapy. And while we used only a short course therapy of a few cycles. So, so these are the challenges, and I will show these are the costs of the drugs in India, and there's a comparable cost in other low middle income countries. So the cost of these essential and at times in many indications this life-saving drugs is pretty high in spite of having a good patient assistance programs. Again, the cost of drugs is high. So there becomes the limitation, and these are the hardcore challenges, especially in low middle income countries. So we need to take very judicious decisions while we are sitting in the clinic, and patient who is sitting across to you, is the most important person, and we have to be precisely, making decisions. Essentially, it's enough precision care, precision not only in the based on the biology. Not only based on the newer therapies available, it's also depending on what kind of infrastructure availability, what is the implication with this patient, what is the social support system of this patient, and what are the wishes of this patient. So everything put together make a precise decision for that particular patient, essentially individualized, and that would serve the best in the given set of situation. To conclude here, in carcinoma endometrium advanced recurrent setting, the second line treatment essentially when there is proficient MMR or MSI stable recurrent CA endometrium, pembrolizumab plus envertinib is recommended. In TMB high or proficient MMR, CA endometrium, pembro plus envertinib, level of evidence 2. Anti-PD-1 monotherapy option is also there, level of evidence 3. DMMR, MSI high, advanced or recurrent CA endometrium who has progression following prior systemic therapy, and who are not candidate for curative surgery or radiation, pembro monotherapy, and who are DMMR, MSI high, recurrent CA endometrium who have progression post platinum and not a candidate for surgery or radiation, dostarlimab. All patients with CA endometrium clinical trial enrollment should be encouraged, and non-FDA approved ICI combination strategies are only in the context of clinical trial at present. Again, to emphasize, only 10% of the eligible population could afford standard of care therapy in low middle income countries. This needs utmost attention and global collaboration, and with more trial access is highly warranted. With this, I will end, and I'm acknowledging Immuno-Oncology Society of India, all the executive members, all the other members who are working to progress in this niche area. Tata Memorial Hospital where I work, and last but not the least, patients and families. Thank you very much.
Very intense session so far. A lot of detailed biological aspects. So I'll just take you in a bit of a different direction than you are used to, especially in the fertility aspect. A lot of talk about biological aspects, physiological aspects, receptors, immunology, and I just want to shift your attention to the mental health aspect for these various women that we are attending to. And just by example, like I just did, a lot of times our focus is on a lot of detailed scientific aspects, right? And we forget to take care of ourselves, our emotional, psychological aspect, and sometimes just a moment to breathe or consider the other side of something. So my outline is I'll just speak a bit about mental health in women in general, factors affecting mental health in women, what is depression. I know, you probably have an idea, but I still have to do it. For some reason, people in the medical field, even after learning about mental health and psychiatry and depression, somewhere along the way, I don't know where people throw it. So allow me to just do a refresher in that area as well this morning. What postpartum depression is, the risk factors, screening, postpartum blues, and management. And this morning we've been talking a lot around infertility, the different factors. And one thing that I've come to understand is there is a lot of stress around the presentation of infertility or different cancers in women. And unfortunately, a lot of focus tends to be, again, on the biological component of these women's presentation. Are we deliberate to look at the psychological and social aspect of these women as well? Their mental well-being, even as they go through these various presentations and challenges that they may be facing. So first, in general, women are more prone to mental health presentations compared to men. And this is due to various reasons. Of course, the hormonal aspect coming in, something that has been in detail discussed this morning. And this predisposes women to depression and anxiety disorders as well. And a lot of just the emotions and the social aspects that come with these presentations as well. And during pregnancy and after pregnancy, whether it's a special type of pregnancy or even just a normal pregnancy as well, there's still a lot of changes that these women go through biologically and even emotionally, right? And some of these emotional changes are due to the hormonal changes, but some of them is just social. Various social factors that could be contributing to their presentation, from cultural nuances to poor mental health or support during this journey. And sometimes even, especially for those who are going through the fertility assisted processes, you find that there are a lot of taboos, stigmas, even financial aspects to these presentations that can make the journey very stressful. Are we paying attention to that part of the presentation? So up to 85% of women experience some type of mood disturbance during the postpartum period, and that's normal. And I think maybe because of that, a lot of times women tend to be overlooked when they present moody during pregnancy or after delivery. But is it just moodiness? Is it just general hormonal changes? Or are we deliberate to look out for more in these presentations? Because there's still a significant number of women, about 10 to 15%, who actually experience some form of depression, actual clinical depression, but a lot of that is missed. And hence my presentation this morning, so that we can just remind ourselves the importance of screening for these mental health presentations, and specifically depression this morning. Even if it's right there standing in the face of a clinician, for some reason, we don't know why it is usually missed. And usually it will take several months before a woman is actually diagnosed with a clinical depression. And a lot of times it will miss various specialists until when they actually, for some reason, if someone around them realizes that, let them see a mental health specialist, then at that point, this depression will be diagnosed. And it's important that we talk about this because this doesn't only affect the woman, but it also affects the child, the development of this child and their behavior into adulthood. So we're looking at two lives that are affected by this presentation. So we want to emphasize the screening of these presentations, the treatment and management of these presentations, and if possible, even referral if need be. So I think I've spoken about that. So we want to be deliberate that even as women go through these various processes, are we deliberate to screen? How many of us, no, you don't need to give a show of hands, just a reflection. How many of us, even just in the last month, has been deliberate as we are attending to a woman who has presented with for antenatal or any fertility concern, taken time to screen their mental well-being, specifically depression today. Even just to ask one question in relation to that. Something that we've noticed in practice is that little is being asked about how they are actually feeling, what they're experiencing emotionally through this journey. A lot of the focus and information and guidance is actually around their biological presentation and challenge. If for some reason one is not able to give that detailed counseling or support within that session, how many of us have actually taken time to refer such a woman or couple for some form of counseling or social support? So these tend to cause a significant psychological distress and actually also affects the outcome that we're trying to achieve. Because it will definitely affect the hormonal balances. It will definitely affect various stress hormone levels, affect one's eating, sleep, and it just becomes a whole complex presentation. So what is depression? Yes, we will go back to the basics. And I think, especially nowadays, something that we've commonly seen is people use the word depressed loosely. So making it lighter further. Oh, I'm depressed just because something bad happened. Oh, they just feel low. Oh, I'm depressed. But we in the health sector should know what depression is, and we should understand it, and we should be able to actually look out for it. It's one thing for an expecting mother or a woman who's just given birth to feel a bit low or sad for 1 day, 2 days, mood swinging. But if this actually exceeds 2 weeks of persistent low mood, that's a clinical depression. And it's not something that we should overlook. So again, very significant, we should ask for the duration that this woman has been feeling that way. And we shouldn't undermine that. It should still make us look for more or monitor, be deliberate to monitor it, or at least even refer this person for some mental health support. So talking about postpartum depression, this can occur within 3 months of delivery. And it's usually missed because, again, people are expecting some of these changes to be normal. Yes, some of those changes are normal. And we'll talk a bit more about postpartum blues soon. But what we have actually noticed in practice is that a lot of people get missed. And you find a woman has struggled through 6 months to 7 months with depression, while trying to take care of her child or her home. And you find that even the care that they're able to give the child, their functionality is greatly affected. And that's another key area to assess. Okay, is this just mood swings? Is it just adjustments postpartum? How is their functionality? How is their reaction, their feelings towards their child? If it's negative, if their functionality and care towards the child is affected, that should be a red flag. That should get our attention to dig further into this woman's presentation. So I think my emphasis today is early diagnosis and being deliberate to actually screen for that. I think I've spoken a little bit about the biological vulnerability and risk factors, and I believe we're all experts when it comes to the biological aspect and the hormonal aspects as well. So maybe just to mention as well, when it comes to the hormonal aspects, various studies have been done, and it's been noticed that actually the women who present with depression, it's not like they've got different levels in estrogen or progesterone levels or cortisol levels during this postpartum period. You find that they might have all those normal changes, but it's different women respond differently to these changes. So others will be more prone or be more sensitive to these hormonal changes, and hence they'll present with depression. Well, others will be able to survive it well. Others then amidst a lot of stressors, they probably develop some good coping mechanisms and they actually still come out well. Well, others who you wouldn't even expect to present with depression because you feel they've got a good support system, maybe their pregnancy was an eventful delivery, but for some reason, they actually do present with depression. So hence we're encouraging just general screening for all women in the postpartum. Actually, we're encouraging prenatal, perinatal, and and just sometimes when just asking whether there's a history of that as well would be very key. But we notice that as well is frequently missed. Then, of course, the psychosocial factors, issues to do with the partner, intimate support, family, what type of birth has this been, separations, divorce, a recent death, or if it's a special pregnancy, if there's been a lot of stress around that, miscarriages before, or if it's a special baby, or even maybe sometimes anomalies with the baby. All those can be very stressful to the presentation. So again, here just emphasizing screening. I think for me, I'll be happy if I left this presentation and at least most of you have understood that we need to be deliberate to screen. Simple screening. And yes, we've heard the complaints, especially in developing countries. No, there are so many patients, so many things to do, so many things to screen for. But come on, it's a minute. How are you feeling? Have you been feeling sad or low? Have you lost interest in activities that you love or you used to really enjoy? For how long has this been going on? A minute to 2 at most. If at all there is more, it will take you maybe just another 2 or 3 minutes to clarify. So is our excuse of the load of patients justifiable? I don't think so. So we're encouraging the screening of all mothers. Let's put it in our routine questions. The way we ask for the last normal menstrual period, the way we ask about any other physical features, are you bleeding vaginally? Let's also ask them, how are they emotionally? So we actually also have some screening tools that can assist. And these screening tools could be done at various levels in the healthcare process. It could be done antenatally, even before the women enter the clinician's review. The nurses could probably assist. Some of them, they could even self-administer some of these tools. Just about 10 questions, you have a good idea of what could be going on and can guide you on the next step to take. It can be done even maybe at the first presentation, somewhere midway, postpartum, and at least a month or two after delivery as well, at their next appointment. And if need be, refer for further diagnostic evaluation and treatment to the mental health section. 2 simple questions that I alluded to earlier. Over the past 2 weeks, how have you felt? Are they consistently feeling depressed, low, hopeless? Have they felt like they've lost an interest or pleasure in doing things that they used to? If a woman answers yes to any of these 2, because these are one of the major criteria that should be there for us to make a diagnosis of depression, then it means that one will need to further explore into the presentation of this woman and probably do a further screening. And I believe we can ask this question in a minute or 2. So here are some of the predisposing and precipitating factors and perpetuating factors for some of these women. So age, again, is another factor. That's why we tend to talk about early childbearing, early marriages, psychological factors, failed relationships. What type of relationship did this pregnancy come from? Does it have other social stressors to its presentation? Is a partner supportive through this journey, or was this woman left at some point during this journey? Is she accepted in the family? Lack of occupation, a single mother, a lack of safe or secure living environment, and also around the delivery, right? Is it a threatened type of pregnancy? Are there various biological aspects to it during the postpartum period? Is it a prolonged labor? Did it have to become a cesarean section? Nowadays, we've even gotten so used to cesarean sections, we think it's normal delivery. I don't know, in certain places, it's like, it's becoming like it's normal delivery, but is it a normal delivery? It actually needs some attention. And we, personally, I've attended to several women who, after cesarean section, they're affected by it for a couple of months, sometimes even into years. But I think through the practice, we've gotten so used to it as if it's a normal delivery, but it's actually affecting different women differently. Their mood, again, how are they feeling concerning this presentation, these pregnancies? Do they have guilt? Do they feel shame? Is it a new mother, right? Is this person maybe having difficulty mothering this child? All those are different aspects that we could actually explore. And of course, the good protective factors, whereby someone has a good partner, a good family support, there are no financial strains around this pregnancy and delivery. Those as well can be protective. So also just to highlight a little bit more about postpartum blues. So postpartum blues as well are common, especially in the first few days of delivery. So these will usually happen 1 to 3 days, but we don't expect it to go over 2 weeks. So that's, again, is another key aspect that we want to assess. And usually these women, they'll mostly have mood swings, they feel fatigue here and there, but you'll notice that their care, their concern towards the child is still there and their functionality is preserved. So that's a key aspect as well to notice. Because again, a lot of women allowed to go or leave the consultation room with the assumption it's just postpartum blues, adjustments, when they've actually gone into a depression. So if it's beyond 2 weeks, I think there's room to explore, especially where their functionality or attendance to their child is affected. So just a quick comparison, just to highlight the differences between a postpartum blue and postpartum depression. Postpartum blues, 1 to 3 days after delivery. By 2 weeks, they should have adjusted. If it goes beyond 2 weeks, sometimes then after a month or two, we'll only notice it then because it was missed. This woman was most likely having depressive symptoms, but it was missed in all these adjustments. So sometimes then a month or two afterwards, if we're seeing some of these depressive symptoms, most likely this woman has depression. And again, when it comes to postpartum, it's more of mood swings, up, down, tired, fatigued, irritated. But for depression, they're constantly feeling low. They're constantly feeling sad, depressed. It's a constant story of feeling. And for postpartum fatigue, well, for postpartum, they're hopeless, they feel despaired, bonding with the child is affected, and there's a lot of worthlessness, inadequacy, shame, guilt, and even negative feelings usually towards the child. And the functionality most impaired. And if there's any suicidal thoughts, please, red flag. At that point, I think that's where liaison psychiatry comes in. I think consult with a psychiatrist as well at that point. So I think we've spoken a lot about the various symptoms, and I think we've spoken into that. So maybe just some interventions to consider. So, of course, there are various symptoms that come up, and for postpartum blues, there are those normal adjustments that come in after giving birth, sleeping time, attending to the child, the demands can be quite tiring. So some form of self-care is important. We see, okay, how do you make a schedule to help you sleep and rest better, eat well, support from family or nannies, whichever way that can help this woman through this period can be very helpful. But as well, important is to screen for other medical conditions that this individual might have, like thyroid, anemia, that you would want to rule out. Then other than that as well, I think also an important aspect would be to give some form of support, even initially. Some studies have shown that it's helpful and can actually prevent a full-blown depression. Some counseling, even some group therapy. I know in our developed countries, psychologists and therapists are in low supply. Sometimes just some form of group therapy. Let's be innovative in our health centers or reproductive centers, obstetric and gynecologist departments. Are we deliberate to create such platforms for the women, especially those who we've seen to be at increased risk? Are we looking for their emotional well-being? And of course, there's also the pharmacological aspect. So for mild to moderate depression, psychotherapy could be helpful, but for moderate to severe, we would usually want to combine some form of psychotherapy and medication. And of course, antidepressants are available. SNRIs alternatively are a good option. And electroconvulsive therapy, a lot of people are reluctant to that, but is actually also a very good option, very safe, non-invasive, no risk to the baby or unborn child. Even perinatal, I think, would be also helpful for these women. So again, prevention. Key is prevention. Are we deliberate to ask the history of these women? Any history of depression? Because if there's a history of depression, that's increased risk. A history of postpartum depression, about 90% at increased risk. Any family history of postpartum depression, again, at an increased risk. So it's important for us to ask these questions, just like the way we ask many other questions related to one's pregnancy presentation. There's also been some studies about prophylactic non-pharmacological interventions being helpful. And for those who have got a history of depression and postpartum depression, feel free to consult, I think, a psychiatrist who could possibly assess if they could actually start some antidepressant prophylactic treatment in this individual to actually prevent a full-blown presentation. Then, in conclusion, postpartum depression causes significant distress and dysfunction. Let's give it the attention that it needs. Let's not be so fixated on the fertility aspect, the physical well-being of the unborn child and the mother, but let's realize that their mental health presentation also has a great bearing on their general well-being and their outcomes. And also just to keep in mind that we're seeing a lot of children who later on, when you follow back to their birth history, childhood, first year of life, so many different social and psychological stressors, which we see in their development. So let's prevent that as well on the other end. And untreated wound disorders place the mother at risk for recurrent disease. And yeah. So here we are creating awareness. So even as we go back to our various facilities, let's create awareness around this area. Let's put interventions to actually screen for these presentations and see how we can help these women presenting with postpartum depression or at risk of postpartum depression. Thank you.
Patients who have some oncological issues going on. I think one of the main reasons we actually miss is we only take things serious when the patients start inflicting harm on themselves or harm on others, or when they start having suicidal thoughts. But we need to consider that for some religious reasons, some patients may not be thinking of taking their lives, but they can have a full-blown depression crisis. And I think adding it, the criteria that you mentioned, the questions, I think I applaud that. And I think when we go back home, why not during the antenatal period, we have those type of questionnaires for our patients? And before we discharge the patients from the clinic after the postpartum period, why not we also have those questions asked before we finally discharge them from our clinics? I think that way things will not go unmissed. And patients also who have fertility issues in the fertility clinic, and patients who are struggling with cancer too, I think we really need to, at every visit, these questions need to be asked. After giving chemotherapy, they go through a lot of suffering, through a lot of pain. Sometimes they want to stop taking the treatment. I think we should also practice asking such questions. Thank you so much.
Thank you very much.
Thank you, Mark, for giving me this platform. And I really have a strong bondage with the Mark because a lot of my friends sitting over here. And thank you, Mark, that because the Merck Foundation, you have given me so many friends in Africa whom I've taught and whom I've given some of shared my knowledge with them, and now they are doing very well in their country. So thank you, Mark, and thank you for spreading this knowledge of infertility and other medical and other medical streams. Today, my topic will be very simple. We know of progesterone, and we know infertility. In infertility, there is only two hormones we talk about: estrogen, progesterone, FSH, and LH. So four hormones, and it's very simple. There's nothing like in a cancer, lot many drugs and lot many things. We have only four hormones to deal with, and of them, progesterone is least talked about. We know only progesterone. We consider progesterone in infertility only when we are transferring the embryos. Otherwise, there is no role. So, to give an insight about the progesterone and what is the implication and what's the importance of progesterone right now we have in ART, and what the level, because right now still we don't know the actual level of progesterone which are being taken up as a cutoff to be considered as a safe for implantation to be achieved. So let's see how it's go by. I don't have any conflict of interest in this. Just to set up the background, over a decade, we know that because of the evolution of the freezing technique and the evolution of the vitrification, now we are almost achieving 100% cryo survival. And along the side, with the inclination towards the freeze-all clinic, because to prevent OHSS, more and more we are inclined to do safer ART protocols through frozen embryo transfers. And this has been shown in the incidences of the frozen embryo transfer. The whole world is shifting towards the frozen embryo transfer. As you can see, in US itself, the frozen embryo transfer has increased from 22% to almost 72 to 70% in just 7 years. And so the Europe also have moved a lot. Not just these two prominent countries, but even in the India also, majority of the players have now shifted to the frozen embryo transfer. Like we are now doing almost 100% frozen embryo transfer unless it's not indicated or mandatory from the embryo perspective. So these are the numbers which itself tells the story that the frozen embryo transfers is now the way to go ahead for the to do the ART cycles. The reason behind, as I discussed, that it's evolved with the as the technique and the skills have been improved on cryopreservations. Now we are achieving almost 100% sort of cryo survival, not for the just for the embryo, for the day 3, day 5, as well as for the oocytes and the sperm also. We are achieving a very good cryopreservation survival rate and improvement in the stimulation protocol. Now long agonist has been and is been taken long agonist has been taken over by the antagonist protocol, just because of the fair one reason that now it's because of the antagonist, it's an OHSS free, and which OHSS, though it happens rarely, means 1 to 2%, but whenever it happens, there are a significant bunch of patients who may have may go into a major crisis and can be a lethal in such cases. And more so, though we have some prophylactic marker to say that this patient may go into and have an inclination and proximity to go into OHSS, but still that's not very well proven, and they are non-specific. And the reason, because of the same reason, we don't know which patient lands up in OHSS, and in the OHSS also who will go into the severe category. That's why it's better to have some protocol which is altogether prevent OHSS and doesn't have a risk of OHSS. So world is moving in that direction, and with the event of NICS cell-free DNA technology, more and more without the manipulation of the dark DNA embryo, we are now assessing the embryo's genetic aspects and trying to help more and more get good implantation rate by transfusing and transferring the euploid embryos. So again, this again needs your embryos to be frozen to be evaluated. All those things added up together when seen from a physiological perspective. Recent studies have also said that and indicated that the frozen embryo transfer, if done in a certain reasons, then certain preventions can be done. All those lead to a consensus that frozen embryo transfer can be a good choice, not for the patient perspective, but from the clinician perspective also. They can achieve, they can marry the embryonal age with the endometrial age very precisely. Now, if I summarize how the way we can do the embryo transfer, there are the protocol for the fresh embryo transfer, where on the day if any HCG trigger has been given, 2 day 36 2 day after that 36 hours we do the ovum retrieval, and on the 3rd day of the ovum retrieval we can assess the embryo for day 3 embryos cleavage state, and if they're good, and if you're not good, we can do the transfer. Preferably these days, again, assessing the embryos on day 3 is not been too much into the practice. Let's take usual protocol is to take them up to the day 5 and assess whether the blastocyst has been formed or not, because the conditions and the in vitro conditions are too good to for a patient for embryo, rather than putting them in a hostile environment of the uterus. So instead, let the embryo grow and go up to the blastocyst. And good blastocyst, if you achieve at the day 5 and day 6, then it's more better to prognosticate the outcome of that particular embryo transfer.
On the if it is an HRT artificial cycle, definitely you will be putting them on an estradiol to on day 2 or day 3 to get the endometrium prepared, and basis the age of the embryo which has been frozen. You will transfer on day 4 of the progesterone or day 6 or day 7 of the progesterone, depending on the age of the embryo. Now, two more protocols have been come into the picture in recent past. Those are like total natural cycle and the modified natural cycle transfers. And in the total natural cycle, we depends on the LH surge. So that is bit cumbersome from the patient as well as from the clinician perspective. To do a lot of monitoring is required from this LH surge, and the LH surge is how to go by the LH surge. We need to be very sure of whether from the baseline and from day 2 and day 3, the best baseline value, they should go up to 2.5 times, 180% increase should be there, or to more than the 20 international IU units, absolute value. Then we consider that the LH surge has happened, and from the LH surge, we can LH fourth day from the LH, we can consider day 3 transfer, and 6th day from the LH surge, we can consider the day 5 of blastocyst transfers. Modified is pretty much more easier and simpler than the total natural cycle, but still it needs some monitoring. Here, instead of depending upon the LH surge, we can see this. You see the once you identify the dominant follicle, you can give the trigger, HCG trigger, and then you can basis these you can plan the embryo transfers. Now, having said that, all these done, still too many questions are there which need to be answered. What is the optimal time of exposure of progesterone is needed? What is the timing of the concentration of the progesterone is required? Which route is optimal? What is the dose should be optimal? All those things. Since then, since in the case of an frozen embryo transfer, there is no corpus luteum, and all the available progesterone which an embryo is needing has to be derived from the exogenous administration. So considering these multiple way of administration of the progesterone has been considered. Vaginal vaginal preparation has taken over the market in the Europe and the US, where vaginal progesterone, since they are more patient friendly. But still, there is a lot of debate is going on whether we should use vaginal or a progesterone or a intramuscular or parenteral administration is superior. Let's discuss this and what is the cutoff which we need to achieve. Before that, coming on judging what should be the ideal way to provide a luteal supporting form of a progesterone, let's understand how the progesterone is there varies during the natural cycle. In natural cycle, once the LH surge happens and dominant follicles ovulate, that secretes progesterone. This progesterone, if we go by this chart, you can make out the lower 95% of the lower limit range is around 8 to 10 nanogram per microliter, while 95th of the upper limit is around 18 to 20, and average mean is around 12 to 14. So this is a natural cycle. What happens once the implantation happened, and it's going from the initial implantation up to the term, all the hormones, whether it's estradiol, estrone, or estriol, or progesterone, or 17-hydroxyprogesterone, all increases throughout the gestation. So we come to know 2 points. One is the progesterone is needed in the immediate luteal phase, and these progesterone level increases continuously throughout the gestation. Now, what are the different ways or means are there for administering the progesterone? So, thanks to the pharma companies, now we are having progesterones available in every possible route of administration, be it oral, sublingual, vaginal, intramuscular, subcutaneous. And again, they are in the various doses and all. The only clinical outcome, clinical implication, which I want to you to make out of this table is those who are having a T half-life of more than near around 12, 13, 14 hours. Those are the preparations which can be used once in a day. Now, considering all these preparation on the three aspects, whether how effective they are, how safe they are, how patient friendly they are, whether they have any first pass metabolism or not, then basis days, if you plot all together, then vaginal preparation is the one which tick all the boxes in all the four aspects. They're having a low first pass metabolism, they are patient friendly, they are pretty safe, there is no much risk, and they are very effective. But intramuscular, again, though it's not, it's having a low first pass metabolism, and it's effective also, but safety and the patient friendliness is not there. Now, let's see, before judging which progesterone, how much progesterone, and when to be given, and what is the other roles of various preparations, let's understand the progesterone, a role of progesterone in ART. We know the progesterone is needed for the pregnancy, to maintain the pregnancy, luteal support. Again,
a few questions.
Sorry, from that, just a moment. It promotes the secretory transformation in the endometrium, improves the endometrial receptivity, causes the uterine relaxation, and causes the immunomodulation needed at the level of endomyometrial junction. The important part of progesterone means, this slide, it gives you an idea of when is the ideal time, but the minimum time required to have a progesterone exposure. So see if I give progesterone, just the blue arrow is the one, the purple line is when we have given up the progesterone, if just a day before the embryo transfer, and the green line is when we have given a progesterone from the day of OPU. Now see, the concentration is different, and these concentration are higher the concentration increases the implantation rate, and higher the duration again increases the implantation rate. And but all these because this effect, this is the minimum duration required to achieve the quiescence in the uterus required and to improve the implantation products, improve the acceptability of a embryo. Now, if we compare vaginal versus intramuscular, so we rely on the how effective the progesterone is on certain markers or the certain levels. Those levels are like serum progesterone level. Only with the way to measure the serum, how much is the serum progesterone level are there. So we cannot measure anything in the endometrium, but the only way to measure is the serum progesterone. Now, if we have given intramuscular or parenteral administration, definitely the serum values will be very high, but we don't know how much of this serum value and serum bioavailable progesterone is reflecting onto the endometrium and is effective and lead and supporting them and supporting the embryo. On contrary to it, if we apply vaginal preparations, then definitely in vaginal preparation, the endometrial levels will be high because of the first uterine pass and local effect, but serum values will be very less. So we have advantage and disadvantage in both the preparation in the intramuscular and parenteral administration. We know there is a value we can measure, and we can see them and monitor the effectiveness of our medication. Whereas, but we don't know whether this serum level are really having any effect on the endometrial level or not. On contrary to it, a vaginal one, though it will definitely have a very good way, give very good reach and on endometrial progesterone level, but we cannot measure endometrial progesterone level, and there is no cutoff value available for serum values for vaginal preparations. So vaginal formulation, as I discussed, it has a targeted the drug delivery approach, have a better secretory changes, though it will have a low serum progesterone level, but it may be having a some advantage because any drug administered exogenously will have some side effects. Lower the serum progesterones will have a lower side effects. So there won't be a low hepatic metabolism, minimal side effects, and these can be given in the form of a capsule or gels and all. So what is the recommended doses? Some studies I want to quote over here. This is a study from 2012, which shows that the pregnancy rate has significantly increased after doubling the progesterone dose from 27% to 38%, 38.4%. So when increased from 90 milligram to 180 milligram, the pregnancy rate has significantly increased. Moreover, uh, the early pregnancy rates was decreased significantly also. But and this is the reason why people are have any in the almost 4 years back, people were fond of giving a lot of progesterone. They in the little support, they try to give progesterone, they try to supplement the progesterone in whatever possible means, oral, vaginal, and intramuscular, whatever. So, but that's not the scenario over here. In though injectable progesterones have very good monitorability, as you can see in the first graph, if I give in intramuscular injections, the serum levels shoots up like anything, and that's a very immediate or immediate effects, and that's the clinical implication and clinical utilization of this. What I can make out over here is that in any intramuscular uh, preparation, which is an aqueous, can be used as a rescue because it increases the serum level almost instantaneously. Whereas the oil-based solutions will have a steady states, and those are the preparation which can you use for routine purpose. But for the rescue purpose, you can use aqueous preparation over the oil preparations. The progesterone serum value after giving it intramuscularly, the dose serum values are dose dependent. Higher the dose, more the values. So considering these two facts, when I gone through the literature, there are hell number of studies are there which support the higher the progesterone, higher and better the success rates, better the implantation rate, better the live birth rate. But in the recent past, few studies have come up who are having who are not so very profoundly saying that higher progesterone is not so good. They are saying that the high progesterone can have some ceiling effect and can have an negative impact on the pregnancy also. So in this study, which has recently been published in 2021, they have done a control in the control arm. They have given 50 milligram of intramuscular injections. In one arm, they have in another arm, in the study arm 1, they have given 200 milligram of twice daily vaginal microprogesterone plus 50 milligram of intramuscular. In the arm 2, they have given only 200 milligram of vaginal microprogesterone. And what they have seen in both the arm, the live birth rate, though there was significantly lower in women who's receiving only vaginal progesterone than one who's receiving combination of the vaginal plus. So still the studies are having a dubious effect. Some are not very keen, sure about whether daily progesterone higher values are helping or not. When it comes to the oral one, we have only one molecule, which is dydrogesterone. And then recently, some studies are assessing the utilization of dydrogesterone on oral preparation to be used for endometrial preparation for the embryo transfers also. So this study, which have shown that if you use dydrogesterone as a sole preparation for endometrial preparation, then the clinical pregnancy rates were comparable with the other progesterones. Coming to the to my findings, which I wanted to show, I wanted to make you aware about. is there any way we can rescue the we can use the risk and we can rescue the cycle with an additional progesterone? Is there any, if yes, what is this, what should be the way of administration of in which progesterone to be administered to do, and what should be the dose and route of administration if you used to if you are going for an rescue doses, and what is the cutoff for the P4 on the day of embryo transfer? So for that purpose, since this was the gap in the whole of the literature, we had done a study of at our own institute, and what we have done is we have taken up a female with an age group of 21 to 14, and we in all these women we transferred the embryo to good embryos of a good quality embryos. Exclusions were usual exclusions were the male with an abnormal serum parameter, male with where surgical sperms retrieved, adenomyosis, endometriosis, uncontrolled diabetes, and hypertension now been ruled out. So is the serological patients. So this was the protocol, institutional protocol we utilized for these patients, where endometrium was prepared by estrogen 2 milligram triacetate, and then we put them on a progesterone intramuscular for endometrial preparation before endotransfer for 5 days, 5 to 6 days. And from the day of ET, we put them on a luteal support in the form of vaginal plus dydrogesterone or vaginal gel at percent twice daily, and dydrogesterone 10 milligram twice daily. On these protocol, we put everyone. We did antagonist protocol for all. We did the artificial HRT preparation for all, and we measured the serum progesterone for each patient on the day of embryo transfer, 20 hours after the last previous progesterone being administered, and collected these sample, done the ELISA and serum P4 being assessed. We categorized these patients into 4 quartile depending on the 25th, 50th, and 75th percentile. And so 1, 2, 3, 4 quartiles are always assigned. Patient been analyzed basis on all the KPIs and the clinic ART outcomes basis on the logistic integrations across various quartiles. So what we come out to know that when there is no deviation in the and that the age, body, BMI, P4, embryo transfer, all those have been standardized. There is no significant deviation. In 61 patients, SCT was done, and in 292 patients, the double embryo transfer has been done. But what is significant is that in both the cases, there was no difference in majority of the patients. There was no significant difference in the beta-hCG positive rate, biochemical rates, implantation rate, clinical pregnancy rate, first trimester miscarriages or second trimester miscarriages, ongoing rate, and live birth. What was significant is that as you can see in this forest graph, in the quartile 2 or the quartile 2 of the progesterone, live birth rate was significantly good in the second quartile, and similarly in the quartile 2 and 3, the miscarriages in the first trimester was high as compared to the when we were having everything equal, everything significantly normal across all, but the pregnancy was good in second quartile, which was where the progesterone was not too high, but miscarriages were high in quartile 3 and 4. So what were the implications? Implication is that first, if you are giving the intramuscular progesterone, then there is no need, because most, as you can see in the last slide, all were having after giving a dose of 5 to 6 doses of intramuscular progesterone, all were having more than 20 nanogram. So one implication is that once we are giving intramuscular injections for endometrial preparation for HRT, there is no need to monitor the the serum progesterone level on the day of embryo transfer. Second is there is maybe a ceiling effect, as we have made out that even the higher progesterone levels, higher the values can have some deleterious effect on the pregnancy, especially in the early miscarriages, which need to be further evaluated. So I suggest not to be very fond of the progesterone. This is good for a little support, but excess of everything can be deleterious. So even those patients who have, we see somebody who comes with a bleeding patients, we try to infuse with them with any kind, whatever possible way of progesterone, like progesterone depots and all. We try to give them everything. 17-hydroxyprogesterone, we try to give 100 intramuscular progesterone, dydrogesterone, but this should not be the way. Once the with any patient which is having a, which is by any mean, if they are maintaining a serum progesterone level of 20, which can easily be achieved with one single dose of single odom or daily dose of intramuscular progesterone, then this is easily be achieved, and with this is sufficient to maintain the pregnancy. So I want to say over here, with I conclude this presentation over here, that till now we don't know what is the everybody for everyone, that the progesterone level need not to be monitored if we are going with an intramuscular. Second is we need rescue dose if needed. If the patient is having a low values below 15, then rescue dose in the form of an aqueous can be given on those days, on the day of embryo transfer. And lastly, avoid from giving excessive dose of the progesterone. Thank you.
Thank you very much, Dr. Kitish Mendia. I will quickly take this opportunity to thank you for training me, transvaginal scanning and everything. It was very useful in your predictive practice. So just a few questions regarding assessment of serum progesterone. I do very few cycles, but we routinely do day 2 progesterone and also do progesterone the day we commence the vaginal progesterone. I don't know, do you think there's any utility or benefit in doing that? Thanks.
If I can make out, you want to know about the day 2 level of the progesterone's implications. So again, day 2 progesterones, if at all day 2 progesterones are high, we tend to avoid and start cycles if or is put on HRT cycles. But day 2 again, if you are giving luteal progesterones for the withdrawal, that definitely the P2 will be high. So day 2 E2 again, I don't say there is much any clinical significance, though the literature says that the high P2 can have negative implications. Again, I don't go by that logic, because for withdrawal again you are using progesterone, and that will stay for some time. So I don't buy with that logic. Definitely, till the research says anything, you can still maintain that any value which is more than 2, near around 2, you can avoid going ahead within cycles.
Good afternoon, everyone. Firstly, I would like to thank Merck Foundation for giving me this opportunity. For the next couple of minutes, I'll be discussing about the culture systems which are being used and were used. And hopefully by the end of this session, we'll know if we are anywhere close to the in vivo conditions. Culture of pre-implantation embryo is one of the key elements of IVF laboratory, and culture conditions maintained will actually reflect on the overall ART outcome. When we look at the embryonic development, it mainly depends upon the quality of the gametes that are there, the culture method that has been employed, the media that we use, how the embryos or the gametes are handled. Unlike a well-established cell line culture system, embryo culture system is very challenging to establish, mainly due to the dynamic in vivo conditions, which is very difficult to reproduce. So when the embryos are having a transit from the fallopian tube towards the uterus for the implantation, there are various nutrient gradients which are secreted by the maternal surface to the embryos. And on the other hand, embryo itself, which is continuously dividing and growing, it has a varying nutrient requirement. The complex interaction between the maternal surface and the embryo starts right from the beginning of fertilization with multiple yet synchronous events. So the fallopian tube has microvilli, and these undergo beatings, and also the cells that are muscles that are surrounding undergo continuous contraction, which ensures that the gametes or the embryos are enveloped with the tubal secretes. In addition to that, the ciliary beads that are there provides vibration, which helps in the nutrient diffusion into the embryos, and also ensures the activations of certain intracellular factors, which are very important for the overall embryonic development. When we look at the embryonic development in general, their requirement, it is varying. So it depends mainly upon the stage of development and the site of development. So until pre-compaction, the embryo is said to have increased pyruvate and decreased glucose consumption. And post-compaction, where the embryos is migrating towards the uterus for implantation, have their nutrient requirement reversed, where there is increased glucose and reduced pyruvate consumption. Keeping the in vivo conditions in mind, and also the dynamic and microenvironment that is involved, majority of the research has focused on either formulating the energy requirement by altering the composition of salts, amino acids, or even the energy substrate in the culture media. In simple terms, the formulation. The other concept is the oxygen tension. So uterus being the natural incubators, there are certain models of incubators which are developed to meet the internal requirement. And finally, considering the biochemical and the chemical stimuli that are present, there are certain culture system platforms that are being developed. Incubators are one of the critical instrument in an embryology laboratory, and it is the place where embryo spends majority of their time. So increasing study has shown that the oxygen concentration in the female reproductive tract is much lower compared to the atmospheric condition. So it is said that the lower oxygen concentration can be beneficial for embryonic development. With advances in the manufacturing and technology, currently there are various models of incubators available, and they exist to meet the internal requirements. The culture media is a substrate where the embryo grows, and there are so many formulations that have been developed. So the concept mainly are of two aspects, that is the sequential culture media and the single step culture media. The sequential culture media mainly employs two sets of formulation, which supports mainly the pre-compaction and post-compaction embryos. Whereas the single-step embryo culture media, it employs a concept of let the embryo choose. So all the formulations are mixed together in the single culture media, and the embryos are allowed to decide upon their developmental stage. The culture media are generally prepared in the form of micro droplets, where they are the embryos are either cultured individually or in group, and these media are overlaid with oil and placed in a various culture system platforms. So two distinct type of culture system platforms have been developed. That is the static culture system and the dynamic culture system. Static culture system is a conventional method which is routinely practiced, and here the embryos are left untouched. Moving ahead to dynamic embryo culture system, it is developed to meet the internal requirement by mimicking certain biochemical or mechanical stimuli. In addition to this, embryo co-cultures were also explored and it is said to overcome the embryonic arrest in vitro, increase the embryo vitality, mimic the in vivo conditions, and also improve the embryonic quality as well as implantation rate. It mainly depends upon three major partners: the culture media, the feeder cells, and the embryos, which are cultured together. And this condition is said to mimic the in vivo environment. However, there have been certain concerns about embryonic co-culture system, mainly with respect to the risk of contamination, the safety of procedure that's been used, as well as time consuming. Majority of the study has focused on providing the nutrient requirement as well as the microenvironment. But very minimal attempt was done to customize certain devices which can be the combination of all of this. That is, to provide the environmental substrate, to provide the physical requirement at the time of the embryonic development. The combination of all this is the dynamic embryo culture system. There have been few models which are proposed, such as the platform movement, the wave-like fluid movement, or the fluid dynamics, which employs either a rotation or the vibratory movement, which is similar to that of the events that are occurring in the female reproductive tract. This is one of the study where a microfluidic device was used, which was connected to electrode. And the embryo culture was performed in the microdroplet. And when the electric potential was applied, there was change or a shift in the contact angle. So when the electric potential was applied, there was a movement towards this arrow. So when the electric potential was released, the droplet reversed back. So this particular movement resulted in the change in the position of the embryo, as you can see in these images. So this dynamic culture was compared with the static culture system, and it was observed that the overall cleavage rate was much better compared to the static, and the blastocyst development and hatching potential was improved in the dynamic culture system compared to that of the static culture system. When these embryos were transferred to a pseudo-pregnant animal, it resulted in live birth. Tilting embryo culture system is another model which was proposed, where a motorized device is placed in the incubator. So as you can see here, this device has a place for the petri dish which contains embryos, and it undergoes constant tilting or rotation motion. So the force which is experienced by the embryo is considered to be similar to that of the movement it experiences in the fallopian tube during its journey into the uterus. A modification of tilting device was done for a microfluidic channel where certain constrictions were provided to the dish, and it was also cultured along with the combination of tilting motion. And with both of these devices, the observation was that it improved the developmental potential of the embryo and increased the blastocyst development. Microfluidics is one of the commonly used method, and in this particular study, they devised a channel which would mimic the peristaltic movement called the microfunnel. So this device was established such that the embryos were not disturbed or replaced from their set position. So the comparison was done with the regular micro channel and the static system. And the overall result of the study was that they found microfunnel culture system improved the embryonic development, and it successfully overcame the limitations of the static as well as the micro channel system, that is with respect to accumulation of autocrine factors and also providing mechanical stimuli. Majority of this study was done with animal work. However, recently there have been a couple of studies which were explored using with the human embryos, and their observations were with the ART outcomes. So what was found is that the presence of micro vibration or use of dynamic culture system enhanced or improved the embryonic growth. It increased the embryonic quality and decreased the embryonic development and increased the blastocyst rate. And also it increased the pregnancy rate. However, much recent study conducted in an IVF lab where the single embryo transfer was done, which was derived from the dynamic and the static culture. It did not show much difference with respect to the blastulation rate or the implantation rate. So they this particular study, they concluded that it might not be that beneficial. The majority of the study that I have discussed previously, here the entire culture was done in vitro. However, there were few devices which were developed where part of the culture was done in vivo. In vitro culture, system is actually a prototype which uses 1 centimeter long silicon hollow tube, and the embryos were placed inside this hollow and transferred into the female reproductive tract. The device was designed in such a way that the embryos wouldn't escape, but there was adequate nutrient diffusion between the maternal surface and the embryos. This study was done in 3 major groups where the embryos derived from ICSI were randomly segregated for in vitro culture and in utero culture and assessed for at the time of fertilization and compared with the in vitro culture system. The second group performed ICSI, and at the time of fertilization, they were randomly segregated and cultured till day 3, followed by the comparison with the in vitro culture. And the final group was done immediately after ICSI, where the sibling oocytes were randomly segregated and cultured in utero and in vitro. So overall, the study concluded that in utero culture system did not interfere with fertilization. In the sense, it supported fertilization. It also supported the embryonic development, and the chromosomal segregation was normal as per the PGS analysis. The device also helped in obtaining the live birth. Intravaginal device is another system where the sperm and the oocyte is placed in a small device, and this device is placed in the vagina and cultured until 46 to 50 hours, following which the embryo development is assessed and the transfer was done. The advantage of this particular procedure was said to reduce the IVF cost and also provide psychological comfort to the mother since they are actively participating. Having discussed about the certain embryonic culture system, we still have a question. Are we anywhere close to the in vivo conditions? Well, there is still a long way to go to actually establish the in vivo conditions. The reason being that, do we actually know what the embryos require? So most of the studies do discuss about the mechanical and biochemical phenomena that are happening in vivo. However, most of them have not been validated with using a pregnant females, especially not humans. Talking about the in vivo secrets that are there, we have provided them or supplemented them in vitro using culture media. But the question arises, does embryo actually use all of the nutrients, or could certain components be detrimental? Majority of the devices that we see have been validated using animal models, and human embryos definitely cannot be used due to ethical restrictions. So as a clinical embryologist, our ultimate goal is to provide stress-free optimal embryo culture conditions. However, increasing evidences show that certain kind of stress or micro vibrations could help in improving the overall embryo quality. In conclusion, what I can say is that mammalian embryonic culture conditions does have a significant impact on the embryonic development. So far, there is no optimized or ideal culture conditions, since we are dependent on the static culture system as it's providing us stable or very good results, and we do not want to take risk as well. Finally, as an embryologist, we can aim to provide a stable condition, and this could help in improving overall ART outcome. Thank you.
Good afternoon, everyone, and thank you for the kind introduction. At the outset, I would like to thank Merck Foundation for organizing this particular conference and Shadaf for coordinating this entire conversation. So we move from fertility issues towards cervical cancer. Yeah, and as we all know, it is a huge problem in the low resource countries, right? So cervical cancer, globally, it is the 4th most common cancer, but in India, it is the most common cancer. And of course, in several African countries, it remains the most common cancer among women, right? And so I'll be dealing with two aspects. One would be the cervical cancer prevention, which will be the primary modality of prevention. And secondly, I'll be dealing with establishing colposcopy units, which are the diagnostic mechanisms of cervical cancers. As I said, cervical cancer is the fourth most common cancer among women globally, both in terms of the number of cases that we see and also in terms of mortality. The death, if you look at the mortality among women also, it's the fourth most common cause of death. But when we look at India, it is the second most common cancer among Indian women, again, both in terms of numbers as well as mortality. And as I said, in several African countries, it's the most common cancer. India contributes to the highest number of cervical cancer cases seen anywhere in the world, and we contribute to 1/5 of the global burden of cervical cancer cases, mainly in terms of the population we have. It is a big risk for us. While the incidence and mortality of cervical cancers, as you know, in the Western countries, in high-income countries, has gone down substantially over the years, mainly because they have good established screening programs. They have been having pap smear or the cytology-based screening program right from 1950s. So for the last 5 to 6 decades, 7 decades, they have been having screening programs by which they pick up cervical precancers at a very early stage and they treat it. Thus, the incidence or the number of new cancers coming up also goes down and the mortality also goes down. So, however, in low middle income countries, it still remains a very huge issue, and we still don't have established screening program. Of course, it's there on the paper, even in India at the national level, but currently less than 2% of our women population are screened for cervical cancer. And the same may be the situation in several low resource settings. This is one cancer where we know the cause, we exactly know how it happens, and we know that infection with high risk oncogenic human papilloma virus is a necessary cause, though it is not a sufficient cause for the development of cervical cancers. So as I said, we'll be dealing with this in two ways. One is looking at how it can be prevented, both in terms of primary prevention and secondary prevention, and how do we go for diagnosis and treatment. So coming to the initial part, prevention, this is one cancer where we can prevent in the entire life history of a woman, right? From the time that women is not even initiated a sexual activity, from the time of primary prevention to secondary prevention with screening, and then diagnostic and management. So we have a very good vaccines available now for cervical cancer prevention, and majority of the Western world have already incorporated the vaccines in their national immunization program, right? But these vaccines are preventive vaccines. They are not therapeutic vaccines. Hence, they are to be given to girls before they get infected with HPV or before the initiation of sexual activity, right? So girls before initiation of sexual activity, and this is the primary modality of prevention. Of course, we know about several risk factors that contribute to the development of cervical cancer, right from having multiple sexual partners, to tobacco use, to early marriage, to a lot of multiple pregnancies with less spacing between the children. And all these risk factors need to be taken into account. The women need to be made more aware of it, so that the cervical cancers can be prevented. So this is primary prevention. What about secondary prevention? All women from the age of 30 years at least need to get screened for cervical cancers. There are various modalities available for screening. And then comes the tertiary prevention. That is, any woman who is diagnosed with the cervical cancer needs to, or who is symptomatic with cervical cancer, need to be diagnosed early. And anyone who is diagnosed need to get appropriate treatment for the management of cervical cancers. So these are the primary prevention measures, mainly HPV vaccination, and of course, prevention of all the risk factors. Of women who has relation with only one sexual partner, but her spouse has multiple sexual partners, is also at a risk of getting cervical cancers, and poor genital hygiene and not using barrier method of contraceptives, all this increase the risk of cervical cancers. HPV infection. Now we know that HPV is the most common sexually transmitted infection, and every woman is at risk of acquiring HPV infection after the initiation of sexual activity. More than 200 subtypes of HPV are there, out of which we are worried only about 12 types. 12 types which are oncogenic and which can infect the female and cause cervical cancers. And we are talking about it. Many women, 90%, 80, 70 to 90% of the women may get infected with HPV, but we need to remember that in 90% of the cases, this is a transient infection. That is, the infection will go off on its own with the help of body's own immune mechanism in a matter of 6 months to 18 months or maximum 2 years to 3 years. The infection will be cleared. But it is only 10% of the women who will continue to harbor the HPV infection who will go ahead to develop a cervical precancer. And later on, if it persists, then the women may develop a cervical cancer. But there are so many stages wherein it can still be reversed and get back to a normal cervix. So we are worried about the 12 high-risk HPV types and most worried about HPV 16 and 18, which are responsible for over 70% of the cervical cancers. A woman may be infected with one HPV type, she may get it cleared the infection, and she may be reinfected with the same or the other HPV type. She may be co-infected with multiple HPV types as well. Globally, 91% of HPV-related cancers, there are many HPV-related cancers that can happen to the penis, to vulva, to vagina, and other organs, but 91% of the HPV-related cancers are cervical cancers. HPV 16 and 18 are the most important, and we need to understand that women who are infected with HPV are asymptomatic, and we can detect them only by screening, that is screening asymptomatic women. We do have a good vaccines available. The first vaccine was licensed in 2006, and now we have 6 prophylactic HPV vaccines which are licensed for use, and all of them are to be intended to be given to people, to girls who are still not started with the sexual activity. They are all vaccine-like proteins. They are not live vaccines, and hence there is no question, there is no chance that if you vaccinate someone, she will develop HPV infection. So this vaccines, they are using different adjuvants and there's no preservative agent that is being used. All the vaccines, 6 vaccines, they contain HPV 16 and 18 because that is the most likely to cause cervical cancers. And of course, nonavalent vaccine also contains 7 more HPV types. The vaccines that are licensed for use for boys are the ones which contain HPV 6 and 11 because they are the ones which will prevent anogenital warts. Again, they are to be given to boys before the initiation of sexual activity, and hence quadrivalent vaccine and nonavalent vaccine are the ones which are licensed for use in males also. HPV vaccine, they are usually available in pre-filled syringes as a single dose. Sometimes 2 doses vials are also available. They are all to be given in 0.5 ml dose intramuscularly on the deltoid region. Whenever it is administered in 2 doses, the minimum interval between the 2 doses is 6 months. So we need to understand it is now a vaccine that has been universally accepted. More than 64% of the countries worldwide, globally, have included HPV vaccine in their national immunization program for girls. And 24% of the countries have also included this vaccine in the national immunization program for boys. India is soon going to roll out HPV vaccination program, but it's going to be for girls because currently the resources that the country has are not sufficient to actually start HPV vaccination program for boys. And we are going to initiate this vaccination program with the indigenously procured vaccine that is from the Serum Institute. Currently, the evidence that we have from the randomized controlled trials that shows 2 doses of vaccine are necessary. But there are a lot of trials going on comparing single dose vaccine with double dose vaccine. And the indirect evidence clearly points out that single dose vaccine is equivocal to 2 dose vaccine. And hence, WHO is also recommending that for low resource countries, you can just go ahead with a single dose vaccine for girls up to 20 years of age. For women above 20 years, go in for 2 dose vaccines with a minimum interval of 6 months. And for women who are immunocompromised, who have HIV, minimum doses are 2 doses, but ideally you can go for 3 dose vaccination schedule. So this is all about primary prevention, avoidance of risk factors and HPV vaccination. What about secondary prevention? For cervical cancer, again, huge scope. So many cervical cancer screening tools are available that are evidence-based, that have been tested in randomized controlled trials. The first one to come was cytology, that was introduced in 1950s, pap smear, and it was introduced in all Western countries despite having a randomized controlled trials. But we don't need a RCT for it because 7 decades of use of pap smears in the Western countries have shown that it reduced the incidence and mortality due to cervical cancers in those countries that used the cytology-based screening, and there the incidence has fallen down drastically. The mortality has fallen down drastically. Then pap smear was one thing wherein you needed laboratory technicians to perform, you needed proper system to be in place. That was still not really affordable for low-income countries. And then it was explored whether VIA, that is visual inspection, after application of 4 to 5% acetic acid and villi would help in reducing mortality due to cervical cancer. And we have good evidence for that also. And the third test that came out latest was the HPV-based test, mainly the HPV DNA test, but there are also several HPV RNA tests that are there in the market. But currently, the WHO recommends that if enough resources are available, then go in for HPV-based screening. Of course, for a lot of low-resource countries, including India, we are still not in a stage wherein we can introduce HPV-based screening because it is quite expensive, it is resource-intensive, and we still don't have a HPV test that is low cost. So again, this is all the evidence. We have this evidence for HPV-based screening. We have all these trials, randomized controlled trials, they're from India that gave evidence of various screening methods. The first one was published in the New England Journal of Medicine, and this trial was performed in India by Dr. Shankar Narayan's group. And it gave evidence that HPV-based screening is much better than other screening methods. But of course, we still don't have a low-cost test to implement it across the low-resource settings. The second evidence was from Tamil Nadu, that is from India itself, which shows that VI-based screening also reduces mortality due to cervical cancer, but here they had used trained nurses to perform the test. And the third one, which was published in the NCI, Journal of National Cancer Institute of USA, was from India itself, from our own institute, Tata Memorial Hospital, and I was part of the co-investigators of this trial, which showed that VIA-based screening performed by even trained primary health workers can reduce mortality due to cervical cancers. So we have evidence of all these 3 tests. And then, of course, if you look at Bhutan, Maldives, Sri Lanka, Thailand, they've all introduced population-based screening, mainly with cytology, HPV, or with VIA. India, our current national policy, we have a national cancer control policy, which is named very differently at different stages, but we are using VIA-based screening according to our operational guidelines every 5 years. But currently with the screening, not even 2% of the population has been covered according to our latest survey, that is the National Family Health Survey 5. And this is the global map of where we stand, the blue color, where still pap smear has been used as a screening test. The dark blue color, wherein in Australia, they have completely shifted to HPV-based screening, and some countries which are in transition from PAP-based screening to HPV-based screening, and you can see many countries in Africa and India we are using still the VIA-based screening. So as I said, our operational guidelines recommend VIA-based screening, but WHO is still insisting that countries should adopt HPV-based screening as soon as possible. And if we want, cervical cancer is one cancer that we are targeting for elimination. That is less than 4 per 1 lakh incidence, and that would be cervical cancer elimination. Currently, we are at a stage wherein in India, it is 18 per 1,000 population. So if we want to eliminate cervical cancer, what we are looking at is 90% of the eligible population getting vaccinated with HPV vaccination, at least 70% of the women who are between 30 to 65 years of age getting screened, if not every 2 yearly, at least twice in their lifetime, at the age of 35 years approximately and 45 years. And then everyone who is symptomatic should get the diagnostic test done, and at least 90% of the women who are diagnosed should get appropriate management, both in terms of surgery, radiation, and chemotherapy. So now the question arises, why do women don't come for cervical cancer screening, whether it's India or Africa? Of course, one main reason is that the facilities itself for screening are not widely available. But if you look more into the reasons, then even if you will see that women from middle income class or high income class, they also don't go for cervical cancer screening frequently. The major reason being is that women just don't like to get screened. They find the entire procedure very embarrassing, and there are several barriers. There is lack of actually awareness regarding what are the signs and symptoms, why they should get screened, all the stigmas associated. And we should remember that women are not the decision-making members of the family. To a large extent, the decisions are mainly taken by the male members of the family. There are a lot of issues available, like how to go, how to reach the place, the transportation, the mobility, and the indirect cost, and the indirect issues like who will take care of the children, who will look after the household responsibilities. But now we have a solution for all this, and we know that HPV test can be done even by self-sampling. And so much research that is carried out world over has shown that self-sampling gives equivocal results to that of a health personnel collected samples. And so many devices are available to collect HPV self-samples. We actually use the same brushes that are used for a clinician collected sample, and they work very well for self-sampling as well. But then the question arises whether the women will be able to collect her own sample. For example, in rural areas, still the illiteracy is there, and whether if we provide this information with pictorial pamphlets, whether the women will be able to collect, she'll be able to follow the pamphlet, and will she be able to collect her self-sample? Secondly, women living in the slums, they go for public toilets. They don't have their own washroom facilities. So where will they collect it? They don't have enough privacy at homes. And then there are different mechanisms, the language barriers, and whether she will be confident in collecting her own self-samples, whether she has other misconceptions that it will cause injury or other things. So all this needs to be considered before we introduce self-sampling into the population. As I said, we have India is very diverse, and so I believe our different African countries also. We have very poor slum population, we have middle income population, we have rural population, which will all have different issues regarding self-sampling and cervical cancer screening in general. So what we do is, whether it's rural or urban area, we go house to house, we collect data about women who are above 30 years of age, we invite them to a temporarily set up camp in the area, we deliver them health education program and screen. Whichever modality is available, we normally do VIA-based screening for the population level. And we have primary health workers called ASHAs, whom we involve. These are from the government machineries, but we involve them because they can connect to the population very well. And we conduct a lot of capacity building programs for these ASHA workers. And we see that whenever there is an increase in the knowledge, increase in the awareness, there's a change to the positive attitude, the screening behavior changes, and there is a lot of uptake of screening. So one thing that we need to remember is that cervical cancers in the precancerous stages are completely asymptomatic. And that is why we need asymptomatic women to come up for screening. Whenever it's an early stage cancer, of course, there are symptoms like intermenstrual bleeding, postcoital bleeding, postmenopausal bleeding, a lot of foul smelling discharge, etc. But once the cancer has advanced, depending on the site to which it has spread, there are a lot of symptoms, including, of course, loss of appetite, weight loss, a lot of back pain, and pelvic pain, and symptoms associated to organs where it has spread. So the second part, coming to establishing a colposcopy unit, let me tell you, colposcopy is a diagnostic procedure. It's not a screening procedure. Anyone who is diagnosed as screen positive on VIA or HPV or PAP, you can undertake a colposcopy. Colposcopy, for those who are not using it, is nothing but a magnifying device, a microscope that is several times magnified, wherein you can see the cervix, which is really enlarged. You can see the lesion on the cervix, and you know where to direct the biopsy from. And several types of colposcopes are available. We see the lesion, we take the biopsy from that particular lesion, and it has to be done in a very standardized manner. Colposcopy is one thing. There are several guidelines available, different societies that have introduced the scoring system, and different types of colposcopes that are available with optics, digital, some which are portable, some which are not portable. These are the ones which we are using. I'm personally very comfortable with using the optic-based colposcope because you can see it, and then it is also attached to a screen. Digital colposcopes are also available, which are quite low cost. They are quite portable. And then a lot of handheld devices are now available in the market, which are very small, which are attached to a mobile device, and you can see the cervix, which is magnified. The which colposcope to use, it depends on what kind of budget you have, what kind of space you have, where you want to install it, and of course, what you're comfortable with. But normally, a colposcope with at least 15x magnification is something that we would recommend, and a colposcope with a green filter. You need to have some basic trolley instruments when you're performing a colposcopy, including speculums, your disposable gloves, and solutions like VI, the acetic acid, Lugol's iodine. And of course, if you're going to follow it with a treatment, then the cryotherapy unit, the thermal ablation unit needs to be in place. You need to have a staff nurse there and a comfortable couch for the women, the gynec examination table, and good light source, which is a must because this is all a visual-based procedure. Record keeping, including capturing of the images, is important, and quality assurance need to be in place in terms of the SOPs. This is freezing the cervix and cryotherapy and thermal ablation. You can go in for LEAP as well as conization whenever required, and this also gives histopathological workup. You understand whether margins are clear or not, and you have a complete diagnosis in place. So wherever cryotherapy is not feasible, or it is the women is not eligible for cryotherapy, and whenever you want a histopathological diagnosis, it's best to go for a LEAP, and if not eligible for LEAP, for conization. So to conclude, I would like to really emphasize that cervical cancer is one cancer that can be eliminated very easily. You have so many primary prevention modalities, including good vaccines. You have so many secondary prevention modalities that are available, including so many well-researched screening tools that are available. And there is no question, no reason why we should have such high morbidity and mortality due to cervical cancers. And really looking at India also, I feel bad that we have the largest number of cases of cervical cancers, and it is the second most common cancer among our people. But again, we need to remember that before we venture into screening services, we need to assure that the referral services and the management services are in place. Otherwise, we'll screen the women, we'll label her as screen positive, and will not know where to refer her for the diagnostic workup and treatment. And with a comprehensive approach to prevent, screen, and treat cervical cancer, we can really eliminate it as a public health problem, not just in our countries, but globally, and looking forward to the elimination of cervical cancer soon, and looking at women empowerment, wherein women can make decisions whether she wants to get screened, she wants to be treated, and not dependent on the male partners. Thank you very much.
Thank you. I am Dr. Sri Prasad Adhikari, a gynecologist from Nepal. It is a wonderful presentation and on cervical screening and treatment. I have one query regarding the woman after 26 years of age, and she comes for vaccination. So what will be our advice for her? And if do we need to do her HPV test before vaccination? Thank you.
Thank you for that question. One thing that we all need to remember, there is absolutely no indication for HPV test before administering HPV vaccine. It has no meaning. There could be transient infection. She might have had the infection cleared. She can have multiple infections at the same time. She can have the same infection later on. She can be reinfected with a different HPV type. There is absolutely no indication for an HPV test before administering a vaccine, HPV vaccine. Secondly, all these HPV vaccines, they have been licensed for use up to 25 years or 45 years, mostly up to 45 years of age. But we need to understand that they are all preventive vaccines. They are not therapeutic vaccines. So once a woman has initiated a sexual activity, there is absolutely no guarantee that this will stop her from getting HPV infection, even if you vaccinate her. The vaccines are safe. So if some women wants to still get vaccinated, depending on the vaccine, if it is eligible till 45 years, you can still administer, but no national program. If we want to incorporate it in our national program, then it has to be, we are targeting girls who are 9 to 18 years, because 18 years is the legal age at marriage in our country. And that is where we really want to focus our attention on. So if a woman of 21 years walks into the clinic till 20 years of age, she can still be given a single dose vaccine. And from 21 onwards, she can be given 2-dose vaccines with a minimal interval of 6 months. The interval can be prolonged, but minimal interval is 6 months. Yeah, and then of course, vaccination doesn't say that don't get screened. So we need to ensure that the women get screened at least twice in a lifetime, and if possible, every 2 years.
Yes, thank you, Dr. Okello Edwin from Uganda. My question is, you said girls not sexually active are the ones supposed to undergo this vaccination. What of girls who are not sexually active but have been in contact with someone with HPV? Because we know that HPV cannot only be transmitted through sexual intercourse. You can also get it through contact. Then the other question is, you didn't talk about HIV being one of the great risk factors for HPV, and then also continuation to what? To a much more severe form of what? Of CA cervix. So I don't know how you can clarify that. Thank you.
Thanks a lot for the question. Though it was there on the slides, for the time factor, I did not speak it out. So yes, as you rightly pointed out, HIV, with the HIV infection, the girls or the women really progress very fast from SIN1 to SIN2 to SIN3 to invasive cancers. And that is the reason that we advise frequent screening of these girls, even if the national program says every 5 yearly, even if the evidence is every 2 yearly, we would still go in for a yearly screening. And if there is a lesion, treat it, because we know that the progress is really fast. HPV and HIV going together we see rampant cases. The prevalence of HPV in Indian population otherwise is 7 to 8%, but in HIV positive women, it's much higher. And also the progression from pre-cancer to cancer is also very rapid, and we just can't miss treatment in HIV positive women. Regarding the vaccination in HIV positives also, ideally 3 doses are recommended. And if not 3 doses are not possible, at least 2 doses at a minimum interval of 6 months. But we don't advocate, WHO has not advocated single dose vaccine for immunocompromised and people living with HIV. So that is it. Thank you. Thank
you. Chair, ladies and gentlemen, dear colleagues, I'm honored to be again part of this scientific activity And as said, the FFS has supported Merck Foundation Luminary sessions for quite a number of years now. I would like to start by saying that Mullerian anomalies are rare developmental anomalies of the female reproductive tract. Traditionally, when we think uterine anomalies or Mullerian anomalies, people think about the uterus only. Yet, one message from today is that we also have to think about the other parts of the female genital tract, namely vulva, vagina, cervix, and of course, the fallopian tubes. So that's why Mullerian anomalies encompasses far more than just the uterus. I will discuss with you today maybe the challenges we have, not necessarily from a surgical perspective, but from a diagnostic perspective and understanding the value of surgery in treating these patients. Currently, the most recent classification of Mullerian anomalies comes from the American Society for Reproductive Medicine, ASRM, Professor Pfeiffer, published in 2021. This is a freely downloadable publication, and it has multiple QR codes, so you can access the information directly. The ASRM classifies Mullerian anomalies into Mullerian agenesis. I'm starting from the top left part of the screen with the absence of vagina and uterus. And you can see here underneath it how you can have Mullerian agenesis, but with also a remnant of the uterus that has actually a cavity inside. And this might explain recurrent pelvic pain in some females that have, for example, Rokitansky syndrome. The next one is cervical agenesis, variants of unicornuate uterus, uterus didelphus, and bicornuate uterus. Furthermore, when it comes to septum, there could be a septate uterus, a transverse vaginal septum, a longitudinal vaginal septum, and complex anomalies. I'd like to dwell a little bit on the uterine septum because the ASRM clearly differentiates between a septum, which is the first figure on the left, defined structure inside the uterine cavity that has a length over 1 centimeter from the line that connects the two ostia, and also that the septum angle at the tip of it inside the uterine cavity has to be less than 90 degrees. So these are important criteria. It is obvious that this cannot be achieved through hysteroscopy or laparoscopy. This is a ultrasound stroke radiological CT MRI diagnosis. As opposed to a septum, an arcuate uterus, picture in the middle, has a length that is less than 1 centimeter, and the angle you can observe is quite wide, well over 90 degrees. Last one is the bicornuate uterus, where there's an indentation more than 1 centimeter, but also a serosal indentation, which is absent in the partially septate uterus and the normal arcuate uterus. So very important diagnostic criteria, and unless you use advanced radiological diagnosis, it will be difficult to differentiate between them. For example, at hysteroscopy, picture 1 or A and C will look completely similar. The European Society of Human Reproduction and Embryology and the European Society of Gynecology published a consensus on the classification of female genital tract congenital anomalies in 2013. And in this paper, the classification is slightly different. You can see the main class on the left-hand side and main subclass in the middle and coexistent subclasses on the right. And it can become very complicated, but as long as you remember the main classes like normal uterus, dysmorphic uterus, a septate uterus, a diffuse uterus, including a septate diffused, and unilaterally formed like the unicornuate, and aplastic or dysplastic and unclassified malformations. So their drawing is far more simplistic, where you have a class 0, normal uterus. Class 1, a dysmorphic uterus, either T-shaped, infantile, or others. Class 2, septate uterus with partial or complete septation, a septum that comes very low into the uterine cavity, and many times, in fact, could be also present in the cervix. A class 3 with 2 bodies, bicorporeal, partial, complete, and septate, and then a hemiuterus class 4 with class 5 aplastic uterus. What is nice about the European Society of Human Reproduction and Embryology and the SK classification, they give you this table, which allows you during surgery to immediately take and create a diagnosis for you in terms of explaining to the patient, but also taking, having a good understanding of what steps you need to take in terms of surgical management. So how prevalent are congenital uterine anomalies? This is a paper that looks only at uterine anomalies from a group from Birmingham, Kumar Asami. They have done a lot of work in miscarriage. So the prevalence in unselected population, 1 in 20 patients, 5%. And in the infertile, 8%. That is 1 in 12 patients. Miscarriage, you can see the rate nearly triples compared to unselected to 13%. And if the patient has infertility, but also miscarriage, they identified 1 in 4 as having a congenital uterine anomaly. So this is quite a large difference between these 4 groups. In terms of clinical practice, congenital Mullerian tract anomaly surgery and fertility, if you just Google this in the National Library of Medicine, PubMed, you only find 24 results. So we have very poor data, truly, in relation to what is the ideal surgical or wait-and-see management in these patients. So I'd like to maybe summarize it for you in terms of when to operate. If a patient has recurrent pain, even in the circumstances where she is a non-infertility patient, so let's say a 12-year-old, a 10-year-old, a girl at menarche, think obstruction. A non-communicating genital tract, think about vaginal septum, a uterine anomaly, and think about a cervix that is malformed. So what surgical management do we have here? Well, firstly, an imperforate hymen. This is a simple operation with the cross incision. There could be a transverse or oblique vaginal septum, which needs to be resected. Cervical agenesis, that's an anomaly that obviously is difficult to treat, surgically at least. And then non-communicating hemi or rudimentary cavity. In terms of surgery, it can be curative. Of course, it cures the pain, but it also can be therapeutic in terms of removal of the septum, which restores anatomy and reproductive system normal function. So think about these anomalies, which I put all together. These are circumstances where you can have either trapped blood, for example, here in the right-left unicornuate with the right distal uterine remnant with functional endometrium, or you can have a midline vaginal septum, vaginal agenesis, uterus didelph with a unilateral septum with trapped blood on the right-hand side, obstructed hemivagina, or a bicornuate uterus with communicating tract and transverse vaginal septum. And of course, towards the right are some rare anomalies like a Robert's uterus, where you have a communicating cavity and fallopian tube and non-communicating right uterine cavity, or a bicornuate uterus with bilaterally obstructed endometrial cavities where there's no menstruation, but there's recurrent pain. The question is, who is best at diagnosing a congenital Mullerian anomaly? And there have been studies that show that maybe we are over-diagnosing congenital uterine anomalies. And this is a paper published in Human Reproduction in 2018 that critically assessed the classification that the ESGE group published, and raised the issue of potential impact of discarding arcuate uterus on clinical practice. And these are all renowned ultrasonographers. So here you can see how one can measure the distance between the interosteal, which is the opening of the fallopian tubes, and the line that connects those two openings, and the wall of the uterus. So you can see W is the distance from this line to the serosa of the uterus, and the I is the distance between the interosteal line and the endometrial part of the wall. And in the picture on the right-hand side, this is an entirely normal uterus, while in the picture of the left-hand side is just borderline towards a septum, albeit you can see it's arcuate as the angle is over 90 degrees. And an alternative measurement here on the right in the picture in B on the right, you can see if you only just measure that distance, it's impossible to classify that as either a septum or an arcuation, because it's not the first part, the W, is not considered. So they showed that 28% of women with arcuate uteri had concomitant fibroids or adenomyosis, which is a very important finding. So any structural anomaly in the uterine wall could actually mimic a septum or a uterine anomaly. So we need to outrule this finding in the presence of fibroids or adenomyosis. In more than a third of cases where the MO or AO techniques were used, they gave discordant results. So one has to further classify what's the best way to assess radiologically the uterine anomaly, and that between 27 and 58% of women with previous diagnosis of arcuate uteri will be reclassified as having a partial septate uterus if the ESHRE-ESGE classification is used, thus encouraging surgeons to introduce more more surgical intervention without having a good reason for that. In terms of a septum, this is still a very powerful debate. There was a Cochrane database systematic reviews. This was published in 2017, where they tried to identify any randomized controlled trial that look at the benefit of resecting a septum for women with in the reproductive age, and they could not identify any single study that brought in evidence. So this group actually published in 2021 a much controversial study called Septum Resection versus Expectant Management in Women with a Septate Uterus. And this was an 8-year-long study which randomized 80 women in multiple locations globally. And you can see in the end, there were only 36 patients in one arm and 33 patients in the other arm. The main concern were the techniques and the diagnosis, and the fact that over 8 years, only 80 women randomized means 10 women per year in multiple locations. That means that these surgeons performed maybe 1 or 2 surgeries a year, which is definitely not sufficient to draw large conclusions. But if you even see in the table 2 here, the energy mortality in this group, no resection. So here we have a randomized controlled trial that introduced patients that have a septum to either no resection or resection, and even in the resection part, there was no resection performed. So one wonders, how was the diagnosis being made? Suffice to say, they show no difference, either one resects the septum or not, and this was their summary answer. Hysteroscopic septum resection does not improve reproductive outcomes in women with a septate uterus. This paper has been criticized significantly, and to date, we still do not have a clear answer if resecting a septum is of benefit in women that have a uterine septum. Of course, if you remember from the first slide that I've showed you in relation to the incidence of septum in women that have infertility and miscarriage, in those circumstances, it's clear that one needs to resect a septum. So, ladies and gentlemen, the conclusions are the diagnosis of a Mullerian duct anomaly is and remains challenging. Multiple classification exists, but none is ideal. the risk of overdiagnosing a uterine septum is significant unless radiological expertise is called upon. Surgical intervention is warranted for symptomatic patients, and of course, the ones, when I say symptoms, it's not only recurrent pain and dysmenorrhea, but also infertility and miscarriage. And the reproductive benefit of uterine septoplasty remains to be proven when it is to be applied to any patient where a septum has been identified without a infertility or recurrent miscarriage risk. Thus, cervical vaginal anomalies remain a surgical and reproductive challenge. Thank you very much.
It was a great presentation. My question is related to transverse vaginal septum. One of our challenges is in managing high transverse vaginal septum, and what technique do you use for repairing? Sometimes we use peritoneal pull down. We used to also use colon to make the vaginal epithelium, but we have abandoned that technique because of its complications. What technique do you advise in such cases where there is a thick, high vaginal septum? Thank you.
My only experience is in vaginal septum with the presence of a uterus, and in that case, it's just incisional as opposed to peritoneal access. Is that you're referring to a septum in the circumstances of a uterine absence? Yes, I don't have any experience in this field. It's usually the gynae-oncologist that will operate on patients that have an absent uterus and vaginal remnant, for example, Rokitansky syndrome. We're considering a new vagina here as opposed to a septum.
Thank you,
I don't know.
Got
I
one
don't
more
know if this
question,
answers. Yes, please.
Yeah, the question is online, Professor Edgar. The question is, what is the role of surgery and chemotherapy in cervical cancer?
I don't think that's the question addressed to me.
I'd like to respond to the question of Dr. Thomas. For patients with high transverse vaginal septum, so the challenge is identifying the borders of that septum, because sometimes it may encroach to the cervix and you might be actually dealing with cervical agenesis. So that's an entirely different animal altogether. But if you have clearance from the cervix and you can determine by ultrasound the thickness of that septum. If it's very thick that you cannot oppose the epithelial edges, what we do is we put a mold so that to allow the vaginal epithelium to epithelialize. And after some time, you can take out the mold. But the complication that you might have there is some sort of infection. So you just have to monitor that patient regularly and perhaps put them on extended antibiotics.
Thank you, Dr.
May I add that the diagnosis is also radiological, as the pooling of menstrual blood in the upper vagina will clearly show a separation between the septum and the cervix.
Thank you. After this wonderful presentation, we would now like to move on for a panel discussion. And the topic for today's panel discussion is Merck Foundation, More Than a Mother Movement's impact on training the first fertility specialists and embryologists in Africa and Asia, sharing experiences and success stories. After thanking Dr. Edgar, we'd like to call upon our panelists. But before that, please note that we will be asking 1 or 2 simple and relevant questions for each panelist, who would be given 3 to 5 minutes only to answer the questions. To share their valuable experiences, we have in order of appearance today with us, Dr. Mackenzie Musebo Bright. Please come up on stage. Next, we have Dr. Gilbert Nibitanga. He is the president of Bafarte, Burundian Association of Fertility and Assisted Reproduction Technology Experts, consultant OBGY, fertility specialist at Polyclinic Umugiran is a fertility service, and a Merck Foundation alumni from Burundi. Next with us, we have Dr. David Wisigia, consultant OBGY, fertility care specialist, managing director at Women's Health and Fertility Specialized Clinic and Merck Foundation alumni, Rwanda. Dr. Thomas Gebre, Associate Professor in Obstetrics and Gynecology and CEO of Center for Reproductive Medicine, SPH MMC, Ethiopia. Dr. Ibrahim Saleh, General Manager, Al Hikmah Fertility Center, Ethiopia. Dr. Wobetu Alebachiu, Assistant Professor OBGY, Fellow in Reproductive, Endocrinology and Infertility, SPH MMC and Merck Foundation alumni, also from Ethiopia. Dr. Romerico Torres, Fertility Specialist, President of the Philippine Society of Reproductive Medicine and Country Representative to the Asia Pacific Initiative on Reproduction, ASPIRE, and Merck Foundation alumni from the Philippines. Please welcome them all. Next, we have with us online Dr. Novia Dennis, Fertility Specialist and Medical Director at the Keneja Health Center, Ministry of Health and Merck Foundation alumni from Liberia. Dr. Mohammad Siddati Kita, Director of the National Center for Family Health and Reproduction, CESFAR, Ministry of Health, Guinea-Conakry. With online, we have Dr. Abdullah Osena, gynecologist and AMP service provider, Referral General Hospital and Merck Foundation alumni in Niger. We have with us Dr. Sene Khadi, obstetrician gynecologist, Center Regional Hospital, El Haji Ibrahima Nias Kolak and Merck Foundation alumni, Senegal. Joining online, we have Dr. Jamil Talha, clinical embryologist, founder of Hayat IVF and Merck Foundation alumni, Bangladesh. Dr. Shri Prasad Adhikari, hospital director and head of infertility unit at the Paropakar Maternity and Women's Hospital and Merck Foundation alumni, Nepal. Mr. Jonah Amoa, managing partner at Mustard Health System, LBG, assisted reproductive technology and Merck Foundation alumni, Ghana. And last, we have Mr. Safwan Sisse, senior embryologist, Sierra Hope Clinic and Merck Foundation alumni, Sierra Leone. Please welcome them all with a big hand of applause. My first question is for Dr. McKenzie and Dr. Gilbert. Dr. McKenzie, we would like to know, please share your work experience as a fertility specialist in the public sector and how, according to you, can IVF services be made more accessible and cost-effective?
Thank you very much. Good afternoon, everyone. Like I've already been introduced, Mackenzie Bright are my name, from Zambia at the Levi Manasseh University Teaching Hospital. My experience as a fertility specialist in my country has been quite interesting and challenging at the same time, if I may put it that way. As you may be aware that from an African perspective, cases to do with the infertility are not disclosed quite often to everybody. And initially before the training, I think we just used to do things the way you understand the patient. But after getting the training and we introduced the fertility clinic at my hospital, things have been much easier in the sense that most of the people, even when they come, we now know that most of them, they'll come with very vague symptoms. They will not come out straightforward, say, no, I'm coming to seek help for infertility cases. They'll come with vague symptoms. Some of them will just come and tell you, no, I've probably abdominal pains, or I don't know what has been happening. So you need to really go in different direction until when you reach at a point that you need to take a past reproductive history. That's when you understand that this patient actually is here for infertility cases. And for the past 2 years, I must mention that we've seen quite, from the time we introduced the fertility clinic, we've got a lot of patients, a lot of patients, such that we couldn't even manage now. We had to introduce 2 days, clinic days in a week. We have Tuesday and Fridays. So Tuesday we do other general cases, but Friday specifically dedicated to infertility patients. And from that, I must mention that some of them have been success stories that I must be proud of, and be able to share that there are a few that we've had challenges where we couldn't manage to really treat them. But those with unexplained infertility, we do have money. At least we have an IVF center, which is private run. This is when we're trying to set up a public one. We still have challenges here and there, but I'm hopeful that we'll definitely manage For those that we send to the private sector, we have a negotiation, like we talk to them, if it's us who are seeing them, we negotiate with those guys so at least they are treated at a very low price compared to those who go direct to the IVF center. So when we screen them and know that these people can undergo IVF, we send them there and we negotiate on their behalf, and we've had success stories. One of the major ones that I'm proud of, like recently, we actually managed to deliver a 52-year-old lady via IVF, married to a 70-year-old man, and it was really, she was very happy, and I think it's been some success and some challenges there. I must mention that. Yeah.
Thank you. Thank you, Dr. Bright. Dr. Gilbert, can you please tell us what has been the role of Merck Foundation in helping you start a public IVF center in your country?
Thank you very much, everyone. Good question. I want to start from my youngest as a doctor when I finished my postgraduate, when I just returned back to Burundi from China, Fujian Medical University. As a young gynecologist at that time, I started to work as a gynecologist at the Burundi University Teaching Hospital. At that time, I was affected to all patients. And that time, I used to get patients who are suffering from infertility. But at the time, as my knowledge was not too many about that field, for sure, I was not able, I don't know what to do when I get, for example, a patient with obstructive fallopian tube, or those ones who are having azoospermia. I don't know what can I do that time. But when Merck Foundation Modern Mother Movement started in Burundi, it was in 2019, I get that one as a golden opportunity for me. And then I was one of the luckiest doctor, gynecologist, who was chosen to come here in India to be trained at the Milan Fertility Center. And after getting there, I met many high qualified specialists. And those specialists always tell me one word: always think big. That's the way they got from Milan. Always think big. And that word, after my training, I went back and I started to think, how can we start IVF in Burundi? And I start myself to think, I don't have enough money, but I'm working in a public hospital, Burundi University Teaching Hospital. I start work, and I start to think to go in touch with my hospital leaders to ask if I can start. But that time it was a big challenge. Many people in my country don't know what is about IVF. I want to start, but I can't get any financial support. But one day, I remember it was 1 year later, I got a special call from my country first lady asking me what I'm doing about what I learned from India. And I told her, I am ready to support my country and help to set up a IVF center in Burundi. And from that time, the first lady of Burundi supported me. We bought equipment and we start to set up that IVF center, and now it's running very well. We just finished the batch, and the batch was quite well, and we got the result of 26% of pregnancy, and I'm happy for that. And I hope that that start can be helpful in the future for our country. Thank you very much.
Dr. David, please tell us about the new initiatives, facilities, services added to your practice as a gynecologist infertility specialist after training with Merck Foundation, and how have your patients benefited from them?
Thank you very much. Good afternoon, everybody. Thank you for giving us this opportunity, Merck Foundation, and really thank you for inviting us to this conference to meet fellow colleagues and intellectuals. So really, I, as Dr. Mwesi David, as they have introduced you, I come from Rwanda, and really, I started way back when I was working in one of the public hospital in Rwanda. It was a Rwanda Military Hospital, and really, as I was like managing my patient, I came across really patients. There's one patient who touched my heart. We used to manage patients in a queue form. So all mixed up with infertility, and there happened to come a malnourished lady. She was really abandoned by her husband and really very hungry, but they made her enter first because when she came to me, I asked what the problem. She was suddenly she said I was surprised when she told us that she's coming for fertility services. So I helped her, got her what to eat. Then thereafter, I arranged her fertility treatment afterwards. So I canceled her. So from that time, after a few days, I got announcement from Merck Foundation. We are recruited. We went to India. So we learned, to cut the story short, we were trained and we learned a lot. So after we came to establish the IVF in public hospital, and we applied all the skills that we learned from India in 2018. So when we came back, I worked there for 3 years. We applied all, and really our patients benefited. So we thank so much Merck Foundation. And from there, when I saw how challenging it was, I also decided to go extra mile and establish my own infertility clinic. It's called Women's Health and Fertility Clinic. It's a specialized clinic. When you go to the Google map, you can watch it. So my going extra mile to establish this clinic, it was not that I had money, but I had to go extra mile, use the small money that I could get from other hospitals. So I can tell you that it's possible. You can also do it, because when we were in the IVF clinic, we used to see many patients, and with the government, so challenging because we have COVID, we have family planning management, reducing the number of births, what we do in the government. So having had that training from India, we managed to meet professionals who told us it is possible. So I tried to open up that clinic, because with infertility in Africa, it's challenging. Men are shy to be seen. You see women who are pregnant, those in labor, that fertility, they are mixed up. So when a man comes, it's like he fears, even some patients would go because they are not seen. But having seen the problem statement within the queue, I said, if I put up a clinic, I would see them. So you find that they are coming because when they reach, they feel comfortable. There's no kid crying, there's no one in labor. Those kind of scenario, atmosphere made patients, like when they come to my place, they feel they can talk they can take time there. All this I learned from the experience Merck Foundation exposed to me in the training. So have you learned the problem statement? So I said, let me put up the infertility clinic to help also the government. We should also support the government. Sometimes we want to accumulate a lot of money, but if you initiative, it is possible, because these patients with infertility, they want some privacy. So I said, let me put my clinic, bit of privacy, and really they are coming. Sometimes my colleagues say, why don't you incorporate other services, the ENT, to get money? No, I said, I'm not after money, but I'm after giving couples with infertility privacy, respect, not after money. So in my clinic, we do IUI, we do counseling. Just, in Africa setting, sometimes women don't think that at the age of 50 they can have babies. So we counsel them, we take time, either they cry in front of us. So we do IUI counseling, ovulation induction, and by the way, not every population or our community needs IVF. In Africa, people have the resource setting is low. So we need to advocate for awareness, first of all, and also manage. There's some I manage a lot without having no money for IVF. They can't my place, PCOS, what? Sometimes these IVF clinic private. Some of them, they're after making money. But in our setting, we are not after making money, but we give them, we manage according to how they come. So after looking how the Passionate Merck Foundation sponsored me, all these, they are going extra mile. So why can't I go extra mile, help these need patients without thinking of getting money from them? So our clinic is based on understand the problems. If we see that somebody needs IVF, we cancel and really we transfer to IVF clinic because we have to work in hand with them. We go for them, take them there. But in the future, we shall also be offering real experience of IVF. But for the moment, that's how we do. And we are very helpful for this community, for sure. Even research will be done. And we do also awareness on social medias, everything. So we're doing great. Thank you so much.
Thank you, Dr. David. We move on to Dr. Thomas Gabriel. So my question is, please tell us about the scope and challenges in providing IVF care in the public versus private sector.
Okay, thank you for the question, and thank you for the opportunity for being in this panel discussion. So as introduced, I still am the CEO of the first public IVF center in Ethiopia for the last 5 years. And we have come a long way since the start. We are doing now around 2,000 cycles per year. Initially, we started batching, just like my colleague next to me. And now we do continuous cycles, and we have managed to do more than 2,000 cycles in a year, actually. So throughout this process, we have had many challenges. The first challenge is setting up the IVF center itself. It's a huge undertaking, as you know. IVF is a complicated service. It needs funding, it needs financial support, and we were able to get that by advocacy from the government. And the government gave us half of the money for the initial budget, and half was secured from an NGO, and we were able to get it up and running. But the real challenge came in actually running the IVF center, because when you work in a public facility, it is a budgeted system. The government gives you a budget in 1 year, and you are supposed to use that budget, and you don't have flexibility. So that was a real challenge for the first year. And the way we tackled that is we had to have a new system called the private wing. So there is a public wing and there is a private wing in the IVF center. So with the money we generate from the private wing, we circulate that money and we are able to use it for many things. For example, for maintenance and quality assurance measures. We are able to incentivize our staff. As you know, clinicians, IVF specialists, and embryologists, they are in high demand, and they won't stay there if you don't pay them enough. So we are able to incentivize our staff, and also we are able to buy media, consumables, and drugs with the profit that we get from the private wing. So I think whenever you think of a public facility, the first thing you need to think about is financial independence. And you need to have that system where the government allows you to have some sort of financial independence so that you can run the center as a private facility. Otherwise, it is almost impossible to run a public IVF center without that freedom. That's all I have for now. And on the questions, I will answer more. Thank you.
2,000 cycles a year. That really deserves a big hand. Next, we move on to Dr. Ibrahim. So you are the general manager of a private fertility clinic in Ethiopia, Al Hikma Fertility Center. Can you please tell us the experience of the patient care provided and the kind of challenges that people have in accessing the private fertility services in your country, please?
Okay, good afternoon, everybody, and thank you for the invitation. So Shaddad, it's almost 7 years now. The advantages, especially what Merck have done for me, okay, sorry. The advantage that we get from Merck alumnus and these things, I used to work alone. 100 million population, one center. Then Merck came with their help. Now we are 6 centers. One of them, these people. So being a private alone, it cannot function. It's difficult. You have to have a lot of centers around you. What I love in IVF, it's a family issue. It's not a personal issue. You will find wherever you go, IVF people are always gathering together. You remember, Shad, 6 years ago, there was 2 rows only in this kind of panels. Now, I cannot see the end. This is also part of the Merck Foundation job. For us as a private, now we depend on them because they are the powerful people now. They facilitate a lot of things for us. Usually when you are a private, you cannot facilitate, you don't have that connection. Public is the one powerful. If they're your friend, you can manage, don't worry. Everybody. And thank you.
Dr. Wiberto, can you please tell us what is the role of awareness, education, and specialized trainings like the one provided by Merck Foundation in removing the stigma against infertility?
Thank you. As you know, infertility had been like some decades ago, it was neglected. But WHO has said it's one of the public, actually a global health problem. So, especially in Africa, especially in East Africa, I can say that there was no any awareness regarding infertility. At times, it could be it was considered that it was not treatable, or it could be by the family, by the community, the surrounding. There was a lot of discriminations. You know, it's difficult to disclose for even a family member, like when there is failure to get pregnant. So, Merck Foundation is really making a difference. Which is a significant difference. One, all these people are the products of Merck Foundation. Back home, we are from different directions of Africa and Asia, where there is low resource, there is everything is compromised. There is no lack of access, lack of supplies. I mean, fertility centers are limited in number. So back home, we all are going back and creating awareness to the community, or in addition to giving the care, in addition to establishing. I mean, that means we are saving the family of many, which were almost imminent to divorce or messed up life. In addition, we have seen important videos, important musics that are beautiful with important message. So that's really also creating important awareness in the community that infertility is not seen, or that infertility have a lot of treatment options. So I would like to thank Merck Foundation for giving all this investing that on infertility, apart from infectious disease or oncology. Still, we need to, as Dr. Ibrahim said, we need to have more IVF centers. So I think I have at least some of few questions.
You have. Thank you so much. Dr. Romerico, our question for you is that how has the general perspective towards infertility changed in your country in recent times? And do the male partners take active interest, undergo investigations, support the females during infertility treatment?
Yes. So we are a predominantly Catholic country, and in the past, discussion of third-party IVF, even ART, is something that's not to be discussed in public. But over the years, we've seen how people have been influenced by information coming in from all sides, whether it's social media, print, or even news. And we at the Philippine Society for Reproductive Medicine are doing our part. We've optimized current technology that's available. Like, for example, during the pandemic, we were able to establish a lot of webinars. We call it Online Thursdays. So when we had our Online Thursdays, part of that objective is, apart from educating doctors like us, we also reach out to lay people to help them understand certain issues surrounding infertility, how they can take care of themselves. So that has been a work in progress, and the awareness does not just involve the changes in perspective, does not just involve the lay people, but we also try to convince the older reproductive medicine specialists practicing in our country, because when IVF was first established, the people who brought IVF in the Philippines had to ask the permission of the Catholic Church in order for them to be able to set up operations. So the ethics behind the operations of IVF clinics have been largely influenced by what the Catholic Church was saying. But probably 2 years ago, we had a consensus. We had to reevaluate of how we stand about third-party IVF, surrogacy, and all of the controversial issues surrounding IVF. And what we did was a different methodology, because in the past, when we talk about ethics, there are louder voices than the rest of us, which means the older people, you cannot answer to them in a way, or it's difficult to oppose them. But what we did was we utilized the Delphi method. So the Delphi method, you put a survey and you ask the opinion of we asked the opinion of all of our members in the Philippine Society for Reproductive Medicine. And they were able to give their own opinions without fear of repercussions, because other people might judge them on how they view certain issues. And although the criteria for reaching a consensus on the contentious topics like third-party IVF, surrogacy, did not reach a consensus, because by definition, consensus has to be 70% agreement in all of those who are involved. There has been a large change in the attitudes of the clinicians, mainly because we see a lot of younger physicians like myself, but also we see how our patients struggle. Because we cannot provide them, once we say that you need oocyte donation, or once we say you need gamete donation, then that's the end of the road for them. But what we saw in that consensus guideline is that we were able to see that majority of the fertility specialists in the country are actually in favor of third-party ART, although it has not reached a consensus, which means majority means 50% plus one. So I think in a way, the perspective on how the issue surrounding the ART has changed over the years, and I'm glad that both the lay people and the physicians ourselves are catching up with what's needed in the times. Thank you.
Thank you so much, Dr. Romerico. I would like to know that if Dr. Novea is available online. Dr. Novea, can you hear us? Is Dr. Novea's audio on? No, I guess no. We'll have to move on with our physical panelists only.
Julia.
Dr. Siddharthi, do you be comfortable in English?
Yes. Exception. Exception fait avec. Voilà en français.
Okay. So our question today for Dr. Siddharthi is that how important is the role of policymakers in helping specialized services like IVF care become available and affordable to all?
Oui.
Role of policymakers in helping IVF services become available and affordable.
Et merci beaucoup. La question est la suivante.
Oui.
Quel est le rôle des décideurs politiques pour améliorer la prise en charge par la fécondation in vitro dans le secteur public?
Merci. Merci bien. Bonjour tout le monde. Bonsoir.
One line at a time.
Go on.
Non, c'est bon, j'ai compris. Alors, en République de Guinée,
in Guinea,
nous avons profité de l'adhésion des autorités.
In Guinea, we provide that the policymaker have supporters in decision making.
Aux stratégies nationales, internationales et régionales.
In supporting the national strategies and the international strategies.
Afin de un défi, celui de l'accessibilité au sein du VF à moindre coût.
So by being supported by the national authorities, that one help us to reduce the cost in the public sectors.
De la mesure où, en Guinée, la tranche la plus touchée, c'est seulement la tranche la plus pauvre.
In fact, in Guinea, the people who are affected are those one who are strong in terms of economics.
L'infertilité reste toujours un défi.
For sure, in my country, infertility is a big problem.
Mais en Guinée, après, pour la petite histoire, après la CIP d'Éducaire,
in Guinea, after the conference in Cairo,
une politique nationale centrée de la reproduction a été élaborée.
So that time, the national policy related to infertility was established.
Une loi santé de la reproduction a été votée à l'Assemblée nationale.
In the National Assembly, the law related to infertility was adopted from that time.
L'enseignement de l'infertilité et de la contraception a été introduit dans le cursus universitaire.
In the teaching system, also reproductive course was started to be taught in those education.
Nous avons donc profité de ça pour amener l'État.
So thanks to those things done in my country, the government was accepted to support us.
À s'investir dans la construction du Centre national.
And from that time, the government has started to construct the national centers for infertility.
Grâce à ça, l'État a donc soutenu le projet du centre en l'introduisant dans tous les projets de développement du pays.
So from that time, the government have started to be involved in supporting all projects related to supporting infertility.
À charge pour l'État de construire.
So the government started to build everything in that field.
Et dans la première proposition, la Banque mondiale allait équiper.
And then the World Bank bought equipment for the center.
Mais l'implication de l'État va avec la lourdeur administrative.
So the government did everything possible to make the thing possible.
Et lorsque nous avons perdu les 2,5 millions de la Banque mondiale pour l'équipement,
so after getting the 2 billion US dollars for equipment,
en poussant l'État, ils ont inscrit dans un projet à hauteur de 6 millions d'euros pour finir les travaux et équiper.
So after finishing the 2 million, we get another loan of 6 million to finalize the whole equipment, and the whole work was done.
Nous sommes donc à ce stade-là.
And then it was at that
L'argent est
stage.
disponible à travers le financement de la BID.
And another work was supported by the BAD, African Bank.
Et l'implication de Merck Foundation
And the Merck Foundation also supported us a
nous
lot.
a aidé à impliquer davantage.
The Merck Foundation helped us to support, push the government to be involved in those projects more and more.
Merck Foundation nous a envoyé un consultant.
Merck Foundation sent us a consultant person.
Nous a aidé à revoir l'architecture.
That consultant helped us to see if the building was conform to the norms.
Faire un projet d'équipement.
And help us to set up a project for equipment
qui répond aux normes internationales.
Which was done according to international norms.
Et ce consultant a rencontré les autorités du ministère de la Santé.
And that Merck Foundation consultant person had met
our country leaders.
Ce qui les a motivés davantage.
And then at that time, the whole leaders was really motivated
Et
for the
nous
project.
a permis d'avoir d'autres infrastructures à l'intérieur.
And then other infrastructure has been built inside that project.
Ensuite, je crois, sénateur Dr. Raja a visité le centre en construction. Dr. Raja.
Sorry? And Dr. Rasha has visited the project in construction.
Avec la première dame de la République.
And with the first lady of the country.
Ce qui a impliqué davantage.
And after that, everyone was involved more and more.
Et l'adhésion de la communauté a été facilitée aussi par l'appui de Merck.
And the community also was involved because of the Merck Foundation support.
Qui a organisé 2 journées de lutte contre la stigmatisation de l'infertilité.
Because Merck at that time organized 2 days activity for us.
Et la formation des journalistes.
For training the media.
Cela a montré à l'autorité que l'idée n'est pas seulement guinéenne, mais qu'il y a l'adhésion des partenaires.
So every partner was involved and then everything was done.
Vous ajoutez à ça la formation de 3 médecins cliniciens.
And then 3 clinicians, doctors,
et un embryologiste.
And the embryologist also the trained.
Qui a fait son master au Burkina.
Embryologist that did his masters in Burkina Faso.
Donc cela, avec l'implication de l'État, nous a permis de voir d'avoir un grand centre.
So all of those works was done because of the government was supporting us.
Autour d'une idée qui est celle-ci, tout en un. Tout en un. C'est une expression.
One in one.
Tout en un. Pourquoi?
Or in one.
Voilà. C'est-à-dire que quand une femme supposée un couple supposé infertile entre dans le centre, il ne va plus ailleurs.
Then one person who is infertile enter in the center, he don't want to go outside to be treated, he want to stay there inside.
Tous les examens qui l'amènent à l'orienter vers la FIV sont faits dans le centre.
So that center have every kind of examination can be done inside the center.
Lorsque la FIV est décidée, elle fera l'intervention dans le centre.
So if we decide to do IVF can be done inside that center.
Et après, le suivi est dans le centre également.
Even the follow-up could be done that time inside the center.
Et puisque nous sommes entourés de pays où les structures sont plutôt privées,
so our neighbors country have the private centers.
Je vais provoquer mes voisins.
So I disturbed them.
Je compte, une fois qu'on sera opérationnel, recevoir beaucoup de Maliens.
So I think I will get more patients from Mali.
De Sénégalais, de Libériens.
From a Liberian patient.
Pourquoi? Parce que il est prévu et l'État a pris ça de construire le logement.
Because our government they plan to construct the hotel inside for the patients.
Et dans le cadre enfin du partenariat, du transfert de compétences.
So for transferring the knowledge,
l'État a accepté et construit, ça c'est déjà terminé, le logement des experts.
That's adequate.
So the government started to construct a house for experts from outside.
Je maintiens là. Merci beaucoup.
Merci beaucoup. Thank you. Thank you, Dr. Siddharthi. Thank you, Dr. Gilbert. You're a savior and a true friend. Thank you so much. Next, I would like to ask a simple question to Dr. Keddy. All right. So, Dr. Keddy, can you please tell us that what are the challenges and what, according to you, are the key elements or components in providing cost-effective IVF care to the general population in Senegal?
Thank you. So my apology about my English. I am from Senegal. Countries we are speaking French. I will try. If it's not possible, my friend will.
Now he's become a friend of everyone.
So I'm start to joking my colleague. We want to have our center before you. Donc, no need to spend our passion in Guinea. I don't know if you understood. You understand?
We did.
So thank for Merck Foundation. Thank Merck Foundation for training me, and I could now help our population and give them smile. Thank Merck Foundation for allow me to joining this panel. I'm working in a public hospital, and we are 17 million people. We have around 60 gynecologists, 17 million. We have around 60 gynecologists specialists in infertility, and just 2 embryologists for all people. It's very less. And I'm working in a public hospital, and I start since 2021 after my training here. And when I starting, I have a few people because population don't have good information about infertility. They took infertility is something. Is it not sick? Is it not a problem? They are waiting until they have baby. It's not good information. So at the beginning, I go to sensibilize them. I go to television and to speak with them, to give them good information about infertility. And I have around 200 population, and 8% pregnant until I start. It is on 2022. So you understand? What am I saying?
Go on, your English is not that bad. Please go on.
Okay. I have 12%. 12%. So we are waiting our government to first to training gynecology, because this training is not available there. I have a chance to do my training in India, but a lot of people don't have it. So our government have to make this training available in our country. The second thing, they have to reduce the price, the cost, because IVF in our country is around 2,000 and 3,000 and 2,000 is about medicine. So the salary minimal in our country is around 100 for all people. I don't know if you understand.
Yes,
Every
we do.
salary. Huh?
We do understand that it is still a very expensive affair in your country.
Okay. So if we have 10 person who have who must do IVF, just one will do it. So we want to our government to reduce the price. The price of the medicine in cancer is free in our country. So we want our government to reduce the price, and why not give it them free? la troisième chose, je sais pas comment on dit ça, is to training to build a lot of center. Okay, we want our government to build a lot of center. We have just one center, and it is private center, and they are building one center in public hospital, but it isn't. We didn't have finished them, so we want our government to build a lot of center, because I work in hospital who is around 200 kilometers about capital, and the private center is in the capital. It is so far for my patient. So when I have one indication to do IVF, they have to do at the capital. So sometimes they want to go there. So we want our government to build center.
Okay. Thank you.
Thank you.
Thank you, Dr. Kelly.
I hope you understand myself.
Yes, we did. We did. I did at least. Yes. All right. Moving on to Dr. Adhikari from Nepal. Sir, I would like to ask you, what are the key challenges, especially social and cultural, involved in providing assisted reproductive services in your country, Nepal? And how has the Merck Foundation training helped you overcome the same and established specialized center of fertility care in your hospital?
Thank you. Thank you very much for inviting me as a panelist in this program by Merck Foundation. I am Dr. Sri Prasad Adhikari, gynecologist and infertility specialist from Nepal. I'm working in a government institution, and that is the only one institution which have IVF center in Nepal, so which is located in the capital of the country. But there are around 20 IVF private IVF center in Kathmandu only, but not in the periphery. So Kathmandu population is only 10%, I think 10% of the whole population, 8 to 10% only. So all rest of the population are without IVF center. So problem is the human resources, cultural. There is a little bit cultural also problem. Like it's a small country, only 30 million people, and it is located in between India and China, and most of the part are mountainous part and hilly regions, and only small part are lowland. So of course there is a cultural differences in the country, and there are 142 tribes and caste, but most of them are Hindu. So they are not much conservative regarding the ART service, like in Catholic, what you said. So, but about the ART donation, IVF by the donor IVF, there is a little bit, we don't have the law, but we have regulations regarding that. So we have to work on that. So, and only problem with our in Nepal is public center, they don't have IVF. And low income and middle income people, they cannot afford private IVF centers, because private IVF centers, they are making money. But they cannot, people in the low income people, they cannot afford in the private centers. So there are many people who could not afford the treatment. That's why I want to thank Merck Foundation, which helped me to develop my expertise so that I could build that IVF center. It is 1.5 years ago, and we have started IVF services. And we have given treatment to IVF around 50 patients in 1.5 years with the help of Merck Foundation. And I need more embryologists, because the challenges with me is I'm a director of the hospital and I have to run everywhere. And I don't have human resources for working especially embryologist in my country, because Because lack of embryologist, we cannot continue the IVF services. So if I go to another department or something like that, the IVF services will be closed. So that is my challenge. Main challenge is the human resource in my country. So hoping for the Merck Foundation to support to be continued in the future. Thank you.
Thank you so much, Dr. Adhikari. Thank you. We move on to Mr. Jonah Amoa from Ghana. I would ask common questions to Mr. Jonah and Mr. Safwan. You have both started your own embryology centers, right, in your respective countries?
Yes.
Okay. So my question to Mr. Jonah first would be, please tell us about the need, challenges involved, services offered, and the long-term vision behind establishing your own embryology facility. And how are your patients benefiting from these facilities, especially after you getting trained with Merck Foundation?
Thank you very much, Dr. Shabab. And I must say that I think it's been 5 years, if I'm right. Yes, for 5 years since I had a training. And right after the training, Ghana already had a couple of centers that were running and a couple of specialists in the area as well. So I decided to go on a freelance, as a freelance embryologist. I had the opportunity to make a national assignment in one of the regions, and listening to radio and all that. There was this, that kept coming up on this traditional medicine stuff. So consistently, you'll be hearing, they do this for fertility, they do that for fertility. So I decided to just go out on a mystery shopping sort of spree. And one thing came up. I realized there was a lacuna between the orthodox care and the traditional setting. Referral was going to be was a difficulty. The traditional bits were, getting quite a number of clients, because when you go to the clinics, you see huge numbers. But if you listen to them and the inputs, you realize there was a gap, a huge gap. But the numbers they were having also was because those people could not afford the private bit or the orthodox bit, which was mostly private. So I decided to, do a little bit around that area, had a couple of discussions with some of their leaders, and lo and behold, they saw sense in the reason that, look, the two must coexist. They could do their bit to a point, but they can't do it all. That the technology must also kick in. And that is how we began ours. So through the freelance, I put together a couple of my Luminary who also had training, I think, after mine. And then we started, on that. So we're able to help set up about 3 so far. There are 2 centers, hopefully next year, we expect them to also come on board. And I didn't just leave it there. I tried also reaching out to some of the alumni who were, let me say, closer, but outside the borders, for that matter. And they saw sense in that collaboration. And I think, lo and behold, they also started from that end. So I think next year, next year, but no, by the close of next year, we are kicking start another project in one of the neighboring countries. One is already, ongoing, and then we are kicking start another one in one of the neighboring countries. So I think that if there is some form of plurality of centers, it's also going to challenge the system in terms of cost, so that those probably who are profiteering can begin to realize that no, they can, reduce their profits in a way just so that the clients can benefit most. So that's it.
Thank you. Thank you, Mr. Jonah. The same question I would ask you also, Mr. Safwan. Please tell us about your new center, the new embryology center that you have started in Sierra Leone, and how is it helping your patients?
Thank you for the question. Good evening, everyone. Thank you again, and also thank all for providing me the opportunity to talk here. Returning home after my training, I was looking out a way to introduce ART in my country. But I faced with two main challenges. One of the challenges was how I could get the money to start at least IUI. And the second one there is I face a world where ART is a new phenomenon. Nobody knows about ART, not only in my community, but the country as a whole. And if I may say, Sierra Leone, my country, is the newest or the recent when we talk about ART. To prove that, this year, August 22, we experienced the first pregnancy from the center. So thanks to Merck Foundation for the training. So what I'm saying there is it is not my center, but I am a key pioneer for the existence of the first IVF center in my country. When I returned home, I was looking for a way to advocate how I can incorporate ART in my country. And I did not just sit down. I had to talk to medical expertise. Finally, I got one, a lady, whom ready to work with me. So after that, then we established that. So that's a good one as a result of the training I got from Merck Foundation. When we started this process, it was actually difficult in the sense that I faced with the world where nobody understands what IVF was or ART was. So my first venture was to mobilize by talking to people through radio stations. And sometimes I was invited to television stations just to talk because I can remember when I was in school or college in my country, what I know was artificial insemination. So the term ART or IVF is never there. So that's the same thing, except people who have family abroad. But majority of the population don't know that. So that was a very difficult one. So my mobilization through registration creates some awareness, reduce the stigma for people who have been stigmatizing with regards to infertility. So that was a very good one. And that was the help I have done in my country. And presently, the center is running very well. I am here to have my own, in as much as I'm working for a personal one. And it's not a public, it's a private.
Okay.
So thank you.
Thank you so much. Thank you, Safwan. That brings us to the end of this panel discussion. I would like to thank all you wonderful people to actively participating in this discussion and sharing your insights on this wonderful topic. Thank you so much, and you may please take your seats back in the crowd. Thank you.
Good evening, ladies and gentlemen. It's a pleasure to speak to you today in Bombay. My poor level in English at the important conference organized by Merck Foundation. And the theme of my presentation is management of infertility in low resource country. For example, in Africa. The plan is first history of infertility in Africa. Second, in Africa context of management of infertility of couples, means of the resolution of infertility for the population in Africa, and for finish, projection in line with new technologies. For the first point, history in Africa, infertility in Africa. It's down in time, Africa has been considered a club of humanity. The people who live there feed themselves according to their needs. They have children and took care of themselves. The medical care transmits by several generations, using psychological and cultural practice with decoction and plant with therapeutic virtues. Over time, the emergence of current medical science has led to new disciplines such as medically assistant procreation or assistant reproduction technical in Africa. The first practice beginning in the late 1990s with the open of the first in vitro fertilization center, and with strong demand for this infertility care service in Africa, had led the French-speaking country of Central and West Africa to create GIRAF in 209 in Lomé, Togo, with the first president is Moïse Fiallo, Dr. Moïse Fiallo. Various presidents of Africa of GIRAF is the first is Dr. Moïse Fiallo, and after Dr. Ernestine Wegbel, and after Dr. J.D. Kaba Jakite, and after Mohamed Latungi, and after Professor Justin Mboloko, and the last is mine, Professor Koulibaly Fungege Amadou in Côte d'Ivoire. Different country is member in the GIRAF. We are Togo, Benin, Burkina Faso, Mali, Côte d'Ivoire, Cameroon, Gabon, Senegal, Congo, Brazzaville, Congo, Kinshasa, Guinea, Niger, Chad, and Mauritania. Second contest, infertility, contest of management of infertility of couple. The vision of GIRAF being to offer quality service at the lower cost for the population in African context. Several difficulties have been identified. The first establishment of the center with reference building, we have premises allowing to work correctly. Second, have a competent local human resource able to work by the taking into account the African context. First, have suitable input with affordable cost. 4, strengthen communication to reduce the stigma of couples expressing a desire of child. 5, establishment in African exchange network which takes into account the particularity of the service offered. And 6, increase the pregnancies rate with the limited means available to the populations. Means of resolution and fertility of a population in Africa. For to have establishment of the center with reference building, we have permits allowed to work correctly. We must do lots of things. Be listening to the population to whom or we offer the care service, have a good command of the work context in line with the population we live there, have a social cultural approach in setting up of the center, to have a competent for local human resource, are able to work considered the African context. It's very important to take into account to account certain measures. Train local skill couple to work while respecting the reference standard in the particular context. Take a particular reference with African Center. We have a lot of years to practice. Participate in the meeting of giving and receiving organized by the Learners Society and laboratories. To have suitable input with affordable cost, it's appropriate to make a following arrangements. Have a few waste, intermediary, and delivery in IVF center in Africa. Have a best case direct collaboration with the manufacturer of product and factory. Set up a virtual forecasting center to make crop order for African country. To have strong communication to reduce the stigma suffered by the couple expressing a desire for children, it will be appropriate to use public and private media for explanatory campaign to raise people awareness. Integrate the model adapted to the level of the learners. Have an African network for exchanges that takes the particularity of context of the service offered. It's important to work in the following areas: organize a line of face-to-face meeting to share experiences, make upgraded in relation to the new technical uses, to increase the pregnancy rate with the limited means available to the population. Practitioner will be able to review the service in the following way: integrate research of therapeutical private medical plant in Africa, reviews psychological approaches in the context of the population, all the multidisciplinarity meeting for each attendee to make the right choice of the service that is offered. Project in the line with the new technologies. Firstly, thank the Merck Foundation for its invaluable in strengthening the capacity of human resources to increase the provision of care in the management and fertility in Africa. Take into account the various description factors will make it possible to reinforce the capacity practiced in the IVF center with the identification of the plant with therapeutic virtues and the psychological approaches. Moreover, a change between African countries that have the same concern must be more intensive to achieve perfection, the activity in the particularity context where resources are limited. Thank you for your attention. Wait a minute. You see, my English is no good, but I try to speak with you. Okay. Now, if you want to ask any question, please speak slowly. I understand. When we speak fast, I don't understand. Yeah. Okay. Thank you.
Thank you, Professor Koulibaly, for your presentation. and we request the participant to ask any question.
Okay, I'm understanding very well now. But you say you are a lot of group. Yeah, English group, Nigeria, and so on. And you are French group. So we are West Africa and Central Africa, but you speak French. For Hunter in Giraffe is a country. You organize in the country, and after you write some letter, send me, and you give your adhesion. It's okay. It's simple. The best. We decide this because, and we together is better. But if you run only, it's very difficult to obtain the objective. You understand to me? Okay.
Guys that come from in the West, how come we get a common bargaining power, get a common bargaining power for cheaper instruments, maybe that could help setting up these centers when we get backward. Because now we realize that our foundation has trained many people to stop the practice. But because of high costs, they are some people are going to say that going private. But the critical capacity, people have set up we start in the West and set up publicity, etc. Because if you are depending on the government, that may not happen soon. And the problem, our countries are still dealing with family planning. They do not even have that again. But such organization can help the government. Look at the data restriction we are in today for that problem. So if you can start and say, in 5 years we set up in West Africa, one family, it can be owned by us partially.
As alumni of Merck, and then in the next 2 years or 3 years we go to East Africa. In the next 3 years we go to West Africa. South Africa. In the next 10 years, we will probably be somewhere. That would be something. And I know with your CV and so on, that would be very easy for you. Thank you.
Thank you. Thank you. You say, when I start my presentation, we want to building public center. There are a lot of countries decided it is not easy. It's the same situation when you are what is it? Le journal, the media is very difficult because you need to put a strategy governmental to decide to do a media. It's the same for all things. But if you want a change after the meeting, I'll give you something because the strategy. You don't give a lot of, it's not good. Okay? See you after.
Other question, call? Okay. Okay. Thank you, Professor. Would you share the slide?
Hello. Gosh, I look a bit of a mess. Good afternoon. I'm very pleased to be able to talk to you today. Thanks to Merck for inviting me, and also thanks to Merck for sponsoring all those students that do the diploma MSc, enabling them to access fertility and women's health treatment online. So we've been hearing a lot about IVF, but now for something completely different. I've been asked to talk about hormone replacement therapy. I've only got about 20 minutes. I can't see my slides at the moment. Is it possible to see the slides on the... Otherwise, I'm going to be talking from memory about what the slides are. Can you show me the slides on my iPad? So we've only got about 20 minutes, so I'm not going to go into a great, that's lovely, thank you. Not going to go into a great deal of detail, but we're going to do a bit of history. We're going to do some basic do's and don'ts about HRT and an update. So what I want to cover during this lecture is why should we be thinking about HRT? And I want to cover things like life expectancy. I'm going to do a bit of history about HRT, how it started and where we are now. I'm going to talk about how we give it, and that includes looking at basic female physiology and the types of medication. We're going to look at risks and complications, and we're going to think a little bit perhaps about how long we should give it for. Next, please. Next slide. Great. Okay, so can we go back to the Queen, please? It just gives a little bit of a... So when our late Queen was born in 1926, life expectancy, she would have expected, and the average life expectancy in 1926 was about 50 odd years. So women didn't live very long past the menopause. In contrast, her great-granddaughter would expect to probably live into her 90s. And that means that she will be living for perhaps 40 years postmenopausally, almost half her life. So in 1900, as you can see from the graph, or in fact, if you look at the first graph, there isn't much change in life expectancy from 1700s up to about 1900. But then suddenly, with the advent of antibiotics and anesthesia and all sorts of different surgeries and therapies, life expectancy is now about 80. And if you break that down, then you can see that women do better, and especially fit women. So if we again change slide, please. We can skip that one because it was supposed to come first, but never mind. So if we then get to the history of HRT, in the 1940s, estrogen was purified from pregnant mare's urine. And that was the basic way of preparing it for the next 20 years. The feminist movement in the 1960s described the menopause as a hormone deficiency, and it could be cured by taking estrogen. And women, especially in the States, started taking equine estrogen, which was developed from the purified pregnant mare's urine, and it was very popular. But what people didn't appreciate was that if you give unopposed estrogen, then you will start to get proliferation of the endometrium, you will get atypical proliferation, and that can develop into endometrial cancer. And this started to be reported in the 1970s. It was then realized that you could reverse the proliferation by addition of progesterone. And in the 1988, estrogen progesterone combinations were approved by the FDA for hot flushes and osteoporosis. In the 1990s, it became very, very popular in Europe, and we were bombarded with sales reps coming along with different preparations and combinations, and this promoted its production. But then several studies were reported, and there was the Women's Health Study, and these started to show that there was maybe increased coronary artery disease and breast cancer, although obviously the estrogen was reducing osteoporosis and also, surprisingly, colonic cancer. So there were lots of studies with conflicting findings, and in the early 2000s, there was a decline in demand, people were scared of it, and GPs weren't prescribing it. In 2015, National Institute Clinical Excellence produced some guidelines, reviewed all the literature, and slowly HRT has been finding its place. So the next one, please. Next slide. Okay, so how should we give it? We realized that the original idea of just giving estrogen alone was perhaps not very good if you've got a uterus. And so estrogen and progesterone were advised. So why is this? Well, just a little bit about, I apologize if, because I'm sure that most of you know all this already, but if there are, it's the basis of how we give it safely. So I'll just run through it very quickly. In the follicular phase, estrogen is causing proliferation of the endometrium. At ovulation, the follicle releases the egg, and the follicle then becomes a corpus luteum, which is then producing estrogen and progesterone. And this makes the endometrium, it matures the endometrium, makes it secretory, waiting for an embryo to arrive from that fertilized egg. If it doesn't, however, then the corpus luteum will die off in 14 days, progesterone, estrogen levels fall, and the endometrium is shed. And then the whole thing starts again. So this, in fact, keeps the endometrium safe. It stops it from proliferating in an uncontrolled way, which can sometimes result in cancers. So how can we give this? How can we give this estrogen and progesterone safely? Well, you can give it cyclically. So you can get preparations which have estrogen continuously, but with 10 days of progesterone added to each pack, each monthly pack. And this will mimic the normal menstrual cycle. But if you're a lady who's reached the menopause, the one good thing about it is that you don't menstruate anymore. And cyclical HRT gives you menstruation monthly, which is not, means it's not terribly popular. There is a place for it in the perimenopausal group who still have some ovarian activity, because it will help to suppress that. But apart from that, it's not very popular. You can give estrogen and progesterone continuously, a bit like the pill, but without the break. And that works very well. There will be a little bit of irregular bleeding in the first few months, but that generally settles down and is very effective at not only giving you symptom control, but also keeping the endometrium thin. So how do we give it as a preparation? Oral is very popular, but it means that it has to be absorbed from the gut and it has to go through the liver. And an awful lot of the hormone is removed in the liver, meaning that you have to give a higher dose before it gets into the systemic circulation. Transdermal is a bit more physiological. It comes in the form of patches and sprays and creams. And that means it gets straight into the systemic circulation, just as it does from the ovary. And it does have some benefits in terms of side effects as well, which I'll talk about in a bit. You can give estrogen vaginally, which is very important when you're thinking about the symptom, urinary and vaginal atrophic symptoms, which can be very distressing and also are quite important from the point of view of pathology in terms of recurrent UTIs. So vaginal can come in the form usually of creams, but you can get vaginal estrogen rings and things like that. Okay, next slide, please. So the prescribing rules. Within a few years of the menopause and premenopausal, you can use these sequential combined preparations because there's still some ovarian activity. But there is a withdrawal bleed. No bleed HRT is what it says, except that there will be some spotting in the first few months, and that's a continuous treatment with estrogen and progesterone all the time. Estrogen only HRT should not be given to women with a uterus. It's a complete no-no, as we've discussed, as there will be uncontrolled endometrial proliferation, which will develop in about 10% of cases into endometrial cancer. Next slide, please. So, as I've said, tablets are popular, but a lot of the hormones are lost in the liver. Alternatives are very well tolerated and popular, and they're also safer for women who are more at risk of thromboembolic disease. So you'd think that maybe you shouldn't be giving estrogen to women with thromboembolic disease if you go back to research that was done on the pill, for example. But in fact, although oral preparations have an increased risk, which we'll discuss in a bit, transdermal do not. Atrophic vaginal and urethral symptoms, which I think have now been reclassified as genitourinary syndrome of the menopause. Vaginal estrogen is very good and can be used in addition to systemic HRT, and can be used in women who even have estrogen-dependent tumors, for example, breast cancer. And a lot of women on that sort of preparation who are on tamoxifen will get exacerbation of atrophic vaginitis. And you can think about vaginal estrogen cream safely because it doesn't really absorb into the systemic circulation. If you have women on HRT, it is an opportunity for regular yearly reviews, and at the same time you can be doing things like cervical cytology, breast screening, blood pressure checks, cholesterol checks, etc., which are all part of sort of general women's health postmenopausally. Just to let you know, at the bottom of that slide, there is a very important reference for NICE. So the benefits, well, 70 to 80% of women will get vasomotor symptoms around the menopause. They get night sweats, so they can't sleep. They get hot flashes, which is embarrassing. And remember, a lot of these women with the raising pension age are being expected to work full time, and it's interfering with their work. HRT is the best treatment for vasomotor symptoms. If it's completely contraindicated, you can try various other bits and pieces like clonidine and various plant-based things, which I'll talk about in a bit. But HRT is definitely the best at clearing hot flashes. Osteoporosis is a major killer. You just think about your mum when she falls over at the age of 70 to 80. If she hasn't had HRT, she's going to get a fracture. That means she's going to be hospitalized. She's going to get confused, and she's going to be not as mobile as she was, which generally means that often the poor old mum's going to have to go into a home. With HRT, you get less osteoporotic fractures. So that's 44 less per 1,000 women years. No, so 10,000 women years, sorry. So I've converted that into PTTWY. Diabetes is reduced as well. Colonic cancer is reduced, and it reduces vaginal and urethral epithelial atrophy, as I've explained. So if you can bulk up the urethral epithelium, then you get less stress incontinence, and you will also protect the urethra and the bladder against bacteria entry, so less UTIs. And that is with oral HRT, but sometimes you do need to add in a bit of vaginal. Next slide, please. Cardiovascular disease. Well, this is a difficult one because we expected, because we know that premenopausal women don't get as much cardiovascular disease as men, we thought that HRT was going to be protective. But the Nurses' Health study that came out in '97 did show reduced mortality in CVS women, but this was on women with equine estrogen. And it was observational, and there were lots of different estrogens, lots of different progesterones, and lots of different ways of giving it, and lots of different ages of the women, and different obesity levels, etc. So what it really needed was RCTs. The Women's Health Initiative looked at 2 RCTs in women aged 50 to 79, mostly 10 years postmenopause. One was estrogen alone, which begs the question, were they had a hysterectomy? And one was combined estrogen, equine estrogen, and medroxyprogesterone. The second RCT showed increased cardiovascular disease, thromboembolism, breast cancer, and was actually stopped. But look at what they're on. Equine estrogen, well, we haven't seen that properly since the 1980s. And medroxyprogesterone, again, that's a very androgenic progesterone, which has largely been replaced by more natural type progesterones. And androgenic progesterones are well known to adversely affect lipid profiles. So it's not surprising that that wasn't an ideal combination. Follow-up analyses on Cochrane reviews, etc., have showed a trend to reduced risk for cardiovascular disease for women within 10 years of menopause. And in all ages overall, there's no evidence, convincing evidence for benefit or harm on these later studies with more modern progesterones and estrogens. Next slide, please. Next slide, please. Thank you. Thrombotic events. Oral HRT has a small increased risk, 2 to 3 per 1,000 women years, compared to 1 per 1,000 in non-users. But transdermal, as I mentioned earlier, because it's not going through the liver, it has no increased risk. So it would be the treatment of choice if you've got a woman who has got perhaps factor V Leiden or something like that. Breast cancer, there are extra cases. Estrogen alone has increased cases, and estrogen progesterone also has increased cases. But it's associated with your years of exposure. So the longer you're exposed to estrogen, the more chance you have of developing breast cancer. So if you stop it at the menopause, then your chances of developing breast cancer immediately fall because you're no longer exposed to it. But if you continue with it, then you have the same risk as you had premenopausally of developing breast cancer. Different progesterones also will have risks. With the more modern ones, more similar to natural progesterone, which is safer than the old synthetic medroxyprogesterone and norelintide. Don't forget, Bo, that hormones alone don't cause breast cancer. Family history is important, and obesity also affects the risk. And just to make a note, no increased breast cancer risk with the use of vaginal estrogen. So you can safely take this and without increasing risk. So an individual comes to you, a lady comes to you and says, look, I want to have some HRT. How do you approach that? Well, I think you need to individualize the discussion. For each woman, you need to take a history, find out what the risk is if there are any increased risks in her, any increased risks in the family. The management should be individualized to address the symptoms. So some women, they may be getting genital or urinary symptoms, so then you can go for a vaginal estrogen. Alternatively, you may want to go for an oral estrogen or transdermal. Concept of risk needs explanation. For some women, any risk may be unacceptable, but others will be happy to take a small risk for benefits. And I tend to go for a sort of betting on the horse races type explanation. So I would say, well, if you're betting on a horse at 100 to 1, you're not really going to expect to win very much money. Whereas, you know, if your risk is higher, then you may be needing to look at things more carefully. In some women, systemic HRT may not be appropriate. For example, estrogen-dependent tumours. And then you can start to think, maybe look at other non-hormonal therapies, which we talked about early, like clonidine, which is good for hot flushes, and other things like black cohosh, vitamin E, SSRIs, gabapentin. Some studies will show some benefit, and it's worth just trying them. And you will find all this in the Australian Menopause Society advice to health professionals. Next slide, please. How long? Well, HRT prescribed before the age of 60 does seem to have favourable benefits and risk profile. HRT initiated before the age of 60 or within 10 years of menopause is likely to be associated with a reduction in coronary artery disease and cardiovascular mortality. If HRT is to be used in women over 60, then perhaps think about lower doses, think about transdermal. Evidence from the Cochrane database, as well as that from long-term follow-up from the WHI, has shown no increase in cardiovascular events, cardiovascular mortality, or all-cause mortality.
Janet, last 5 minutes, please.
Yeah, I'm on my last slide, I think you'll find, who initiated HRT more than 10 years. Women with early menopause and premature ovarian infertility should be definitely encouraged to use HRT at least until the average age of the menopause. Last slide. Last slide. The story of HRT so far. In the 1970s, it was the best thing since sliced bread. In 1990s, you wouldn't give it to a dog. 2020s, it's been rehabilitated, individualized with more evidence coming online. And there's an increasing need as we live and work longer. So maybe HRT has found its place. And a final thought. Would men be happy to live half their lives without testosterone? I'll leave you with that thought. Thank you.
Good afternoon, Doctor. Thank you very much for a good presentation. I just need your comments regarding the use of HRT. We know very much that with combined estrogen and progesterone, there appears to be more increased risk of breast cancer. And some literature suggests that the recommendation should be limited to 5 years of an average menopausal years. Whereas with with estrogen only, you can continue to up to 7 years. I just want your comments on that. And I see also with patients with premature ovarian insufficiency, one of the slides they stated that the patients should be on HRT at least until the average age of menopause. So can you just give us a guideline on that? When do we stop these medications, especially considering that the life expectancy too seems to be continuously being prolonged? Thank you very much.
I think as women live longer, they are going to want estrogen for longer. So you have to be prepared to have that conversation with them. And it has to be a conversation about risks, which will go up. But on the other hand, so does their risk of falling and getting an osteoporotic fracture and ending up confused and with a pulmonary embolus in hospital due to bed rest. You know, you've got to balance the risks and treat women as intelligent people who can balance risks and think about it and decide as women get older and survive longer, should they be spending half their life without the hormones that are keeping them healthy. And it's an ongoing risk stroke benefit analysis every year that you're prescribing it, isn't it?
It's a pleasure to speak at Luminary. You know, I've been to many of these in Africa. I'm sure this one is outstanding as always. And the audience and the speakers have really given us instructive information, and I hope I'll be able to do the same. If we could share the screen for the first slide. Okay. Disclosure information. I'm the clinical PGT, pre-implantation genetic testing director for Reproductive Genetic Innovation. This is a pioneering group in the United States. The very first pre-implantation genetic testing was accomplished by this group in 1990. They have done 42,000 pre-implantation genetic testing for both single gene disorders, monogenic or Mendelian, as well as chromosomal abnormalities. They, as the slide shows, they have done monogenic testing for over 700 different conditions. About half of the pre-implantation genetic testing done by this unit just is restricted to aneuploidy or chromosomal abnormalities. Most typically in OBGYN, we think of trisomy. So what we'll be talking about is that. Now, why are we interested in that? Why we're interested in that is that, as we all know, the success in assisted reproductive technology plummets once we get over about age 35 to 38. We've all familiar with this. This was a problem from the beginning, and now fortunately could be addressed. The reason it could be addressed is that we can now look at the embryo that is about to be transferred and decide whether or not it is going to be resulting in a normal pregnancy or a miscarriage. And as one's age, maternal age goes on, you can see the likelihood of miscarriage increases. So this is a mirror image of the previous curve that we looked at. Now, the obvious mechanism to address this is to look at the genetic status of the embryo before it's transferred, because indeed 50% of these embryos are not normal. They are usually trisomic or monosomy, that means only a single X chromosome, or they have 3 different haploid sets as opposed to only 2. So this accounts for about 50 to 60% of the miscarriages that occur. Sex chromosomal abnormalities or much less in this situation. So it's instructive to remember that the trisomies that are seen in miscarriages are not necessarily the same ones that we are familiar with in terms of monitoring a pregnancy. The live-born trisomies are number 13, 18, and 21. I'm not quite sure why we have this disruption of this slide, but I think you can see trisomy 13, 15, and trisomy 13, 18, and 21 account for the live-borns. But the most common miscarriage due to a chromosomal abnormality are none of these 3, namely trisomy 16, which accounts for 31.6%. So I hope this slide is clear, even though it's certainly confusing as it appears to be projected. So this is not a surprise to look at even a 30-year-old woman, to look at the chromosomal abnormalities or lack thereof of the embryos that she has, and we're trying to make a decision about transfer. So you can see in this 30-year-old woman, she has 11 embryos, but only 4 of these in a dark, bold-faced type are associated with a normal outcome. The others are going to result in a miscarriage. So we have a couple of questions that we need to talk about in terms of pre-implantation genetic testing for aneuploidy, that is a chromosomal abnormality. And the question is, how accurate is it for PGT aneuploidy testing? The other issue that we don't have time to go over relates to mosaicism. And all I'll say here is that one can transfer a mosaic embryo. The closest to a normal outcome occurs when you have the lowest percent of a trisomic line. So if you have 30% or 40% mosaicism, it's well worth transferring. We could talk about that in questions and answers if time permits. Now, the best way to determine exactly the accuracy of pre-implantation genetic testing for chromosomal abnormalities is the experimental design that's shown here. Biopsy the embryo, transfer the embryo without knowledge of chromosomal results. This takes care of a lot of biases that we could go over if we had time. And finally, then compare the pregnancy outcomes at a later stage. and look at euploid transfer versus aneuploid transfer. So such a study has been done. This is the best of the lot, 2021, by the three authors that are shown, published in Fertility and Sterility. In this case, there were 648 couples, 2,100 blastocysts, 60% euploid, and 25% aneuploid. So look at the outcome. In looking back at 13 weeks pregnancy, if there was a pregnancy, look at outcome as what was occurring. The euploid embryos, chromosomally normal, resulted in 82% implantation, 73% clinical pregnancy, and 65% take-home babies. Aneuploidy, there were some implantations. There was some clinical pregnancies, but 0 take-home babies. So no question that PGT-A is an accurate test and can be used. This is consistent then with randomized clinical trials. Here are 4 studies. These were done in the early stage of the development of the methodology to determine the chromosomal status of the embryo. We now have next generation sequencing, which is an even better technology. But each of these, there's about a 20% increase in the pregnancy rate when one transfers a euploid embryo compared to simply transferring an embryo that is morphologically normal, but we don't know the status in terms of chromosomal complements. See if we could get this to advance. Okay. So this means that in terms of the indications for PGT aneuploidy, the first 4 are unassailable. If you've had a pregnancy, if you've had a patient who's had a prior live-born trisomy, this will assure that you don't have a recurrence of that trisomy. The same thing would occur if you have detected the trisomy with a miscarriage. Likewise, we know that the major indication for PGT aneuploidy is advanced maternal age. So about a third of all ARTs in the United States are associated with PGT aneuploidy testing. And of course, that's more efficient as the maternal age increases. In terms of other indications, we will talk in just a minute about structural rearrangements, that is translocation. But I'd also like to call your attention to 2 other concepts in here that are very, very logical and can result in better outcomes in ART. So the first of these is that whenever you do a PGT for a monogenic conditions, such as any of the disorders that are associated with thalassemia, for example, cystic fibrosis, it is completely logical to not only do PGT for monogenic conditions, but also add PGT-A or aneuploidy. So here is the results of what we've had in our unit. You can see if you take individuals who are at risk for monogenic disorders, and we simply only look at this, there's about a 40% pregnancy rate in the referrals. If we add PGT for aneuploidy, it jumps up another 20%. And these results now are over 60, and in most cases, over 70% taken on baby. Likewise, the miscarriage rate drops because you have avoided transferring an aneuploid embryo. The other issue, which is, I think, even more important and addresses a public health concern, relates to the fact that there is no benefit in transferring two embryos when you can only transfer one. So this shows the results of a very good study in which half of the pregnancies were due to a single embryo transfer that was euploid. In the other situation, there were two transfers, and these embryos were morphologically normal, but you did not know the chromosomal status. So the take-home baby rate is about the same in the two cases, but the huge difference is there are no twins when you're only transferring one embryo. On the other hand, if you transfer two untested embryos, half of the pregnancies are associated with twins, 48% for twins and 52% for a single gene for a single embryo and a single pregnancy, of course. So there are some controversies in PGT aneuploidy and also in PGT for a translocation or structural abnormality. And the first is, should we do PGT in every single cycle or only for a specific age group? I've already commented that about a third of the pregnancies, ART pregnancies in the United States have had PGT for aneuploidy. So this is an individual decision and an individual decision for a given laboratory. PGT for aneuploidy testing as a way of testing for every single pregnancy is controversial. So some would say, let's test anytime you've had miscarriage, anytime you've had miscarriages, and others would say, let's only test if there's a specific indication for disorders other than chromosomes. And then finally, this reflects the balanced parental translocation. And so do we do this for every single couple or only those of advanced age? So let's comment a little bit about these topics here. So in addition to chromosomal abnormalities as an indication for pre-implantation genetic testing, we know that there are other conditions in which there is an increased risk, and it is feasible and appropriate to address this. In diabetes, if you're well controlled, you don't have an increased risk for miscarriage. But if you are poorly controlled, you do, and this needs to be addressed. Same thing for thyroid disease, in which you have, a lower rate or an increased rate of miscarriages due to hyperthyroidism. It was arguable as to whether that is applicable if you have antithyroid antibodies. Still, it's always good medicine to address glucose and thyroid status and treat this if it's feasible. There are other situations in which we believe that there are euploid explanations for recurrent losses, but in none of these do we really have vigorous testing and vigorous confirmation about the necessity of doing something. But we're all familiar, uterine anomalies, particularly controversial other than for second trimester losses. There should be an assessment about whether the prior losses were euploid and not aneuploid, because you could make the assumption that this is, if they are aneuploid, you would not make the assumption that a uterine anomaly was the explanation, as an example. There's usually a lack of a control group, and there's failure to take into account confounders. But nonetheless, I think we could take home the idea that diabetes is not well controlled, antiphospholipid syndrome, thrombophilias, and maybe endometrial receptors, but this is an arguable issue. So in general, I could address the fact that the real question is, are there any euploid recurrent explanations for miscarriages? And there are some, but we need to address that. For example, let's move ahead for that slide. What happens if you simply, in a sequence, tested and transferred euploid embryos? If you take a series of women aged 35, the first transfer of a euploid embryo resulted in 64% take-home babies. Those that did not have this, then in a subsequent cycle also had PGT-A, 54%. And those that still were not pregnant, the third transfer, again, a single embryo, 54%. The bottom line is that almost all patients became pregnant, over 90% in this particular situation. So the other concept, I think we could skip that, is translocations. We all know what translocations are: rearrangement of chromosomal portions between two or more embryos. So this is what we see right here. In this particular case, this is a normal 5, a normal 13, but there has been exchange between chromosome 5 and chromosome 13, and they've resulted in these unbalanced rearrangements. If you take such a patient, you can overall look here, and you can see that most of the embryos are unbalanced, and if transferred, would not result in a normal outcome. So what would we do if we have patients in which there's a balanced translocation? The reality is most embryos are unbalanced, and we would like to transfer only, for example, in the previous slide, that single embryo that was balanced. And the other value that we don't think about too much is that we can reduce the time until there's a viable conception if we have a euploid transfer as opposed to an untested embryo. So this is the real results that you can see here. If we could look at two very good samples 15 years ago, but they're still applicable, the cumulative live birth rate is very good, 71%. But look how long it takes. 6 years in one study, 4 years in the other study. And we all know that if we transfer a euploid embryo, the likelihood is that we don't need to do this for more than a single year. So pregnancies require longer durations by natural conception than they do by translocations. So the final slides here, just to show you here, for aneuploidy alone, that is an increased number of chromosomes, euploid embryos and aneuploid embryos are morphologically indistinguishable. In addition, euploid embryo has a high predictive value for sustained pregnancy, whereas aneuploid embryos have almost zero likelihood of a sustained pregnancy. Randomized clinical trials confirm the benefit, added 20% for PGT-A versus an untested embryos. PGT-A should always accompany PGT monogenic disorders, given the fact that the DNA has already been amplified. In terms of the other benefits of PGT-A, there is the obligation to transfer only a single embryo, and in this case, it reduces the twins and it has the same pregnancy rate. Finally, in patients who have a balanced translocation, it makes complete sense to do PGT and only transfer the balanced pregnancy, the balanced embryo. So the proportion of miscarriages due to euploidy has been overestimated, in my opinion, and many of these euploid embryos or in fact that do not implant are probably just bad luck from where they may have been put in terms of the transfer. So I'd be willing to answer questions, and thank you for the opportunity of going over this information. Thank you.
Our last speaker for the day is Dr. Painota Zamakupis from the United States of America.
So thank you very much for the kind invitation from Merck Foundation, for the great organization, and it is an honor always to participate as a speaker. As Professor Simpson indicated, I had always tried to participate, been to Africa, Dubai, and now online. So thank you very much again for the kind invitation. So the topic of my presentation is male infertility and clinical management of erectile disorders. As we know, and we'll start first with the male infertility coming from a reproductive endocrinologist point of view. We do see male infertility in approximately half of all our infertile couples, whether it is solely the diagnosis or combined with female infertility factors. Many of our couples will have treatable conditions, so either medical or surgical. Some of them will resort to ART to achieve pregnancy. And of course, there's going to be a proportion that unfortunately will have to resort to donor sperm or adoption. It takes two to tango, and that goes for infertility assessment. So it is very important that we concurrently assess both male and female partners. We should never forget that no matter what, the maternal age is the strongest predictor of fertility outcome in couples. So the initial evaluation will include, like everything else in medicine, the history. So it would focus on medical, sexual, lifestyle, and medications. And of course, the standard test to evaluate the male factor is the semen analysis, preferably at least 2 semen analyses. It is important to point out that semen parameters below the lower limit do not by themselves predict either fertility or infertility, and keep that in mind. So the goals of the evaluation, as we said, is to make sure that we can guide the patient in treatment. And then, of course, always keep in mind that there might be some underlying life or health-threatening conditions on a male infertility patient. Also bear in mind that, genetic abnormalities or lifestyle of the patient himself can affect the outcome in the offspring. For example, you have an older male partner, then the offspring would be at risk for de novo gene mutations, aneuploidy, and birth defects. We do need to refer to the reproductive urologist when we have abnormal semen analysis, failed ART cycles previously, or recurrent miscarriages, and the reproductive urologist will do a more thorough history and physical examination, and also order tests beyond the semen analysis as needed. The relationship between infertility and other health conditions is very important. We should never forget that, because up to 6% of those patients will have an undiagnosed medical pathology. And men with abnormal semen parameters have higher rates of testicular cancer, and the ones with azoospermia have higher rates of cancer altogether. In more than 50% of the time, the cause of the man's infertility can be attributed to another medical condition underlying the infertility itself. In regards to lifestyle, diet, smoking, there is low quality evidence to show that high lipid diet, like high fat diet, can affect semen parameters, and the same with smoking. But there is one thing for sure that we know, that if a patient takes anabolic steroids or testosterone for bodybuilding, which is quite common, that will definitely suppress spermatogenesis. And as the lengthy use of those medications or supplements, I should say, might also lead to complete azoospermia. Gold standard for diagnosis is the semen analysis. Here is the WHO 2010 criteria that we all use on a regular basis. Volume should be at a minimum 1.5, cc's concentration more than 15 million per cc, motility 40% with progressive motility 32%, and by strict morphology criteria, we want at least a 4% normal morphology. It is important to keep in mind that semen analysis on any male patient vary from ejaculate to ejaculate. We cannot label somebody infertile, or even in the case of azoospermia, even more so, with only one semen analysis. We need to repeat. We want at least 2 1 month apart. The results also should be used to guide the management of the patient, and are of mostly clinical significance if we have more than just one parameter abnormal. For example, let's say we have a semen analysis that only has a 3% morphology, the rest of the indices are normal. That is of a questionable clinical significance, versus we have, diagnosis of azoospermia, complete globozoospermia, or nectarozoospermia, that definitely make the diagnosis of male infertility definitive. In regards to azoospermia, we need to make sure that, the absence of sperm in the ejaculate is evaluated with a centrifuge semen pellet. So we'll have to make sure that basically we evaluate the whole ejaculate by doing so. And it is very important to distinguish obstructive versus non-obstructive azoospermia. How do we do that? I always say, if most of you are gynecologists, I say related to an ovary that is not functioning well. So if we have non-obstructive azoospermia, it means that the testes are failing. So then the testis volume will be small, the FSH will be high, the volume will be normal. But if we have a obstruction, then the spermatogenesis is not affected. The volume of the testis should be normal, the FSH should be normal, but the semen volume will be low. And then, of course, if we have a physical exam where we have, we feel like the proximal epididymis is enlarged, that also contributes to a diagnosis of obstruction. The hormonal evaluation in impaired spermatogenesis when it comes to obstruction, non-obstructive azoospermia, and hypo patients is here. Hypo, of course, LH, FSH, and testosterone will be low. In obstruction, the spermatogenesis is normal. Hormones will be fine. FSH, LH, testosterone normal. But in severely impaired spermatogenesis, then we have failing testes. So FSH will be elevated, LH so, and testosterone low to normal. If we feel that we have, by exam, congenital bilateral abscess of the vas, automatically we should think of cystic fibrosis gene mutation testing. Why? Because in 80% of those patients, we will find a mutation in the CFTR gene. If it's unilateral absence, 20% of those patients will have a mutation in the cystic fibrosis gene. Once we confirm that the patient is a carrier of cystic fibrosis, then automatically we need to evaluate the female partner for carrier status. And then, of course, if they're both carriers, offer PGTM. When do we test testosterone and FSH? Is when we have impaired libido, erectile dysfunction, oligozoospermia, atrophic testis, or evidence of hormonal abnormality on physical examination. Furthermore, genetic testing is indicated when we have severe oligospermia, and that is less than 5 million per cc. Automatically, we need to run karyotype and Y chromosome microdeletion. Karyotype Y because Klinefelter's 47XXY chromosomal analysis is the most common reason for severe oligospermia, azoospermia. In those patients, up to 50% with microtessy, we will be able to find foci of spermatogenesis, so we can freeze these sperm and then proceed with ICSI on these couples. Y chromosome microdeletions are the second most common reasons for severe oligospermia and azoospermia. And it is important to know on the results when we see an AZFC deletion, then yes, indeed, we can take the patient for TESI because, or we can find also in the ejaculate some sperm in 50% of these patients. On the opposite side, though, if it is a microdeletion, AZFA or AZFB, at that point, we should tell the patient there is no need to have any surgical retrieval because there's no way we're going to find sperm. Those patients will have to resort to either sperm donation or adoption. This is an algorithm of what I just pretty much described. You can find it in the American Society of Urology website, and it's a very good guidance of how to take the patient and evaluate the couple from top to bottom based on the male side. I know there's a lot of talk of sperm DNA fragmentation as a test to evaluate male infertility. We need to remember that it should not be routinely performed, but there are no prospective studies that have shown that this test is predictive of any outcome. But on the other hand, we do know that sperm DNA fragmentation might affect the outcome of ART, and it is definitely associated with recurrent miscarriages. So if we have a patient with recurrent pregnancy loss, we should offer the male testing should be karyotype and DNA, sperm DNA fragmentation. It is important to note that once you have the results, if the test is abnormal, the result is abnormal. If you have it is easily reversible causes for that, such as an infection or antidepressants, use of antidepressants. Then you can try and aid by fixing the problem. Otherwise, in select patients, you can also offer use of testicular sperm in ICSI to overcome the sperm DNA fragmentation problem. Treatments of male infertility will start with varicocele and look at the data. If it is a palpable varicocele that the patient has that is associated with infertility and abnormal semen analysis, then yes, indeed, it makes sense to have the patient undergoing varicocelectomy, because meta-analysis have shown significantly higher pregnancy rates after varicocele repair in this particular subgroup of patients. It is not, though, recommended if the varicocele is not palpable, and it's definitely not recommended if we have non-obstructive azoospermia. We also need to bear in mind that if we have the patient undergo varicocelectomy, that will delay an ART procedure for at least 6 months. So in the big context, if we have the female partner being of advanced age, low reserve, time limitations here might be crucial for this particular couple. So then the route might be to get sperm via surgical procedure and proceed with ART instead of varicocelectomy and waiting for so many months. Sperm retrieval can be done surgically, either through epididymal aspiration or testicular aspiration or testicular biopsy. Sperm retrieval by microtestis specifically is the way to go with people with non-obstructive azoospermia. Once we retrieve sperm, this can be either cryopreserved and used later on, or it can be used fresh for ICSI if we've made the proper, obviously, arrangements to have retrieval of the female and microtestis on the same day. In men with non-obstructive azoospermia, microtestis is better than TESI, and it's better than TESA. And also the microtestis offers the benefit that it has been shown that it can affect less the testosterone levels after the procedure. There is no difference if we use fresh sperm or cryopreserved sperm in cases that we have done testicular aspiration, but we also need to bear in mind that if we have a very low number of sperm cells, these sperms might not survive the freezing thawing process. So in a case like this, we probably would like to combine fresh microtestis and egg retrieval on the same day. Obstructive azoospermia is obviously when sperm, as I said, doesn't find its way out due to a obstruction. At that point, we can retrieve sperm from the epididymis. If we have an ejacular dysfunction, then we can use other methods to aid the patient to ejaculate, either sympathomimetics or vibratory stimulation, and even also electroejaculation, as long as you have somebody who's expertise and can do those procedures. In the case of retrograde ejaculation, we can alkalinize the urine, so it will not kill, in a way, the sperm. And then after the patient has ejaculates, then we can retrieve either through urethral catheterization or have the patient void and then isolate sperm cells this way. Or you can also obviously resort to surgical sperm retrieval. In cases of obstructed azoospermia, if it is status post vasectomy or if it is acquired or congenital, we can refer the patient on for microsurgical reconstruction, but we should only offer this as long as the female partner has good fertile potential. Otherwise, the patient or the couple should resort to ART, and then the sperm can be retrieved with surgical extraction. Medical interventions include intrauterine insemination for not severe male factor, but we need to keep in mind that after the first IUI prep, we need to make sure that we have a motile sperm count that is at least 5 million. If the numbers are lower, then this couple should better be referred on to ART, because the results are for clinical pregnancy rates are very low. Medical intervention will also, of course, involve medication. If we have a patient with hypogonadotropic hypogonadism, then we can use pulsatile GnRH, or we can start with HCG, mimicking LH activity, and follow testosterone levels initially. Once the testosterone is normalized, then we can add FSH to optimize the sperm production. We need to keep in mind that anytime we have a male patient, for whatever reason, that needs future fertility, but is prescribed monotherapy of testosterone, that will impair spermatogenesis. And eventually, after a long period of time, the patient might become completely azoospermic. And that is why, because the testosterone we give will have a negative feedback to the hypothalamus and then pituitary. So we'll have inhibition of gonadotropins that will then stop their spermatogenesis. If we have low testosterone levels, and that is the one indication when we can give either SERMs or aromatase inhibitors, Clomid is commonly used, but that should be used only in the male patient with impaired spermatogenesis and low testosterone. Same for HCG. If the patient has idiopathic infertility, like the FSH is normal, is a bit elevated, or if the patient has non-obstructive azoospermia, use of Clomid has very limited benefit and actually should not be given. And the same thing for FSH. Supplements have not been shown necessarily to improve semen parameters and fertility potential in male factor patients. They are of questionable value. Nevertheless, I know a lot of people will recommend. There's no data to recommend a specific one. But also data show that they are unlikely to cause any harm. So if the patient feels better taking them, I will say, why not? This is only one slide that I want to briefly discuss oncofertility. And what is very important is to keep in mind that if we have a male patient that will be undergoing gonadotoxic therapy, whether it's chemotherapy or radiation therapy, we should always have a discussion about fertility preservation. It is very simple in the male. We would like to bank multiple specimens, if at all possible, for use in the future. After the patient stops gonadotoxic treatment, it's important to let them know that they should wait and not conceive for a minimum of 12 months. Why? Because that treatment might have caused mutations in the developing testicular germ cells, and also likely-wise wait for at least 12 to 24 months to do a semen analysis, because it's going to take that much to find sperm again in the ejaculate potentially. If we have, if we resort to ICSI, it is always to keep in mind what the data says. And I know that worldwide, less and less programs offer standard IVF. The trend is to offer ICSI to pretty much everybody. Specifically, all the PGTA cycles will undergo ICSI anyways. But the data still shows that in unexplained infertility, in low oocyte yield, and in women of increased maternal age, the use of ICSI has not improved live birth. It is definitely indication if we have severe male factor and history of fertilization failure. And it's if we use it in any other indication, we need to keep in mind, specifically for fertilization prevention, that we should do 30 ICSI cases to prevent one failed fertilization that unexpectedly we might encounter. Again, I know the worldwide trend is to use ICSI, but I thought it's important to keep in mind the data. So in summary, in regards to the male factor infertility patient, we should always remember to parallelly evaluate male and female. We need to have a stepwise process of evaluation and consultation regarding treatment options. Definite treatments would be varicocele repair in the case of a palpable varicocele. We should correct any hormonal abnormalities, and we should have microsurgical correction of obstructive conditions, as I've discussed already. ART, on the other hand, is an effective intervention for fertility for patients that have non-obstructive azoospermia and require surgical sperm retrieval, and also in people with congenital bilateral absence of the vas. And now on to the erectile dysfunction. Briefly, I'll touch on the subject. As we all know, ED is the inability to attain and or maintain penile erection that is sufficient enough for satisfactory sexual performance. Erectile dysfunction is a risk marker for the presence of treatable underlying medical conditions, and we should always keep that in mind. These people have many other medical conditions that I will discuss here, and we should never just see erectile dysfunction and focus on that, but need to keep in mind that there might be also undiagnosed medical conditions underlying this presentation. It definitely will negatively affect a man's mental health, psychological health, his relationships, and his overall sense of well-being. We need to bear in mind that every person that presents with ED is unique. Why? Because the degree of the distress or how it affects his own relationships with his partners, the sociocultural, education, and religious context might be very different from patient to patient. And ideally, anytime we evaluate those males, we should involve the partner. 30 million men in the US suffer from erectile dysfunction and 150 million men worldwide. So it is a major problem. The independent risk factors for erectile dysfunction are the same like cardiovascular disease. So if a patient is older, smokes, has diabetes, hypertension, dyslipidemia, depression, or obesity, these are people that are way more likely to present also with erectile dysfunction. Why is that? Erectile dysfunction is a vascular, you can say, disease, has the same etiology and pathophysiology like cardiovascular disease. And we know that the worse the cardiovascular disease is, the more likely is the patient to have erectile dysfunction. And it is crucial to see this data that says that a young patient with erectile dysfunction has more than 50-fold increased risk of a future cardiac event, which is significant. Hypertension, likewise, contributes to the etiology of erectile dysfunction. Up to 42% of hypertensive men will have erectile dysfunction, and similarly with dyslipidemia. Up to 42% of men with high altered lipid panel will have erectile dysfunction, and total cholesterol and LDL significantly correlates with moderate to severe erectile dysfunction. One of the most common complications of diabetes mellitus is also erectile dysfunction, and we know that the prevalence of ED in diabetic patients can range anywhere from 20 up to 85%, and 20% of men with erectile dysfunction have diabetes. Often it might be the first presenting symptom of an undiagnosed diabetic patient. And we also need to remember that the longer the patient has had the diabetes, the more likely it is to develop erectile dysfunction. Other risk factors for erectile dysfunction include depression, smoking, premature ejaculation, lower urinary tract infections. So again, anytime we have a patient with erectile dysfunction, it is critical that we think of underlying medical conditions that should be addressed concurrently. The evaluation, lies again into thorough medical, sexual, and psychological history, a physical exam, and the one test that we usually run is a morning testosterone level. The treatment, and I will come to that shortly, is to be discussed with the patient and ideally the partner. There is no such thing as you need to start with medication. If this fails, then you need to go to penile prosthesis. Any patient can choose any type of treatment that they feel is best for their needs or for their, having assessed, obviously, risk benefits. And it is always a shared medical decision between physician and patient and couple in general. We need to refer to a mental health professional. Why? Because that will help them deal with the psychological burden of an affected sexual relationship potentially, but also boost treatment adherence. And lifestyle modification is very important on this patient. As I mentioned, a lot of people are smokers or are diabetic or hypertensive, obese. So the moment the patient, tries and have a better lifestyle, healthier diet, exercises more, that sense of well-being might also translate to an improvement in his erectile dysfunction. Oral medications, FDA has approved oral phosphodiesterase type 5 inhibitors, as we all know. It's very important we discuss risk benefits with the patient. We need to give instruction on how to maximize the benefits, and we titrate the dosage. We start with low and we go up as needed. It is important to know that if people take nitrates, they shouldn't be taking these medications. And these medications can cause an abrupt drop of blood pressure. So the people need to know what to look for and advise people, for example, if they have nitroglycerin, not to take it within 24 hours if they had taken one of these medications. If we have a patient with erectile dysfunction, we prescribe this, but they also have low testosterone. Those patients, we can add some testosterone. There are some other treatments such as the vacuum erection devices, intraurethral alprostazole, and intracavernosal injections that are left mostly for the urologist, I guess. As a gynecologist, I don't think that we will be going into those treatments as much. And also, ultimately, a urologist can perform a penile prosthesis implantation. Again, risk benefits need to be discussed. This should be viewed as a permanent surgical procedure, and patient needs to understand that, needs to know of post-operative expectations, but also complications, and always keep in mind that it should not be performed in patients that have any acute or active urinary tract infection. And with this slide, I will conclude. I think this is the last presentation. Thank you very much, everybody who stayed late for my presentation, and always a pleasure to present. Thank you.
Thank you very much, Doc. Can you just quickly tell us, is there any correlation between ED and male who use supplements, especially the bodybuilding supplements or the energy boosters?
Yes, it could be, and we've seen it clinically in a lot of those patients, not only having impaired spermatogenesis, but also erectile dysfunction. Yes, indeed. And also, I know widespread use, which is a social thing, because also bodybuilding, it is a social, trend. It's the same thing with use of pornography. Similarly, I think the lifestyle and the social trends have contributed to increased erectile dysfunction in the male population. But yes, indeed.
Thank you.
Thank you so much, Dr. Panayota, for joining us and presenting this wonderful topic. And now, on behalf of Merck Foundation, I would like to conclude this wonderful session with a vote of thanks to all our speakers, panelists, and attendees for joining us today and making this knowledgeable session a huge success. We look forward to meeting you all soon again for more knowledge sharing and great learning opportunities.